Welcome, everybody. We can, or you want to finish this? Welcome to Colorado, sunny Colorado, on the 19th Rocky Mountain Interventional Endoscopy course. We have an incredible lineup of cases and faculty, patients that have agreed to participate in the conference. And, a conference of this magnitude cannot be done without really not a small village, a big village, that includes folks on the nursing side, led by our nurse manager, Taryn Hardesty, and assistant nurse manager, Shelby Evans. We have all the nurses within the rooms and technicians that assist in these procedures to help our faculty run seamlessly. And also the hospital support to be able to have the hands-on stations that some of the fellows enjoyed yesterday within our lab. The School of Medicine support to have a venue such as this, and to allow the support from our AV group, Proximy, who is an external company that we transmit with, and of course our administrative staff, especially Christy Click. Without you, we would not be here today for sure. And so, when I thought about this morning at around 3:30 in the morning, about where we are, it was almost 25 years ago that the tragic events of 9/11 occurred, and it led to a war on terror. And unfortunately, that's continued, and it's become a bit of a war domestically, actually. There was a pandemic war. During the pandemic, there was a war on a virus, and now there's a war against public health. And there's a war on education, on science, the environment, the diversity of peoples and ideas. Gun violence is a public and mental health crisis. It's not being addressed. We lack much needed wars on poverty, protect human rights. We lack wars for ending safety, food and shelter insecurities. One may say that our priorities as a country are upside down. So why do I bring this up? Because I think medical conferences where we're able to freely exchange thought and experiences, combine faculty experiences that are not just in a vacuum. They practice at major medical centers with other respected colleagues. They learn from each other, they challenge each other. And really, this type of medical conference is a safe haven. It provides objective, evidence-based opinions, a wealth of expert experience, and all of this allows us to improve and enrich our practice. So we are here to expand our knowledge base and skill sets, all to provide the best care that we can possibly deliver to our patients. It's not hyperbole, it's not far-fetched, it's our reality. And a conference of this magnitude would not be remotely possible without a generous partnership with our industry allies. It has been and it remains an essential and cherished aspect for us to bring a conference. I'm speaking also on behalf of my course co-directors, Dr. Wani and Dr. Deloy, who are busy getting all our cases prepared this morning. And to get us set off on that tone, I would like to introduce our first speaker. And our first speaker is Dr. Doug Rex, who is professor of medicine at Indiana University. And a little short story I'm going to tell you about Doug, because when I was a fellow at the University of Cincinnati, Doug Rex came from IU, and he actually had done some type of a judging for an award competition for Ohio GI Fellows research presentations, and I was one of the few, fortunately, that was able to present our data on the usefulness of colonoscopy for unexplained diarrhea. Can you believe that? It was something my first real article I published. And Doug asked me a question, and I was very intimidated, and I remain intimidated by Doug, but he asked me a question of, well, Raj, if you have a normal terminal ileum, should you biopsy that? And I'm just like, well, yeah, I think so. But I'd like to answer that a little better today. I think I don't treat or see IBD, but my sense is that if you're worried about quiescent Crohn's disease, you biopsy it. But if it's otherwise normal, don't biopsy it. Is that the right answer?
I think it's pretty much always a waste of time.
So again, I failed the answer. Doug, thank you so much.
Thank you, Raj. Good morning, everyone. Congratulations to the course directors and to the University of Colorado for this wonderful course. We're going to start off by giving an overview of colorectal polyp resection. I'll talk about an overview of the approach, a couple of comments about the use of hot and cold forceps, and then cold versus hot snare resection, and finish up with some comments about special techniques. So here's an overview of the current approach. Everything now 10 millimeters and smaller can and should be removed with a cold snare. This includes pedunculated lesions. I would say that extends to 1 to 3 millimeter polyps. If you're using cold forceps for tiny polyps, I would encourage you to move away from that. All of the SSLs and HPs, regardless of their size, can be removed by cold resection with or without injection. The possible exception is when there's a significant area of dysplasia. Adenomas 11 to 19 millimeters. Here is an area where we have mixed evidence and less evidence, so variable approaches can be used. And then for the adenomas 20 millimeters and larger, the lateral spreading lesions, we have hot and cold EMR. And here we have a clear trade-off. If we're going to resect these cold, we're going to have a higher recurrence rate, more safety, but a higher recurrence rate. So we need to think about whether any of those lesions are acceptable when we know that this recurrence rate is higher. Hot forceps, no role now in the resection of small or diminutive polyps. If you have a complication with hot forceps, you're going to have medical legal liability if you do that with a small polyp. There still is a role for them for avulsion of flat or fibrotic tissue during EMR that you can't get a hold of with a snare. You can also do that with cold forceps. Cold forceps, the evidence suggests that they're effective for 1 to 3 millimeter polyps, but you shouldn't use them for polyps that are bigger than that because they're less effective. You shouldn't piecemeal with them. I consider them often a wasted device. If the patient has 1 to 3 millimeter polyps and 4 to 10 millimeter polyps where you definitely need a snare, you're going to end up using 2 devices and more waste and cost. When we see lesions in the colorectum, we go through this series of questions, some of which we answer instantaneously. The first one is, are we going to use electrocautery? For some bigger lesions, another question is, do we need to resect them en bloc, or would piecemeal be okay? If en bloc is required, what method are we going to use? So hot versus cold, this is a fundamental question. And I think it's important to try to get the right balance. I see people in the community who have moved completely toward the cold revolution because they want to avoid complications, understandably, but there's a set of lesions for which we still need electrocautery, and other people that are still using the old-fashioned approach and using hot snaring for lesions that are under a centimeter. And again, if you have complications now, there's medical legal liability associated with that. The fundamental differences between the two are that cold snaring cuts superficially through the submucosa, and this may be the reason why there's a higher recurrence rate for large lateral spreading adenomas. There's more immediate oozing, but a very low risk of complications. If you do it correctly, there's almost no risk of complications with cold snaring. Hot snaring cuts more deeply through the submucosa. We want that when there's any perceived risk of cancer. But because of that deeper injury, there's a greater risk of delayed bleeding and injury to the muscularis propria, potentially delayed perforation. There's more power for cutting when you have a hot snare. So if you have a bulky lesion, you oftentimes need electrocautery. surgery. And there's increased cost and inconvenience because inefficiency, it just takes time to get things set up. So what are our targets? Well, for cold snaring, as I mentioned, everything 10 millimeters and smaller. The only rare exception would be when you are suspicious of cancer in a lesion that small. SSLs of any size, although the ESGE says that if you see endoscopically a focus of dysplasia, you should remove it with electrocautery. And I oftentimes follow that, especially with a big focus. Flatter adenomas in the 11 to 19 millimeter range. Again, mixed evidence, but I think it's okay in this set of lesions. And then we talked about this trade-off when we get to the larger lesions. Hot snaring, when do we need that? Anytime we have a perceived risk of cancer, there might be cancer in this lesion, we should be using a hot snare. So bulky lesions, whether they're sessile or whether they're pedunculated, harder to predict the presence of cancer based on examination of surface features. Large, thick-stalked pedunculated polyps, lesions that have large nodules in them or depression, and then the rectum. The rectum is an independent predictor of the presence of cancer. So anything that's above 10 millimeters with bulky shape in the rectum, and just most things over 10 millimeters, we should be using electrocautery. If it's difficult to transect, and here we've got overlap, so 1S, large 1P lesions, we need electrocautery. And then if you anticipate fibrosis, usually because somebody has already removed part of the lesion. There are a lot of ways to deal with fibrosis, but cold snares tend to bounce off scar tissue. If you really want to get in the submucosa, I think you can do it better with electrocautery. So when to resect cold. So we all know that we can now evaluate the quality of our resection. The keys to high quality resection of small lesions are that you keep the right working distance, that you move them into the 5 o'clock position, especially if you're in a straight part of the colon, you're not en face to the lesion and it's up between 9 and 12 o'clock, you rotate and then you grab the lesion with a rim of normal mucosa around it. And here's a pedunculated lesion that's small. These can now be removed cold. They tend to bleed a bit more than sessile lesions of similar size. I like to grab them right along the wall, and if you squeeze them for a few seconds and then come through a little bit slowly, there's less bleeding. I would try to avoid clip usage. You're going to need clips more than you would for sessile lesions of this size, but we use them to control immediate bleeding only about 2% of the time for these small pedunculated lesions. Okay, SSLs of virtually any size we can resect cold. A lot of people like to inject them. There is some evidence that you can get them out effectively without injection. The keys to effective resection are the same things that are important for small adenomas. You keep the right working distance, you get into the 5 o'clock position, and then you place the snare accurately. If you're near the edge, you overlap the normal mucosa, and you also overlap the submucosal defect as it develops. And then you want to push the snare in so that the tissue is actually coming up through the snare, so that when you transect, you're going to get into the submucosal plane. We don't want to leave any of the muscularis mucosa or the polyp obviously intact. You can use the water jet some to help you expand the submucosal space. And when we're done, we're seeing all submucosal fibers. And part of the beauty of this is that we don't have to clip it. Even if the patient's going back on DOACs or warfarin, we don't have to clip these to prevent delayed bleeding. Now, this is an adenoma that's maybe 13, 14 millimeters in size, and it's relatively flat. I would view this as a zero risk lesion. You can predict this thing does not have cancer in it with complete certainty, and it can be resected cold, but it's going to have to be resected piecemeal. The technique is get outside the margin, do your first resection, and then move over and overlap the submucosal space and the normal mucosa on the other side. And we found this to be very effective. Probably good technique is important. Okay, electrocautery. I mentioned if you have an SSL with dysplasia, the ESG says to remove it hot. So here is an SSL that has a dysplastic focus. Rather than having the nice 1 pattern, it has the nice 2 pattern. It looks like a conventional adenoma. And I don't think there's really great evidence that we should use electrocautery, but I think the message the ESGE is giving us is that this is more advanced lesion, and we want to be sure that we get it out completely. If there's a large focus of dysplasia, I do use electrocautery, but I don't always for a small focus. And in this case, we're taking out the focus right there without electrocautery, but following the same principles. Overlap the margin, overlap the submucosa, push hard enough on the snare that you're clearly in the submucosa. Large pedunculated lesions. Obviously, we're going to use electrocautery. I don't like to use either loops or clips. If there's cancer in the head of the polyp, about a third of the time it will invade the stalk. I think our priority is to get away from the head, and then we can put a clip on afterwards if we want to. If you use forced coagulation current, you'll almost never see immediate bleeding. So I don't think it's really concern. I see people using endocut for forced coagulation or for large pedunculated polyps, and I don't think that makes sense. And then here is a small bulky lesion. And this also, just for the transection issue, and especially in the rectum, we should use electrocautery. This lesion, this is a non-granular lesion with pseudodepression. This is 2A plus 2C morphology. This is the worst morphology for cancer risk that we see in the colon. This should always be removed with electrocautery. And the cancer risk is high enough that en bloc resection is also important. And then here's the lesion with fibrosis. This has part of the lesion removed by the referring physician along the distal edge. We see this in almost 25% of our referrals. And I actually applaud the referring doctors when they send the patient, because what I don't want them to do is to send this patient to surgery. You can almost always manage fibrosis. I think it's more easily managed with electrocautery. We're going to use avulsion to take this edge off down here, hot avulsion. But I think this is another indication for electrocautery. Okay, so now we go into this group of large non-pedunculated adenomas, the large lateral spreading lesions. We've got 4 randomized controlled trials showing that the risk of recurrence is higher with cold EMR, but the complication rate is lower. No perforations with cold EMR in these 4 studies. So we have this trade-off. Is there ever a set of these lesions that we can still remove by cold EMR? Well, we need to rely here on morphology. So we talk about granular, which means lumpy, bumpy surface, non-granular, smooth, flat surface. And then within these, if there's a nodule in the granular, the risk of cancer goes up. If there's depression in the non-granular, the risk goes up. So here in the upper left is the homogeneous granular lesion. This has a very low risk of cancer, very little submucosal fibrosis. You put a nodule in it, and the risk of cancer goes from 1% or less up to around 5 to 10%. If you have the flat non-granular lesion, the risk of cancer about 5%, but when it's depressions in it, the risk goes up to 30 to 50%. So probably this set of lesions, these 3 over here, we should be using electrocautery, and here the risk of cancer is high enough that we want en bloc resection. Is there a group where we can still use cold EMR sometimes? If it is, it's probably this homogeneous granular LST. And this is an important group because it's the most common large lateral spreading lesion that is seen in clinical practice. So here it is again, it's in the cecum, and we're going to remove it, in this case, with electrocautery. But these are some of the things I would consider. The first thing is, can you close it? Because if you're removing a large lesion proximal to the splenic flexure with electrocautery, you want to be able to close it. So you want to ask yourself before you resect it how you're going to accomplish that. Ask yourself, can the patient tolerate a complication? You don't want an 85-year-old patient in the ICU with a bleed, somebody that many people would ask, should you have removed the lesion even in the first place? Can you tolerate a complication? Are you in a practice environment where people learn about your complications? That happens in smaller communities than it does in the big city. And is the patient likely to follow up? Because the truth is that most of the recurrences after either hot or cold resection are very small and very easy to manage. But the patient has to be the kind of patient who's going to show up. So again, here's our summary of when we would use hot and cold resection. When to use underwater? Well, it's hard for me to talk about it with Ken Benmoller sitting over there because he's the guy who invented underwater resection. And he would say, do it for everything. I think that it has to be part of your armamentarium because there's some lesions where it clearly has an advantage. When you feel you need an en-bloc resection in the 20 up to 30, 35 millimeter size range, you've got a much better shot underwater than you do by injection because injection makes lesions larger to prevent the thinning of non-granular lesions. And then you also can float lesions into position, pedunculated lesions in the sigmoid, things hanging on the cecal lip of the ileocecal valve. You go underwater, and a lot of times they become much more visible and accessible. So this is an elderly patient with a lesion in the right colon, a very poor surgical candidate, not in good shape. You might be able to get this out with the full thickness resection device, but this patient had a bad sigmoid. We took it out underwater. It did have cancer in it. You can tell it's got cancer in it by looking at it, but the overall features were not too unfavorable, just deep submucosal invasion, and we're able to avoid surgery. And then this is the non-granular lesion, flat elevated. These lesions, when you inject them, they become very thin. A lot of times they're actually more difficult to snare than they were if you approach them underwater. So be sure underwater is part of your armamentarium. This is the lesion we saw before. This thing is perfect for the full thickness resection device. It's relatively small, it's flat, it's got a very high probability of cancer in it. And then I think whether you're an ESD zealot or not, I'm not an ESD zealot. There's a set of lesions that we have to have ESD available for. And it's lesions that are in the rectum that are either sessile or have a large nodule in them. They're too big for anything else endoscopically except ESD. So we have to be able to refer for that set of lesions. So this is my conclusions about the current approach, and thank you.
Thank you very much, Doug. That's excellent state of the art for 2025. Dr. Rex needs to head over to the hospital. He's got some cases lined up, and we're going to start with the first case.
Good morning, everybody. It's my pleasure to introduce the first case of the day. We have a demonstration of an esophageal poem. The patient's initials are AL. This is a 69-year-old female with newly diagnosed type 2 achalasia presenting for esophageal poem. High-resolution manometry from March of this year demonstrated and confirmed type 2. The median IRP was 34. Absent peristalsis was noted in 100% of the swallows. There was panesophageal pressurization in more than 20%. An esophagram from a few months ago in June suggested achalasia, and FLIP performed in June of this year demonstrated absent contractility, and the DI was 0.6.
Is this Raj or right?
You can see the manometry study here as well as the upper GI.
I just want to make sure you guys have.
And we'll go right to the case.
Morning, Bilal. Can you hear us?
Yes, I can hear you. Guys, can you hear us?
We can't hear you.
Okay, they can't hear me.
No, now we can. It's wonderful. We hear you great.
Okay.
And
Fantastic.
could I just
Can you hear Dr. Gabbert?
Could I just say one thing, Dr. Bilal? Is we
Please,
have Dr. Isiyama, Dr. Pohl, Dr. Binmoller, Dr. Singla here to guide you to the very best that you can be.
So you think I should stop hearing? We can't hear you now.
We're not saying anything.
All right, can you hear Dr. Gabbert?
Good morning.
Yes, we
You guys hear
can.
me? Okay, that's great.
Okay, fantastic. We're going to introduce our team here. So obviously, we have Dr. Gabbert here visiting us from University of Cincinnati. We have our advanced endoscopy expert nurse, Christy Tronick. We have Amy Martizio here on the back, our second nurse. We have Andrea, who's our expert CRNA. And then we have Dr. Blake Nickham, who was our former advanced fellow and now our esteemed partner. So as you have already seen, this person has type 2 achalasia. Is already confirmed from manometry and esophagogram and endoflip. So in our practice here, we've converted to a tailored short myotomy when the disease is at the lower esophageal sphincter. So, which means that for type 1 and type 2 achalasia, we do about 5 and maximum 6 centimeter total myotomy, including the esophagus as well as the gastric side. And I talked to Dr. Gabber, and it seems like this is his practice to be. So we've already identified our landmarks, and the GE junction is right here. As you can see, it's a little hypertonic, and we've already gone through it, done some cleaning. We're using a Fuji TP scope, which has it's a 7.9 outer diameter with a 3.2 working channel. So we just are trialing this, and this is the first time we're using it for EPOM. We've used it on a couple of GPOMs and a couple of ESDs, and then we're going to be using the T-knife. So I'll talk about it as we go. But Dr. Gabber, any thoughts, and is that your practice as well?
Yeah, that's my practice. So basically, we cannot transition to this shorter myotomy, so 3 centimeters above the GE junction and 2 centimeters on the gastric side. So total is 5 centimeters. As we can see here, Dr. Bilal is starting with the injection. He's creating his bleb with the injection needle, and then we're transitioning to the knife. We're going to be using here the hybrid T knife. That's the RB knife. That also has injection capability, so we'll be relying on that for further injection as we go down after the incision.
And we're doing a posterior POEM here, which is typically our practice here at the University of Colorado. Is that what you do, Dr. Gabber, or about the panel?
That's my practice as well. Does anyone on the panel have any opinions about anterior versus posterior? So long, of course, as it's doable. I mean, if you have a patient who had like Hillers in the past, we're gonna do posterior. But if it's patient like this, treatment naive, any opinions on anterior versus posterior?
The right knife.
Hi, this is Ken, and I think the only time you got to think about going anterior is if the patient's post-Heller, but otherwise really doesn't matter, right? Whatever you think. For me, I don't even look whether it's posterior or where exactly. I just want to be sure that I can, as I advance my scope, I'm going to have good contact with the wall of the esophagus, because sometimes it's very tortuous, right? So when it's very tortuous, this looks pretty straight, but when it's very tortuous, dilated, that's where you're going to be a little bit more picky in terms of where you go. I just want to ask a question now. I saw you injected, but do you really need to do that first with an extra injection catheter? Couldn't you just do that with the hybrid knife there?
Yeah, that's a really good point, Dr. Ben Muller. We sometimes will, for ESDs, I will do that. For POEM, I still like a little initial injection, but you're right, you could go both ways. Needle out, knife out, a little back.
I would comment on that too as well. So as you said, Dr. Ben Muller, we can definitely inject with this knife. It will require basically a short, quick tap on the knife at the mucosal side, and then once we inject, it should go through. But what I've found is that in rare cases, if you have like a sudden like contraction from the esophagus, and then that knife goes deeper than what you want, and you feel bad about it, that initial bleb with the needle just kind of takes an extra minute or a couple of minutes, and it kind of makes us avoid that issue if the knife goes deeper than what's intended to. But it's absolutely a reasonable practice to just use the knife and skip the needle part completely.
Yeah, maybe when you're starting, do the injection, and as you become more comfortable and have a better feel for the submucosal space, because I will admit, when I started doing POEM in the very beginning, it can be very deceptive. What's the muscularis mucosa and what's the muscularis propria, right? So you can think, oh my God, this is the MP, but it's actually the muscularis mucosa. It can be very thick sometimes. So I have another question. So it looks like this is the Legacy hybrid knife that you're using. Is that right? Not the Flex?
Not the Flex, yeah.
Yeah,
It
we
is the
use the
Flex?
Flex knife for the ESD. No, this is the hybrid T-type knife. And
The
for
Legacy,
POEM,
right? The original.
That's right. Yes. We use the Flex for ESDs, but for POMs, we still use
So there's the
T-type.
T and the I. Why this one? What? Just explain the reason for choosing this one.
Yeah, I think that's a great question. I think, as you said, like a lot of people have different, inject please, different practices for using these different types of knives. We like the T-type knife because it allows us to hook a little bit better in the when I'm doing the myotomy, because I do my whole procedure with the same knife. So it allows a little bit better. But there have been times when we're out of it. We've also used the I-type knife. I think you can certainly do either or, but that's why I do it. What is your preference, Dr. Gabber?
It's the same thing. So to clarify to our audience, for those who are not familiar with the different types, so with the hybrid knife, the Legacy, we have the I and the T, and the difference between them is the I is basically like a needle knife, and the T is the one that has this non-insulated disc at the tip of the knife. So the advantage of having that disc at the tip of the knife is that you can use it to kind of hook around fibers, and it also kind of increases that surface area that you're using for dissection. The Flex knife is a slimmer knife, which, as Bilal said, is kind of, in my practice too, it's a better knife for ESD where you need more precision. In POM, you really are inside the tunnel. I don't feel that you need that much precision of a slimmer knife. And the bigger knife is more efficient in the process as we dissect faster. And really also it works better on large vessels when we sometimes use the side of the knife to sclitonize the vessels before we cut through them. I found that the thicker knife, like the Legacy knife, is much better when it comes to that.
So we're using this TP scope, and like I said, it's the first time we're using it for an esophageal POM. And you saw the tunnel entry was really easy. What we're having a little problem is with this cap orientation, because I think it hits the tip of the knife when you come in and out. So knife out.
And this is a standard cap? Standard cap?
This is Dr. Ben Moore, this is the TP Fuji scope. So this is a 7.9 working outer diameter and a 3.2 working diameter.
No, I think that's fantastic. I mean, you have larger diameters, working channel and slimmer diameter shaft, but I'm talking about the cap. Is this a standard straight cap or is this the ST hood?
This is a tapered. Oh yeah, this is a tapered cap. It's ST hood for the which is designed for this smaller scope, smaller diameter scope. I think it looks like it just keeps getting stuck a little bit when the knife comes out. So inject. So here what you can see is we're starting our tunnel, and because it's such a small scope, we were able to get in really easily. So now you'll see that sometimes I'll intentionally just nick the muscle just a little bit, because this is really, with esophageal POM, as we all know, our guiding light, opposite to ESD, where you try to stay closer to the mucosa. Here we're going to try to stay as close to the muscle as possible. Try to keep kind of hub it, and then just follow it all the way down. One full injection.
Can I ask a question about endoscope selection also? We have a new unit and we're primarily Olympus right now, although leaning towards Fuji in the future. What is the panel, or what do experts use for an esophageal POM? Is it standard Olympus, or is there variability?
So I will comment. I use the standard. We have Olympus, and I just want to make sure it's the Q scope that has near focus. Yeah, because I do mine, of course, underwater.
We have converted to almost underwater EMR, but we're still not fully converted to underwater POM, Dr. Ben Muller. So.
Yeah, what I hate about when using gas, and there's not a compelling reason to use underwater. That's why I haven't really been a vocal advocate of it. It's just my preference, just from the optics. But, I hate smoke that, clouds my view. I hate it when I have to pull the scope out and clean the lens. I also hate that cellophane look when you're giving gas and it looks all cellophane-like. So I just feel that underwater, I just get this beautiful 3D view of the anatomy. And then the vessels literally just float in front of me so that I can preemptively coagulate them ahead of time. If I can just make a comment though about T versus eye knife. So I think the advantage of the T is when you're doing the myotomy because you can hook the muscle
Right,
better
exactly.
with the T end. Yeah. So when you're pulling back or when you're pushing, it's really pulling back, I think, where you can hook and just pull back. So that might be an advantage, but I think a drawback of the T, because I started with the T, a long time ago, but that's how I started. And then I had cases where I had mucosal blanching. So the transmission of the diathermia, that's because that tip is a little broader, that disc, and it transmits to the mucosal surface. And the one thing you must avoid is getting transmission to the mucosal end. And that's why you're erring on the side of cutting into the MP. But just be careful when you do this because what causes, I mean, really frustrating bleeding is when you have these blood vessels that you cut into at the MP and they're like rubber bands and they just retract into the MP and they start bleeding and you can never get at them because they're below the surface then. So that's why I personally always stay in the middle lane, like the highway. So I want to be above the MP and below the mucosa, but stay in that middle lane if possible and not cause any thermal injury to the MP.
And then, that's a great point, Dr. Bimler. What we do is we have also switched to an ultra low flow, carbon dioxide. And the moment we get into the tunnel, and our team is excellent about it. We all verify this. This is part of our timeout process as well. Check. And then obviously we're watching the peak airway pressures and intermittently, feeling for either crepitus or pneumoperitoneum, just as a practice, even though we know that some degree of crepitus sometimes occurs. But I will say that ever since we have switching to the ultra low flow CO2 processor, it's an extremely rare event in esophageal poem.
Bilal, we're going to transition to the
Okay, sounds good. We're going to keep working on the tunnel.
next case. You keep working, and we'll get back to you here shortly.
Okay,
Can we go to the next case presentation, please?
All right, we're going to switch to a different case. This is an ERCP with patient initials SG. This is a 74-year-old female with metastatic cholangiocarcinoma diagnosed in February of this year, currently on chemo and immunotherapy, complicated by malignant biliary obstructions with multiple ERCPs, also complicated with acute cholecystitis and a pericoli in April of this year. Their last ERCP was 2 months ago. There was a bismuth 2 stricture measuring approximately 9 millimeters. This was dilated with a 6 millimeter balloon. A 10 by 17 plastic wedge stent was placed into the right, and a 10 by 20 plastic stent was placed into the left. You can see the labs that we have most recently showed an ALK phos of 229. The other liver enzymes were normal. So is this the gram from last time, I would presume? And you, okay, so we'll skip to the plan. I think they're going to have some updated fluoro for us. So we'll go ahead to you guys.
How are you guys?
Sham, can you hear us?
Yes, I can hear you. Can you hear me
Tucker's
okay, Raj?
there. We can hear you great.
Wonderful,
We got an
wonderful.
excellent moderator team here.
Okay, yes, I got Alan over my shoulder here, so I think we're going to be in really good shape. And I've got the lovely Summer from your team. She's fantastic. I've actually already offered her a contract, Raj. Please don't, please don't be upset.
Unfortunately, it's Morgantown, so we're okay.
And then we got Lindsay.
Just kidding. I'm an Ohio boy. I can say that.
And then we got Lindsay in the background. So we've done a little bit of work before you've come here. Can you see our fluoro images?
Yeah, we can see fluoro, you, Alan, Summer, and the endoscopic view.
Okay, great. So what we have here is we've had prior plastic stents and we've gone ahead and placed them. We have not obtained our cholangiogram as yet. However, while this patient has a percutaneous drain in place, and it's been really an issue for her quality of life. And her cystic duct has been obstructed from the tumor. But what we opted to do was to see if we could get a wire across, and we were able to get an 025 Vizia across. And then from that, we weren't really able to push a catheter, but now we've got a 345 catheter across. So we're going to try and see before we shoot our cholangiogram if we can reasonably get the cystic duct opened up enough that we could place a double pigtail stent and potentially get her a percutaneous drain out. And then we'll work on the biliary tree for her hilar stricture. So if you'd be patient to wait for us to get a cholangiogram, I'd like to try and see if we can get a wire into that, or get a good sense of what we can do with the gallbladder first.
And what was your trick to get into the, so you do have a skinny catheter in there right now, or?
I do. You know, what we did was we didn't want to shoot a cholangiogram initially because we want to be very deliberate with our injection, as you talk about so frequently, and I think it's a great teaching point that you have put forth so many times. So what we did really was just kind of played around with the wire, and we could see there was a point in the mid CBD that it was actually buckling a little bit. So we just drove our balloon catheter up, and we didn't expect to have success as we were messing around there for a few minutes. But then suddenly I could feel that that was probably the site. So gave a little wisp of dye, and from that I traced it with the wire, and we were able to get that wire into the gallbladder. So now we're going to take an 021. We can go with the straight 021 wire through this 543 catheter that we have in place. And if you can see the spot film I've obtained, you can see this gallbladder is packed full of stones. And so, Alan, I think this is kind of the case where doing a transmural gallbladder drainage is not a good idea. Yeah. Any thoughts from you?
Yeah, so I just want to mention, just for the audience, that the first part we were looking at was when we had the plastic stents in place. Do you just pull the stents, or do you put guide wires through so that you keep your position in the hepatics, both on the right and the left side? Because then it may be a problem going back in. And we elected to go ahead and remove the stents over the guide wires. That's the first thing that was done.
Keep going.
Then the next level was because of this percutaneous cholecystostomy that was in place. We said, while we were waiting to come on, is there any way that maybe we could go ahead and access the gallbladder to be able to hopefully go ahead and drain the gallbladder? And so that's what we're working on right now. And the algorithm is going to change, because if we are able indeed to drain the gallbladder, then it'll be plastic stents that will go back in and view our RFA. If we cannot manage to successfully drain the gallbladder, then we may decide rather to put in some fully uncovered metal stents on both sides. So because there'll be no RFA in that context. So people have to follow the decision process. That'll be different depending on the success of draining the gallbladder or not. And that's what we're working on right now. Sean.
And
So
Sean, did you encounter any stricture in the cystic duct, or did that catheter go pretty simply? It looks like maybe a 5 French.
Yes, this is a 543. I got a lot of resistance. I could not push the balloon. I tried a 39. I could not push that. Then I ultimately pushed a 543 over the 025. So you can squeeze one through. I actually learned that recently. You can squeeze one through over an 025 wire. I learned that from Todd Barron, and he's right. And so we did that, and then once I got this in, and we shot some dye, and we got that cholecystogram, as you can see. And now Summer has just, worked the wire so well that she actually sent it down through the tract, as you can probably see there. So what do you think about that, Rod? Do you think we should try and send it out the track and use that as a counter?
Yeah, I think that's fine to do it. And I'm curious, Professor Isayama, your experience with this, with gallbladder stenting, what size? Do you think it helps?
Yeah, gallbladder stenting, the long-term outcome is not so good. So then I prefer the ES-guided drainage for the such kind of situation. But if we perform the transpapillary stenting, we will use a 7 French, the double pigtail. It is easier to pass the cystic duct area.
But I will say that after a cholecystostomy tube is in place, the transmural drainage, EOS-guided cholecystoduodenostomy, can be technically challenging because the gallbladder is contracted. In this case, also it's packed with stones, and so it becomes a much riskier procedure. And there's a much higher risk of leak and perforation. These stones have been in there a long time. So I really want to commend you for thinking about not just going by reflex to, oh, well, let's just drain this EOS guided because we can do it with the lambs, but thinking, well, what's the underlying problem? And it's really the cystic duct obstruction. And I think that if you can achieve this transpapillary, that is the ideal solution here.
Can I ask a
no,
question?
Thank you, Ken. I agree with that as well. I'm a little worried about this 021 wire, but I'm going to try and drive a 4 millimeter hurricane balloon to see if I can open up this cystic duct a little bit, and then that should.
But can you
really
get
help.
that wire to go out of the percutaneous tract?
That's what I was thinking to try and do.
Because
and
then,
didn't
I mean,
wanna
then
get
you got
too
a
crazy.
closed circuit,
Countertraction,
right?
yes.
And then
Yes,
it'll be
yes,
very
yes.
easy to push a stent
Yes.
over.
Or easier.
Yes.
Yeah.
Easier. I don't want to say very easy. But
No, I think if you
so
can
we'll
give
go
that
down into-
traction the whole time, it'll
Yes.
go.
Yeah, so let's go down first with the hurricane and see what we can do with that. So while we're at this, I guess, we've talked about a little bit about, gallbladder drainage options. And here you can see, we'll just try and push. And so this is a short system, so I'm just going to try and hold traction with my locking device. But as you can see, it's just a very tight stricture here.
And for the fellows in the audience, you can see the 4x4 balloon. That's what I would do next also. It buckles a lot. It's such a flimsy device. And what's nice right now is they haven't used the 4x4 yet, so it's as stiff as it's going to be. But if you use that for an actual dilation and then try to use it to traverse a stricture, it's almost never going to work. So I agree with this as the next step.
It's a hurricane?
Yes, it's a hurricane.
Sometimes
Which I tend to like because it tends to be a little stiffer. But this is very tight. Like I said, I could not push a 39 through it.
even a
And,
short wire system, you can still use long wire technique. So another thing to consider is ask Summer to do a little bit of back tension on the wire, unlock the wire, give a little bit of back tension on the wire, and sometimes that can be helpful, which is a old school kind of long wire technique. Apologize for those who still use long wire, but it is a little old school, but that's okay. And so sometimes this can help you get across the stricture too.
Go ahead and take that. Let me fix
And
my
then
wire.
negative pressure on the gun to help and reduce pressure. Sometimes there can be just a touch of air that gets into the collapsed balloon. Also, you can mag up the fluoro. I think Tom is in there. He can mag that up for you.
Yeah, Tom, do you want to go ahead and mag it? Yeah, give me some back tension, please. Yeah, a little more, a little more, a little more. So, not really getting any progress there. It's just buckling on me. Yeah, one thing we can try is, I might go back with that 345 and see if we can just send that wire a little deeper right through the channel and see if we can get it as a traction and then, use that as Ken suggested to get a double pigtail.
I would, before you exchange, before you do that, I would consider dilating where you are. It's surprising. Sometimes you can't get this balloon across, but you dilate just the lower aspect of the stricture, and then some other intervention, then you go back and you can get across. Maybe it's just luck, but I think that sometimes helps.
Actually, I'm just sending the wire as we speak. You want to see percutaneously if you guys can see the wire at all?
Can you see?
Let's go ahead and do a quick dilation.
And there are other tools in the toolbox. I've used a 7 French retriever. You just have to be careful what kind of wire you're passing that over because it does tend to strip the coating. So if it's a VisiGlide, it'll work fine. So yeah, that might be an option. I don't know, maybe in Japan they have that tonus. I don't know if they've got one.
But I heard so Tonus had approval in the USA.
We have it. We have it.
Can you push
Yes.
You have to be very, very careful using it in the
Yeah,
pancreatic duct.
but I think that it is also very helpful in this case, I think.
Can you guys explain that device for a moment? What is that?
Yeah, so basically it's like a screw. It's a threaded tip and, you're just rotating.
So
When Nib Sandra developed the retriever, it was designed to screw into the end of a plastic stent, obviously a straight one, and then over the wire, you could pull that stent out, leaving the wire in place, and then put your new stent in. So it was originally designed just to enable or facilitate the exchange of a plastic stent over the wire. But then we discovered it was very useful to
Yeah, it's
dilate
almost
these refractory strictures,
Good, take the
like in the bile duct or PD, and you just keep rotating and it drills over the wire. It drills a passageway across the stricture. So the 7 French actually works pretty well. I've used it many times for that. The only issue has been the stripping. So if you use like, you know, a conventional .035, it can strip the coating.
Yeah, it's not.
So I agree. So the in the thrombus dilator is very good. There is a very tortuous area. If we have a tortuous area, thrombus can pass through such kind of the area. But user Sahendra dilator
If you want to push the
cannot
wire, I
pass.
think
I
we're
think.
almost at the percutaneous, if that can help. We're almost at the skin level.
Okay, so you know, at this point we've got almost the wire out. We're going to go back with the 345. I'm going to keep pushing the wire. I did dilate that lower part of the stricture, but despite that, really couldn't get any further. So, or of the cystic duct there, I should say.
I just wanted to mention, because this is what we face when we're doing HGS, right? Hepatical gastrostomies. So we get in with a 543, and then you can't get in maybe with the Hurricane with 4 millimeters. So the intermediate step would be to use a stiff ERCP catheter. And for example, I use the glow tip from Cook, but I think, you know, I mean, all the companies have stiffer ERCP. So you can try something in between the 543, which is very flimsy, and, you know, it doesn't have a very stable platform with a standard ERCP catheter.
That's a great point. Perhaps maybe we should try a 457 dilator now, because actually these guys have gotten the wire. We've got the wire out of the tract.
Yeah,
So
maybe
I think with
even
some
a 4 to
countertraction, we
6.
might be able to push it.
Maybe.
We have a 4 to 6
have a 4 to 6
Sahendra
graduated
dilator, and you
dilator?
can float the
Okay, let's
short
try.
wire. The other thing is that we're going to let you keep working on dilating that, and
Okay.
we're going to go to the next room, and we'll come back to you in a
Wonderful.
minute.
Okay.
All right, thank you.
Goodbye.
All right, we're going to move to our third case. This is an EGD with a patient, TH, 60-year-old Caucasian male with a history of prior tobacco use, longstanding GERD on BID PPI, non-dysplastic Barrett's in surveillance for 5 years, and now with high-grade dysplasia, no family history of Barrett's or esophageal cancer.
Had you said yes, I would have thought less of you.
So an outside EGD from June of this year revealed 4 centimeters of Barrett's, no documented visible lesions. Biopsies were obtained per Seattle protocol and revealed at 32 centimeters high-grade dysplasia, actually at 32, 34, and 36. And the point is made that the path was also sent over here for review. So the plan today is resection versus RFA for Barrett's with dysplasia.
Put some mineral oil and stuff.
Hi, Jen, you're live. Can you hear us?
Hi, everyone.
We see your endoscopic view. We see you and Dr. Pokola as well.
Fantastic. Thank you so much for having us. So this is a patient of Dr. Sachin Wani's, who obviously did great work in how we manage, diagnose, and treat Barrett's esophagus. So this is a gentleman who has had multiple EGDs now and multiple multifocal high-grade dysplasia on outside pathology. So here we're doing an examination using the Fujifilm Zoom gastroscope. And so one of the things that has been well published is the utility of a very good examination under both high definition white light imaging as well as virtual chromoendoscopy. So here we're using BLI in order to take a good look at the Barrett's esophagus to evaluate our suspicion is if there's a possible raised lesion because of the multifocal high-grade dysplasia. So here what we're doing is taking a really close look at all the Barrett's. I'm going to use some underwater and cap attachment. And this is the zoom scope. And what we're looking for is any kind of vascular disarray or glandular disarray. And you can see that with the zoom scope here, you can almost see individual red blood cells kind of going through the tissue. And so as we take a good look, we see some areas of inflammation. We see some areas where there's a little bit of distortion of the vessels. Can you all see this?
Yes.
I can't hear them at all.
They can hear.
And so here we see that the glands actually look pretty homogeneous, but as we start to turn to the left here,
What about going to
we
India?
see some glandular disarray. Can you, I don't know if you can tell, but you can see individual red blood cells kind of flowing through, and you can see that the vessels here are just not as organized as they were previously when I was scoping to the right there. Can you all appreciate that? And so from this visualization, we can definitely see that there's areas of dysplasia here, right? The glands are the vessels are disorganized. So now I'm going to take us off Zoom. I'm going to suction all this water. I'm going to see if there's any sort of raised lesion that we can see. So here, if we look at the landmarks, we can see that the pinch kind of comes in around here. Top of the fold comes in around here, which is around a 3-centimeter hiatal hernia. The circumferential area of the Barrett's kind of starts and stops where the top of the gastric folds are, and the most proximal extent of the Barrett's comes up around 4 centimeters proximal, so making this around C0M4 with a 3-centimeter hiatal hernia. Now, when we take a closer look, and we've done an exam now for quite a while, we see this area here that is a little bit more slightly raised than the rest, right in this area here. Everywhere else from kind of from the zoomed out view looks pretty flat.
Hi, this is Ken. I have a question. I'm a big fan of acetic acid. Do you ever use the acetic acid?
So I used to use it, but now that we have such great virtual chromo, I've switched now more to just using kind of our virtual chromo endoscopy. Do you still, when do
So
you use
I
the
don't
acetic
use it for the
acid?
chromo effect. I use it to look actually for areas of bleeding. So before I start scraping with my cap there, that can cause some bleeding, I'll just
Yeah.
shoot some acetic acid down, and I want to look for areas where I see some spontaneous bleeding or some red areas. And that literally is like the red flag telling you this is high-grade dysplasia or invasive potentially.
Yeah. That's great.
But then I'll
Does
do, of course, the exam.
Yeah.
Heiko is going to comment on this.
No, I like the idea of acetic acid. When I still worked in Berlin, this was like a normal thing to do using
Yeah.
acetic acid.
Yeah.
So I tried something recently at our hospital, and you have to use medically approved acid, acetic acid, which is a 1-liter bottle, and you can only use it once. So once you open it, you have to dispose of the rest of it. So I'm curious how you managed it, whether you take your vinegar from home and just squirt it down, or because, it's just.
We still get it under the radar as we do our PAM, right?
Salad dressing, exactly
Yeah.
right. Yeah. But I wanted to comment, and I really think it's great and a very important point how you examine the Barrett segment. And I cannot stress it enough to our fellows to do a very slow and deliberate exam of the Barrett segment. And I see you use a cap. So I always use a cap for examine the Barrett's esophagus because you can really keep the mucosa still and examine everything like point by point or detail area by area. You got to be careful not to scrape on that and not make it bloody. So I work in 2 hospitals. In one hospital, we actually have the Olympus scopes, and I really love the near focus situation. So it's always near focus. In the other hospital, we have Fuji, and except for the zoom scope, I think the resolution is not as great as with the Olympus near focus. So I really like the Olympus version. But like pointing out, you got to really examine every area of the Barrett segment in slow motion and look for irregularities in the mucosa. And you pointed out well where the irregularities are. The examination time in the Barrett's is like the withdrawal time in the colon. So you just come back like 3-4 times back and forth in the Barrett segment, and then you can see everything. So
yeah, and there's good data to suggest that you're supposed to spend 1 minute per 1 centimeter, right, of Barrett's. I think Sachin was part of the authors that described a high quality Barrett's examination. But what we know is the risk of post endoscopy esophageal neoplasia can happen. And the risk for that is mostly related to the inconsistencies of an examination. So thank you for your comments there, but I agree that taking really good time to look at every single centimeter, taking really targeted biopsies when you're doing the initial evaluation for the Barrett's esophagus is key.
Dr.
The
Fan,
question I have for the, yes.
no, I don't want to interrupt you. Go ahead.
So we have a little bit of a raised lesion here, and this patient's coming from far. So what we discussed was resecting this raised lesion here and then ablating the rest. And typically we would do those in different sections, but given that the patient's coming from far, we're electing to likely do both therapies at the same time.
Thank you, Dr. Fan. This is an excellent review of advanced imaging and the benefits of quality endoscopic inspection, because this was billed to us as all flat, high-grade dysplasia. As you get the resection plan set up, we're going to move to room 16 with Dr. Bilal, and then come back to you.
Thank you. Great.
Dr. Bilal, we have you here live. We can see you. I hear you got something interesting going on. Can you hear us? Ken, we lost the preview image. Ken. We lost the preview image, Ken. Dr. Bilal, can you hear us? Well, can you give us a thumbs up if you can hear us? All right. Well, we have Dr. Benmuller here that can probably talk us through this, but if you want to proceed, we have about 2 minutes to show all of this. Obviously, you don't need to get this done in 2 minutes, but we're going to then go to AIG. So please, sorry we can't hear you just yet.
So I can't tell whether he started the myotomy. I believe
I
he
think he's just about
has,
to.
and
Can you hear
if
me
he
now?
has, then he's going proximal to distal. I personally like to go distal proximal, but it's just because you can really hook well and just sort of pull your skull back. But you can also do it proximal to distal.
Bilal, can you hear us now?
I
You
can
got
hear you.
us?
Can you hear me?
All right. Yeah, we can hear you now. Great.
Okay, perfect. So yeah, so we finished our tunnel and we're ready for the myotomy. So I just want to show you guys the tunnel. I know Dr. Ben Muller was saying he goes distal to proximal. I go proximal to distal. Dr. Geber, is that your practice
Do
as well?
proximal to distal as well, but there is
So,
no strong
right.
preference
I mean,
there.
the goal is to make sure that we do an adequate myotomy. So here you'll see in the tunnel that we have, this is our high pressure zone. You can see this is the G junction, or where the highest pressure zone is. And then once we go beyond it, we're actually in the cardia. And right here, this is our gastric cardia. And we've confirmed it I know we're short on time, so we've already confirmed it from outside the tunnel to make sure that we're in the cardia, and also our numbers on the scope from the incisors match up to make sure. So like I said, in our practice is to do a tailored short myotomy. So we're going to start at 3 centimeter from the LES, or the high pressure zone, which we decided was around 35, so it's around here somewhere. And we'll start with a selective circular myotomy. So knife out, please. So typically, like Dr. Ben Muller said, there's multiple ways to do that. But I think that if above the LES, I try to preserve the longitudinal muscle fibers as much as I can. So we'll start right around here. And then you'll see we'll make a little initial incision and then try to expose some of the circular muscle fibers. And then once we've looked at that, we'll go to the evaluate that. So you'll see here the more circular fibers are still there. And this is where Dr. Ben Muller's approach of underwater really can give you a really nice view of doing this. So once we're here I'll show you the scope also has this ACI mode, which really highlights vascularity. So I really found it helpful to be in ESD, but I just wanted to show you this mode. And we'll dissect a little bit of these circular fibers.
Bilal, can you say something about the electric cautery setting for both the tunneling and the cutting?
You wanna? Yeah, so for the tunneling, I use this mode on we have the RBVO3 generator, and the mode we use is called the precise sect, and find it really efficient for coagulation. It's sort of a smart sort of a mode. So here you can see the longitudinal fibers coming into view, and this is where I've learned this actually from Dr. Ben Muller. The underwater view really helps me identify them, and then I can just use that as my guiding source. So here I'll tap these circular fibers, and then for the myotomy, I go back and forth between the precise sect and the endocut mode. If I see a lot of vascularity, especially as I get closer to the G junction, sometimes I'll use a precise sect mode. But typically for the myotomy, I use endocut. What is your practice, Dr. Gabber?
It's exactly the same. Myotomy is typically endocut. If there are any vessels, I try to kind of coagulate them separately, target these vessels and coagulate them. And also at the end of the myotomy, after we're done, want to make sure there are no oozing vessels because we're going to close the tunnels. Want to make sure there is no chance for any delayed bleeding. But myotomy is endocut, and then for the dissection, we use precise sect now with the new machine. Before the VO3, when it was the 300, I used to use a spray coag, and that was a very efficient current also.
And you can see as we're getting close to the high pressure zone, the circular muscles are getting more and more thick. We're really nicely be able to preserve our longitudinal muscle fibers. And obviously you have to be careful of the LES for those starting out because the mucosa is too close. So sometimes, in this case, I haven't needed to yet, but sometimes I'll inject the mucosa or just do it completely underwater.
Or another option
Dr.
is to
Bilal,
go
we're going to,
distal
Yep,
to
exactly.
proximal.
Which is what we're going to do now. So this is the distal to proximal at the G junction. I find this to be a little helpful approach. But the key is to really just go slow. Slow is fast, I feel like, in esophageal poem.
we have a question from the audience.
Yeah.
Professor Messman.
A question to Ken Binmiller. Ken, I know you really like underwater, and me too, but is there an increased risk of fluid collection which increases the risk for infection if you use this in the tunnel? I mean, we see pneumomediastinum and so on. So do you have experience with infections after using underwater in the tunnel?
Yeah, so we're 80% water. So firstly, it's quite natural to have water sailing in that space. But no, I haven't. I mean, of course, these patients are on antibiotics. You just have to make sure it's all about the pressure differential. And so I think the only time you're going to run into that as potentially an issue is if you're using underwater and you need to switch to gas to be able to see, like if you have some bleeding, well, then that gas is going to push the water out. But otherwise, there really is a minimal pressure differential between that third space and the space around the esophagus. And then I always preserve the longitudinal muscles because the disease layer is the circular. So I want to really just selectively cut the circular, and I want to preserve the longitudinal with the idea that maybe that also will reduce the risk of reflux afterwards.
And also blown out myotomy, Dr. Ben Muller. I think that if you do full thickness myotomy, the risk of blown out myotomy or BOM is a little bit more.
We're going to move to, Dr. Bilal, we're going to move over to Dr. Fan's
Sounds
room
good.
here for a minute.
We're just going to finish up the myotomy. Thank you.
All right, wonderful. Thank you. Dr. Fan, we're back with you. Can you hear us?
Right. I can. So we are now moving on to our resection of this small nodular area, this raised area here. Marked out the borders of the lesion, and then we're going to use the Cook Duet kit in order to do a band EMR. And so I know that there is different ways to take out resected lesions or raised lesions. I think we're a big fan of using band EMR. So you can see here the deployment of the first band. And I'm going to put the snare down, and there's debate about going above or below the band. I tend to go below. I'm a lineage of Raman Muthuswamy who loves to go below to get a little bit more tissue as much as possible. Open, please.
I will say that under Sachinwani's tutelage, I tend to be go over the band a little bit more frequently myself.
Right, good. So we're nicely tucked underneath the band. Lay it pretty loose, lifting up. A little bit of coagulation, and then cut. Close. Cut. Okay. And then taking a look at our resection site. Quite safe, no areas, no issues of perforation, no bleeding here. So what we're gonna do now is do double therapies at the same time while keeping a border around this resected site just because he comes from afar. And so I'm gonna take out the duet kit, put on an RFA catheter, and start to ablate now the rest of the Barrett's that has been shown to have multifocal high-grade dysplasia.
That's great. Thank you, Dr. Fan. It was an excellent demonstration. We'll come back to you to see some of this ablation. I believe we might be going to the AIG in India, if that stream is set up. So far, it's looking good. This is in Hyderabad, India. It's actually about 8 o'clock in the evening there, which is just a typical endoscopy day for this busy endoscopic practice on a Friday night. I did clear it with them for sure, and they were happy to oblige. And if we don't have them set up just yet, okay, we're going to go to room 14, Dr. Tucker. Sham, you're there. Can you hear us? We're back with you. I don't know if they
cannot
give you
hear
a heads
Raj.
up.
Can you hear me?
Yeah, we can hear you.
I heard him.
No,
Well, they look like we're live.
Yeah.
Yeah, you're live.
I can hear you now.
Now we can hear you. Good.
Okay, so I'm going to kind of walk you through a little bit what we've done. So we got the wire out the tract. Alan held some back traction with Tom, and I'm going to show you here some of the images that we have. So here you can see, go back one, please. Go back one. Yeah, so here you can see we got the graduated dilator through a 456 with that back traction worked very nicely. And then we took it to our hurricane dilator. And so go to the next image, please, Tom. Yeah. And so you can see how tight that stricture was there at the takeoff with the hurricane creating the waist. And then ultimately we did a second dilation. You can go ahead again, Tom. Next image, please. Yeah. And we dilated all the way up into the gallbladder. So I think we've got a pretty decent dilation done there. And what I'm going to do is now just do a gentle dilation of the left main hepatic duct, just to open that up a little bit, followed by some RFA to the hilum, and then we're going to put the double pigtail stent in and plastic stents into the right and left. What do you guys think?
That's amazing, actually, that all this is being done. This patient, if you want to become best friends with this patient, you're going to take that perc drain out after you put the transpapillary stent in. It's been in for more than a month. Oh, we got it now, Ken.
So So I got to
So
share something with you, Raj, but you got to promise me you won't tell my wife, because the patient told me she was going to give me a big kiss if I got this perk drain out of her. I
see all
can't
the
have this reputation of having affairs out in Colorado.
well, the visiting faculty get to know their patients before the procedure, so that's
Yeah.
good to hear. We're gonna switch quickly to so you're gonna do RFA on the left side and on the right side. AIG is ready. I apologize, we're not gonna be able to show this, but
No.
we'll get back to you here in a minute. Dr.
Okay.
Laktakia might be from AIG on next.
Okay, sounds great. Yeah, please go to them, and we'll show you at least one RFA hopefully.
Thank you.
Bye.
It's a beautiful building. And
Hello. Hi.
we
Can
hear
you
you,
hear us?
Sandeep, Dr. Laktakia. We hear you,
Okay. Hi,
but
Raj.
we can't see you. We see your beautiful building. Oh, wow. Here we go.
That's incredible.
Hi, Raj. Good evening from India and good morning to people in Colorado. As you see, we have a big team of performers on the stage. On my right is my friend Jahangir, Dr. Nitin, Dr. Asif, Dr. Anirudh, and Dr. Anudeep. So all are interventional EUS guys. We also have two senior techs, Srinivas and Sridhar, and we are supported by two senior anesthetists. So we have a big team here late in the night at AIG. All of them can perform interventional EUS. We did a toss before coming live, and it fell in Jahangir's hand to do the EUS GJ. So let's get the history sorted out. Do you see the slide on the screen?
Yes,
Raj?
we do. Yes, we do.
Okay. So this is a 66-year-old lady with a cancer head of pancreas with duodenal narrowing, and she has symptoms of gastric outlet obstruction. She also has malignant biliary obstruction with bilirubin of 30, and the biopsy is positive from the pancreatic head mass. So the plan is to do a EUS biliary drainage and EUS gastroenterostomy. So two procedures in the same patient is what we would like to show. And Jahangir would be performing the EUSGJ. As you see on the screen, there's a mass with the head, which is locally advanced, and patient is not operable candidate. So we'll do the palliative procedures to drain both the obstructed systems. Jahangir, over to you.
Yeah. So the plan is to perform EUS guided gastrojejunostomy. The meantime, while we were waiting, so we did some of the procedure. So we performed upper GI endoscopy. We passed the endoscope with the help of a over tube. Can we get, yeah. So you can see on fluoro, you can see the over tube. So we passed the scope with the over tube inside, and then we reached the second part of the duodenum where there was narrowing. We negotiated the guide wire. The guide wire has gone deep into the jejunum beyond the DJ flexure. And the main purpose of the overtube is because we are going to perform GJ with the help of a double balloon catheter, that is the EPAS balloon. The technical details of the EPAS balloon specification, Dr. Sandeep will explain shortly. So it is very flexible tube. So to prevent it folding in the stomach, so we used the over tube. So you can see through the over tube, over the guide wire, we pass the EPAS balloon catheter, and you can see on fluoro at the tip there are lead balls, that is the distal part of the EPAS balloon. Behind the tip there are two balloons, the front and distal balloon. I request Dr. Sandeep to explain about the EPAS, then we can
So
start
as you
filling.
see on the screen there, this is the EPAS balloon on the slide. This is from Japan. Takao Itoi, my friend, has provided that. And this is the device. It is from Clini system. The device is an oroenteric tube. I can show it to you ex vivo. This is a tube which has, this is a lead ball tube. The whole tube system is about 3 meters long, and the proximal end has 4 tubes. So the two red ones are to fill the two balloons. One of them is to take the guide wire.
Inflating.
One of them is to fill the contrast and the coloring agent between the two trapped balloons. So to save time, we have introduced this balloon inside as Jahangir just showed, and then we'll start the procedure. So this over tube is actually meant for enteroscopy, which we borrowed from them for the short enteroscope from Olympus. So let's start the procedure, Jahangir.
Yeah. So now we start filling the balloon. First, we'll start the filling front balloon. Front or the distal balloon. You can appreciate on fluoro, contrast mixed with the saline is getting filled. This is actually in the proximal part of the jejunum. And simultaneously, we started filling the distal balloon also, the back balloon, which is just adjacent to the spine. So both the balloons we fill, we would like to fill with approximately 30 to 35 cc of saline mixed with the contrast. The intervening part of the catheter has side holes. So after completely filling the both balloons, then we instill saline mixed with contrast and methylene blue, the blue dye, and then we'll distend that segment.
So just to let the audience know, there are several ways to do EUS gastroenterostomy. There are several experts world over who perform with a freehand technique using an oroenteric nasobiliary or an NJ tube and fill liberally with a pump and after paralyzing the duodenum. We believe that using this kind of a balloon, especially for people who are starting early in the career, we fix the small bowel because that's a very mobile organ. So going from stomach to the jejunum, sometimes there's a risk of perforations, adverse events happening. By fixing this loop of bowel, which will now get filled with contrast, can we start filling the contrast? We actually have a target organ right in front of us, as you see now. So the whole process of putting the over tube, the EPAS balloon takes just about 10 minutes, but it adds a lot of safety. So start filling. Yes, Fluoro, please. You'll see the contrast coming in as you see from the distal balloon. Yeah.
Okay.
Raj, you can appreciate that?
Yes, we can see that very well. It's a very nice demonstration. Thank you, Sandeep.
Yeah, so we're pulling back the over tube. That purpose is done now. While the intervening loop of small bowel is getting filled, the job of over tube is over and it's coming out while the loop is getting filled in. We've also given the patient glucagon while doing it. This is a very nice loop, a descending long segment, a perfect position for the beginners. If you have a tortuous loop, sometimes it can cause challenges. So you can, okay, come out. No. We fill this segment with about 100 to 150 cc of this mixture, which is saline, contrast, and the coloring agent. Okay, it's come out. Yeah, over tube has come out. Yes. And then we pass the EUS scope beside the oroenteric tube now, the double balloon.
So now I am passing the linear EUS scope. Jali.
Sorry. Side button.
Yeah. Just adjacent to the EPAS balloon catheter, I pass the linear EUS scope.
And then,
Yeah, it's good.
will we be able to have an EUS view? It looks like the fluoroscopy view is overlapping the EUS view, just so you know.
I'll show you the EUS view. Yeah. Okay. Can we have the, sorry, EUS is frozen. Can you have the big one?
Oh yeah, that picture in picture. There you go. Thank you.
Yes, mild ascites is there. So
Is
There
that
is
going to
some mild
limit?
ascites.
Yeah.
So
Yeah.
that's another reason where this balloon would help, that we can actually go in the target organ then.
I think this is the balloon catheter.
So there's
This is the catheter.
abdominal ascites, but not necessarily intervening between the stomach and the bowel of the you're targeting, and you're okay with that?
Yes, we are fine with that. I think a little bit of contrast has gone beyond, but this is a very good segment.
This is excellent target. Right, Ken?
Yeah.
Oh, yeah, yeah. No, it's beautifully distended. It looks like a pseudocyst, right? And you can see also that the catheter is inside of the lumen. That's important because sometimes when you're infusing a lot of saline, that's when you use just the oroenteric catheter without balloons, and you have constant efflux of the fluid distally. You can actually fill the colon. And I've seen cases where cologastrostomies have been created, right? So you can mistake the colon for small bowel.
It happens. Yes, it does. The other thing that,
In spite
and
of using the balloon, some contrast has gone beyond, so no worries, right? But we are still in a good position. And seeing the catheter, as rightly mentioned, is very important. This looks to be a good sort.
and what size Axios, and do you put any lubricant on the delivery system or wet it or any other tricks?
So we're using hot Axios from Boston Scientific 20 mm lamps, and we always lubricate it well with saline. Fill karo, it'll fill more.
So we want to fill little more.
I think in spite of the balloon, you see that some of the contrast has leaked beyond the distal balloon as well.
Can you overinflate the balloon or it doesn't work that way?
Yeah. No, we can inflate. We can go to the maximum. Since the patient was a little short in stature, we didn't want to we can little bit inflate more balloon.
Well, what's the maximum diameter of that balloon? Is it 4 centimeters or 5?
So about 3.5 centimeters it can reach. 40 cc is the upper limit before it ruptures. We don't want that to happen.
ये ठीक है ना सर क्या? ये जजनम में है ना?
हाँ ये और नीचे जाओ. Can we see the?
We'll pause questions while you're targeting here.
Yeah.
This is good idea.
This is good. Yeah. So this loop is looking good.
That is good. Good. And already glucagon has gone in. Yeah.
Yeah, and you have a nice long axis, right, for your
Yes.
runway.
A good landing space. Yes.
The runway Dr. Binmiller is talking about is from here to this
It's
direction.
gone in. Yeah, as you can see.
You can see the catheter has gone in.
Very nice. We can see that well.
Yeah.
Now you can. Yeah.
Yes. Now I lock it.
And
okay.
We don't
Now
see your
we'll take
hands,
this
but that's
safety hub.
okay.
Yeah.
Here we go.
Camera
All right.
and yeah.
Now I'll start deploying the distal flange.
It takes little time to open up, so one has to be a little patient. Sometimes the 20 lamps takes longer time to. I think that distal flange.
Do you ever push it in a little bit more to try to like jiggle it a little bit? That part of it. Yeah, kind of let it expand out.
Yes.
Excellent. We see it perfectly. Thank you.
Yes. So now we'll lock it here, unlock, and then
Let's pull it back.
we'll pull it back so that it will approximate at the jejunal wall.
Yeah.
We need just a slight deformation here. I think this is fine.
That's plenty. Yeah, it's plenty.
Yeah, that's fine. We'll lock it here, and then I'll deploy the proximal flange in the channel.
Push it in a little bit, you think? Push it in a little bit? I would push it in a little bit. I don't know. Am I?
It's okay. So,
Yeah. Yeah, that makes me feel better right there. Yeah, don't you think?
Yes.
Okay.
Now
Okay.
it's better.
Oh, can we see the endo part whenever you're? No, go ahead. Keep doing this. I got three
Yes,
people
yes.
talking to me. Sorry.
Yes. Now we'll deploy the proximal flange
Go ahead.
inside the channel. Now we deployed, and I'll move to the endoscopic view.
Yes, thank you.
Now I'll start slowly.
Push it out a little bit, maybe.
Yeah.
They push and pull back.
Sometimes we'll use the elevator up and down to try to release that out of the scope.
Yeah,
Did you
I
put
think
methylene blue in it or no?
Yeah, we have put methylene blue inside.
yes,
I
yes.
see
Now
a
we
little.
can see the methylene blue and we can see the stent also. Now,
Also jiggle a little bit.
now,
Yeah, just
yes, this is okay. Now we can push it.
Yeah, yeah, perfect.
Yes.
Yeah. Oh, so nice. What a demonstration. Thank you.
The reason why Raj recommended pushing it a little further out is because when you're pulling away from the gastric wall, what you don't want happening is that you pull the distal flange out, right? So you're giving yourself just a little bit of buffer there so that you can back off from the wall. You really want to see that proximal flange deploy. You don't want to do that blindly, and you want to do that very slowly, because you also don't want to push the proximal flange, through the wall into the peritoneum.
And for the younger doctors that don't know this, Dr. Binmuller invented the stent. So he's very modest here, but he knows what he's talking about.
I was actually going to say
Hi,
the same
Ken.
thing to our nurses. Ken, can you tell us what are your hands doing during step 5 of Axios deployment, deploying that proximal flange? How
Yeah.
do you teach that?
Right. So it's basically you're turning your body a little bit to the right, and you're backing away from the what you're pulling your scope back, right? And you're giving gas. So you have to insufflate well, and you're looking for the saddle. It's almost always at the right upper quadrant of your screen, and you're looking for that. And as soon as you see that saddle, then you can start advancing, and you just push. Now, the black hub is what you're pushing forward. Sometimes you've pushed that black hub all the way down and it still hasn't released from the working channel. In that case, you grab the gray hub and you push the gray hub down, or you can take that black hub and just kind of, jam it back and forth a few times and then it'll come out. But that part, I think, is really the trickiest. You got to be very slow and deliberate when you're deploying that proximal flange. You'd never want that proximal flange, because you think about this, right? This would be that type 3 where you have basically the contents of the bowel, swallow bowel, draining freely through the axios into the peritoneum.
So Dr. Latakia, thank you so much. It's an excellent demonstration from you and your colleagues. And we're gonna switch over. We're gonna come back to you for the other aspect of it. Is that okay? We're just gonna quickly show some case going on here. So we're gonna go to room 16 with Dr. Bilal. Bilal, we're back with you. We can't hear you, but can you hear us? Can you hear us? Give us a thumbs up if you can hear us.
We can
Okay,
hear
that's
you.
good. You have, let's see, we're waiting for your mic to be unmuted, maybe.
Can you hear us now?
Yes, we can.
Okay, fantastic. So we're done with our myotomy, and we already off camera did a flip, endo flip to confirm. And our DI, which was 0.5 before the procedure, now is 3.2, and diameter went up to 16. So you can see here it's a patent LES here, and much better than what it was before. So now we're going to close our mucosal incision. So we usually use through the scope clips. Open. The clip that we're using is the Cook Instinct Plus clip. I like it personally because I feel like it has a really good graspability. Close, deploy, and obviously you start at the distal, and this has to be a zipper closure because obviously you don't have any muscle layer below us. So Dr. Gabber and I were just talking about the role of EndoFlip, and we started incorporating in our practice once we started doing the really tailored short myotomies to make sure that we're getting full thickness myotomies. Our site is also going to be part of the Primidia trial, randomized control trial led by Northwestern, which we're waiting for NIH funding, which is going to look at long and short myotomy. And as part of the Primidia trial protocol, we have to do an intraoperative flip. So that's what we do. And then the benefit of, like I said, this scope is that now we don't need a lot of clips because it's a pretty short incision. Open. Open it, allow it to be You can see it to a little bit low now. Yeah. And I really try to approximate him as good as we can. Again, inspired from Dr. Belmore, using water, close. And for the fellows in the room, you know, one of the important things about closure, you never want to deploy until you've confirmed. So this looks good, so please close. Deploy, yeah. And then we're gonna close off our incision here. Is everybody like here use clips on the panel, or anyone prefers some other matter of closure for esophageal poem? Dr. Gabber, what's
I
your
think
practice?
everyone using clips here.
Yeah.
I use clips as
I don't
well.
do
It's
palm, but
simple
that's my
and
guess.
safe and effective.
Yeah, clips work very well. You just need to be sure that the prong doesn't slip off as you're closing it.
Yeah.
And it looks like this instinct clip is doing a very nice job of grabbing
Yeah.
both edges.
And that's like why I like it, Dr. Budmuller, because I feel like even sometimes the other clips will look like they're holding, but then they'll flop off just right when you're ready to deploy. But this one I feel like holds even if I feel like it won't hold. Close.
Nice.
Here we have both sides, check though, and deploy.
Bilal, as you're closing that, we're gonna, first of all, congratulations on an excellent demonstration.
Thank you.
Thank you.
That was a very, very subtle clap there.
We're gonna go back to room 14. Sham, you're live with us?
Thank you.
Thank you, guys.
You've been busy here.
Yes, can you hear me?
We can hear you perfectly.
Okay, wonderful. Yeah, it looks like you had some great cases going on there. We're about to do RFA in the right side. You can see I have the RFA catheter up on the right side. We've also already RFA'd the left side. So we're going to go ahead and perform this treatment. I think while we're doing it, we'll start the timer. It's a 90-second treatment that we're doing with the Habib catheter. I think there's different options when it comes to RFA in the biliary tree. There's the Habib catheter, and then there's also the catheter by Taiwan. Taiwan has different sizes. I think a little more flexibility around the hilum, so that can be an advantage. And it's not timing based, whereas the Habib one we have a little more experience with, and that one is timing based. So I'm going to go ahead and start, but as we're doing it, we can have a little discussion on RFA if that works.
That's great idea.
Yeah. So
And Tom, I wonder if you can pull up the spot film. Did you take a spot film, Tom? So we can get a better quality image. This is his live fluoro. So with fluoroscopy, we use low dose pulse, 3 pulses per second, minimize fluoroscopy as much as possible. This is the spot film here that they've pulled up, and you can see okay, well, no, it's good. Keep going. You're treating the patient. I'm just kind of talking.
Can you guys have a discussion about the efficacy of RFA? Because we were having a controversial discussion here. The data is kind of both ways as to whether it should be used or not used, and what the benefits are in the context.
Hey, this is Sumit Singla with Henry Ford. We've done a lot of work looking at efficacy of RFA in this context, which is unresectable hilar cholangiocarcinoma. I think there are benefits to delivering RFA with a carefully selected patient, and as adjunctive to chemotherapy and radiation in those patients. So we tend to offer it in a protocolized format for all patients who can tolerate serial ERCPs along with plastic stenting. But I'm open to discussion from the group also.
When you say selected patients, do you mean in a metastatic situation, or how do you define the patient population?
Yeah, it's a great question. In a metastatic patient, I think the benefit is more stent patency, prolonging interval between ERCPs, reducing hospitalizations from cholangitis. I think a survival benefit is more seen in that locally advanced patient, advanced bismuth classification, who can't get surgery but otherwise is receiving other therapies. So those are the patients I really look to perform RFA. I'm curious why. So we use both Elra and Habib in our practice, and I'm not sure if others in the group, and how you decide on which company and which type of probe you would use.
Yeah, good question. I would probably in this situation probably have favored Elra, though I think Habib can still work well. I don't think that there's any data that I'm aware of, but you might know better, Sumit, of one being superior to the other.
There isn't. We've tried to work with other centers to at least retrospectively look at this, and it's not easy. I prefer ELRA in a lot of settings at the hilum because the depth of penetration is predictably a little bit less, and I worry about the hepatic artery in a lot of these hilar cholangios, and I've seen pseudoaneurysms form as a result of RFA. So that's one reason I prefer it. I also like the different lengths, whereas this one is 24 millimeters pretty predictably. So those are some of the reasons.
Right. And so yeah, I think in this case, I think you outlined it nicely in terms of whether we should do plastic stents or metal stents. My preference here, we're going to be able to get a double pigtail stent hopefully here into the gallbladder. I would like to leave plastic stents into her biliary tree. As you saw, her hilar stricture on her cholangiogram did not look that bad. I don't know, Tom, if you can pull that cholangiogram back up. I mean, there was still obviously a stricture, but it wasn't nearly as severe as I thought it was going to be. And so my sense is perhaps she's had some response. And, we're seeing with these hilar strictures oftentimes when we put metal stents that the response to chemotherapy and treatment is they outlive the stents, and then we're coming in to constantly clean the stents or place stents within stents. And that can become more of an issue than the, cancer itself.
After the RFA, do you do any balloon sweep to clean out? And then also for the audience, after that 90-second, he waits a minute, I believe, to cool down the tissue before pulling out the catheter. There was a question in there, sorry. Do you use any balloons or anything to sweep out tissue or not really?
I do not, but certainly you can to see if you can get any of that tumor sludge out of there. I'm actually trying now to see if I can get this double pigtail plastic stent into the
You pay attention, on your side as well. Okay.
Or I'm sorry, into
Were you able to dilate with the
More
4?
the better.
I did. I dilated actually with the 4 millimeter hurricane. And right now I have the 7 French double pigtail that I'm trying to push through.
And your wire's through the perk track right now?
Correct.
Yes,
Correct.
with tension on both sides.
You could try. Oh, is Summer giving you some back tension?
Just popped. Yeah.
Ah, nice.
Beautiful.
All right.
Such a good feeling when it gets across.
That feels so good for everybody,
Feels
actually.
so nice.
Yeah.
Yeah.
So we see it right there. Yep.
Yeah.
And part of the reason it's so hard also is this is
So I think
a
at this
packed
point-
full of stones.
Holding it
Yeah.
there 'cause I feel I'm pulling you towards me, but that's okay.
Yeah. So
Yeah,
I think at
exactly.
this, we don't want it to go any further in. So we're going to go ahead and just stop right there. And there's my mark. Beautiful. So I'm just going to push it out and go ahead and, you can pull wire. You can let go, please, Alan.
Yeah, then go.
Yeah. Go, pull. Great. Whoops. There we go.
And you just push that with the catheter or a 7 French pusher?
Yeah. I pushed it with the 7 French pusher.
Okay.
Yeah.
Okay, and I cannot let go. I cannot let go more.
Might be stuck in the elevator. Is that possible?
I can
Yeah.
go- I
Well,
can
this
let
is
go completely.
this is excellent. Quite a relief.
Okay, go for it.
They'll probably push it out either with a balloon or a forceps. You can use it.
There we go.
Perfect.
There we go. You got it.
Bingo. I wasn't gonna let go.
Wonderful. Thank you. We may be able to get back to you.
Okay, we're gonna go ahead
So it
and put
sounds
our,
like your plan is plastic stents then, replacement?
Correct.
Fantastic. Thanks so much for this demonstration. We're going to go
No
back
problem.
to
Thank you,
AIG, I believe.
Okay, excellent. Thank you, guys.
Okay.
I think we should pull the double pigtail down a little bit because it's into the track there a little.
Okay, we're going back to AIG and waiting for them to unmute. There we are. Sandeep, you can hear us?
Yeah, hi.
Wonderful.
You can see us and hear us? Okay.
You
So
look
we walk
great.
with the same patient. Raj, who's there with you on the podium?
So we have Hiro Isayama from Japan, and we have Heiko Pohl from Dartmouth, and Ken Binmuller from California, and Sumit Singla from Detroit.
Hi. Oh, so you have a very powerful People on the podium
It's a
there.
little intimidating here,
Hi,
honestly.
Hi, Ken.
Hi,
Hi, Hero.
Sandeep. Good to see you. Doing great. Look forward to your beautiful demonstration.
Okay, so we'll do the hepatogastrostomy is the plan. And once Hero is sitting there, he will help me guide.
Hello, Sandeep. I'm Hiro. Brother.
Brother.
Yes. We can see you very well. Very so smart.
Thank you.
So your groupie fan club is here.
So we are going to puncture the segment 3 duct, which is on the screen. So I'm looking at the left lobe for the beginners over there. And as you can see, these are very grossly dilated intrahepatic ducts. Very, very nice to start off with. As I turn my scope clockwise, I see these ducts, which is the big one, if I can use the pointer. So this is a segment 3 duct. If I turn clockwise, it will go up, further, then goes medially towards the hilum. This is another segment, which is probably segment 4. And then it goes right there on the top of the bile duct. It'll enter that's the main left hepatic duct, which will go into the bile. So our aim is to puncture this duct. And I'm using the Olympus 19 gauge easy shot 3 needle. Yeah, thank you. Just reduce that. Yeah, thank you. Avoiding the big hepatic vein that is there. Jahangir, if you can help me with that. So that's the hepatic vein here, which I want to avoid as my target in between. Ideally, I would like to have at least 2 to 3 centimeters of a liver cushion parenchyma, which prevents any bile leak in case there is a malposition of the stent.
Do you
just remove
you
the
choose an FNB needle? Is there advantage you believe to the FNB needle compared to FNA needle?
Now I'm using a FNA needle 19 gauge.
Okay.
So we use FNB needle for the CDS. And now we are not access available for the CDS. So, but HGS, FNB, a little bit difficult to puncture.
Yeah. Okay.
So then
Advertising, right?
Yes.
I mean, yeah. I mean, the
I
easy
typed
shot is
easy
an
shot.
FNA needle.
Yes.
A 19 gauge.
Yes, FNA.
Oh, I see. Okay.
It's really nice because it has that coil sheath. You know.
Coil sheath, yes. Yeah, very flexible. And I agree with Sandeep to keep the liver parenchyma about 3 cm to avoid the leakage.
Yes. Minor adjustments are required. There's a small duct which is interposing in between. I wanted to avoid it as much as possible, but I'm not sure I can avoid it. I have gone in. Yeah, I think it's through it, but that's
Penetrate.
okay. Yes, aspirate the bile, please. Aspirate. Aspirate. Okay. White bile. Okay, it's white bile. Okay, that's stop. Inject contrast. I'll follow the bile duct direction, and okay.
Very large diameter.
Little more contrast. Yes, saline with contrast. Yes, it's going up, and then okay, yeah, we got that picture. So we'll use an angled long wire. It's 025 jag wire. So if the wire goes, yes, please.
Yep. Visigride, do you use?
I'm using jag.
Jag.
That's a preferred wire instead of Visiglide, because sometimes the cautery does not work on Visiglide. I know Japanese don't use the cautery. We use a lot of over the wire 6-inch cystotome.
Okay. So then when you injected the contrast, did you also flush with some saline to make the channel less sticky prior to the guide wire?
Yes, yes,
Okay.
Raj.
Thank
Very
you.
good idea.
Can the fluoro be increased in size?
Yeah, we
Magnify,
can
yes,
see
thank
this really well. Thank you. This can be a very difficult part to try to get it down toward a good target.
Yes, 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 yes.
But of course, he's gonna just crush this.
What did you say, Raj?
No, this is excellent. Expected
So
nothing
we
less.
have
Yeah.
Mr. Srinivas. Okay. Let's exchange. I'll take out the needle, giving the guide wire inside. And at this point, I would just like to highlight for the beginners that we need to keep the EOS view with the wire always visible. As you can see the wire, maybe Jahangir, you can point out with the arrow. Always keep the wire there.
And the point is, it's an excellent point, and it's just related to maintaining that access and not relying or trying to revert to an endoscopic view can be a big mistake. So that's an excellent point. Thank you. And now you're passing.
I am passing the 6 French cystotome. This is over the wire cystotome, which is a very commonly used device to create a fistula between the stomach, the liver capsule, liver parenchyma, and to the bile duct.
And
Raj,
we
I'll
now
also
have
make
that.
an effort. I will also make an effort to pass the guide wire ultimately across the papilla. If that happens, then I have another option of doing an antegrade stenting. The reason I'm keeping that in mind is because this patient also has ascites, and that can help me in that kind of option. All set? Cautery settings, okay? Yeah, so we have the cautery settings exactly like what we use for ERCP. This is not 100 watt, this is only 40 watts. You can remove the
Yeah.
Hey, this is Heiko. I have a question as someone who's not doing those procedures. So does it matter which direction you put the wire in? Like, is it more towards distal or towards the common bile duct? And then how far above the bifurcation do you try to get in? Or so to make sure that you're not going too far distal in the bile duct?
I'm sorry, I could not did you understand what was there?
So which part of the
You're just busy with something very important here right now. Maybe talk about this
Yeah,
later.
I will. Maybe my colleagues can, Jahangir or Nitin or Asif, we can answer that. Direction of the wire. Contrast. Yeah. So I should always look at the scope, should look towards the hilum and not towards the peripheral side. So the guide wire preferentially goes to the hilum and then go. I'm putting some contrast now to fill the lower CBD. It's very tight. Nothing is going down. Stop. No, don't overfill. Don't.
Usually the best part to negotiate the guide wire towards the CBD is to puncture segment 3 duct just close to joining of segment 2 and 3. If we rotate a very small movement, if you can see the joining, and at that point, if you puncture, the chances of negotiating the guide wire towards the hilum is more. So we usually target for that. If not possible, as close to as possible. I think there is a tight stricture there in CBD.
The lower CBD is very tightly blocked, so I don't have an option of an antegrade stent. And the reason I'm saying is that not a drop of contrast went in the lower part in the duodenum. If that had happened, then I would have made a little more extra effort to go across the papilla and have opened the third option of antegrade stenting. So we'll use a geobore stent, the cold variety. Jahangir, you can show that stent. This is a 10 centimeter long stent, which is partially covered. The hepatic side, 3 centimeters is uncovered, and the rest 7 centimeters toward the stomach will be fully covered. So it does not block the side branches because I've gone through one of the small side branch, but if my stent is okay, that should not cause any problem. I'll get my wire in my view once again, as you see it
So
there.
this is the stent we are using.
This is from Taiwan Medical.
10 centimeters long and 10 millimeters in diameter. Proximal 3
Yeah, Sandeep, this one is not available in the US, so unfortunately.
I know you guys use the other one, the viable or the. So here comes the stent now, wire tight, wire tight.
Yeah. Yes.
So in the US, we could
I'll
use
go
a
as
partially
deep as
covered
possible, and I
stent.
will not come
Mhm.
back. You see, there is a mark between the covered and uncovered segment.
That's
Wire
nice,
tight.
yeah.
Let it go down.
We're
And
just
that's
envious right
the
now.
junction of. You
Yeah,
can
yeah.
little bit more, and I would actually open it now. Open it now. We can always pull back, but can't push it once it opens up. So I will now start deploying the stent, and keep looking at the transition zone between the covered and the uncovered. Release, 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 release slowly. Yes, slowly. Hero, you're happy?
Yes. Yeah. I love this tent and I love this procedure. Very excellent.
Release.
Ken, what would you use
will
in
release-
America for this case?
Oh,
release
so
in the
I
channel
think many of us are using the viable. It's a laser cut stent, so it doesn't foreshorten, which I think is a huge advantage here. And then it has side holes. So it doesn't have an uncovered portion like the GeoBore or, other standard braided stents. It has little holes that are cut into the covering. And at least conceptually, maybe that reduces the risk of ingrowth. Because that's always a problem, right? With these uncovered stents, that they cause hyperplastic tissue response of the ductal epithelium with ingrowth.
Yeah.
But the viable you're using is a covered.
Yeah, they are all covered. It's just that there are two versions. One version has little holes at the distal end, the intraductal end, along about 2 centimeters. And there's there's one without holes. So an unholed version.
Got it. Thank you.
Yeah.
Oh, very nice.
Excellent.
Excellent.
So
Excellent.
while you are talking, I deployed the stent in the channel of the scope, pushing the gastric wall all the time. I didn't want to see it endoscopically. That's one important crucial step one should avoid doing, that visualizing the stent getting deployed endoscopically. Deploy the stent in the channel and push it out. This is what is better to prevent any kind of candy sign. That's okay. Ken,
Yeah,
are
very-
you satisfied with this? And
Yes.
Hero, these are
Yeah. So I
simplified.
think from puncture to the B3, the gastric wall will be returned to the original position. Then protruding portion in the stomach, about 5 cm enough. But less than 5 cm sometimes cause stent migration. Okay, it is also very enough, I think.
Very nice and very nice
Yeah, so we had
demonstration.
Thank you.
Thank you very much for joining us this evening.
Yeah, this comes to 5 centimeters approximately. Yes.
Is there a rule to fixing the stent in the stomach?
No, but if the length is very short, I will stabilize the stent by a clipping at the stent body. So make a new flap.
Congratulations. Thank you
This
so
is
much for
like a,
excellent
quick flap technique.
demonstration, Sandeep. Thanks for joining us today.
Excellent.
Excellent.
Maestro.
Thank you for the opportunity. Thank you. Thanks for giving us the opportunity, Raj, and the entire team there at Denver. It was a pleasure transmitting from AIG Hyderabad to all of you. We thank you all from our team. Goodbye and have a wonderful conference.
Bye. Thank you.
Okay.
Thank you.
Thank you. Bye-bye.
Hiro, do you mind? Sorry, I didn't mean to interrupt. They looked like they were wrapping up. You have some additional comments? You want to
Yeah.
say, then we're going to go to break.
Yes, yes, HGS is still difficult. So this procedure is very smooth, but sometimes very, very difficult. So the most difficult step is also dilation of the puncture tract. But this time, so using the cautery dilator, it is very smooth. And finally, we should think about after the procedure, the stent sometimes go into the abdominal cavity. It is a very risky situation to avoid this disaster. So long portion in the stomach or make some clip flap by a clip to the stent body to prevent migration. After such kind of the procedure, we can go to the home and a good sleep.
Thank you. Wait, no.
Yeah, Hiro, you don't have the viable stent, I think, in Japan, right?
Yes, we have a more good stent named spring stopper stent. So
Okay.
geoball stent with very good anchoring portion at the stomach area.
Yeah.
Yes.
So I just wanted to mention, so the viable, and like, I'm not trying to put a plug in. I have absolutely no conflict of
Yeah.
interest. And it's really by default that I'm having to use it, but I do like it because I've found that the fins,
Yeah,
they
fins.
are very effective in preventing migration. So I personally feel always uncomfortable when so much stent
Yeah.
is in the stomach, 5 centimeters, and that creates a lever. When you have peristalsis, it can pull the stent and it can migrate. So I actually try to place when I use the viable, I place it as close to the wall as I can so that I don't have that lever effect.
Yeah.
So it's just a different mindset here.
Yeah, I agree with you. Because the shorter portion in the stomach is better. So then so good anchoring the stent we required, but actually nothing. So then we use such kind of stent, and I agree with viable stent is very good, but I saw some complication with the flap in liver parenchyma, so cause through the aneurysm.
Yeah, but that's on the other end.
Mm.
Yeah, those are the flaps are flaps on the proximal and distal
Yeah,
end. And
yeah.
those fins can be traumatic
Mm.
on that end.
Yeah, so still require the better stent with.
And a good point. Good. Another point is just know the type of stent you have in your lab because the viable stent, has been mentioned, is non-foreshortening, as Ken mentioned. Oftentimes, you have to use a longer stent than you might expect compared to the foreshortening stents that are by some of the other companies, such as the Wallflex and Evolution. So keep that in mind. We're gonna thank you all for your commentary, and please come back after the break. We are going to do a break for 15 minutes. Please go to the exhibitors, say hi to them, see what they got to show you. It's very, very possible that what they're excited to show you may be in your hands in a year and 2 years or 3 years. You never know. So please do that. Enjoy the refreshments, and we'll see you back at 9:50. Thank you.
I know exactly. Nice applause. It's good start. Good job. Good cases, actually.
I have never used the cystotone. I've never used it. I've always succeeded with just dilation, mechanical. Yeah. And I feel always nervous when I'm using
Even when you pass your stomach well. And it goes, yeah. I tried that.
But I find it. I go in those steps that you show.
What steps do you take?
5, 4, 3, glow tip,
Oh, you practice.
hurricane.
So the
Oh, really?
Yeah.
catheter?
No, it's just the ERCP, but it's very stiff.
Yeah.
Hook works really well.
Yeah. Actually, that's pretty good success, depending on your angle.
And
It's
sometimes
just
you just go right in with the hurricane.
Yeah.
It all depends on your angle. If you have like if it's a straight shot, you just go right
Did you
through.
use a 4 mm hurricane?
Yeah, for only the 4, yeah.
And you're talking about for like osmosis gastric, or you, for what indication you're describing? Great.
Oh, no, I'm talking about HG.
Okay, all right, got it. That's big cases.
I would have done ESD for that.
Yeah, I was wondering. I mean, it's hard to predict if you have cancer, how deep it is.
Yeah, I know. I would have definitely done ESD for that one. That should be the teaching point, is that when you've got something with a nodule like that, elevated area,
Cancer.
and this
couldn't
multifocal
predict-
high-grade dysplasia, you should be sending that for ESC. You should not be
I
trying
did not
to
think
keep
about that
feel
before.
that,
I used
because it's really about what message are you giving the community, right? When you do a live. So, I mean, this is sort of because you know, you want to show this, but it's not the right teaching point, I think. I think the teaching should be, no, high-grade dysplasia. High-grade dysplasia in my book should be sent for ESD unless it's really, really flat. And you think, okay, I think RFA is able to get adequate depth.
Flip the stent after gastroscopy. And you have it like this.
Yeah, it's about 2 centimeters out.
Millimeters.
Looks really, I've never had a migration.
And on the inside, migration coming out? No.
No?
But
Also
they
not.
just, depending on where you kind of position the location, making sure that you're not too distorted.
Yeah.
When you ask.
Yeah. What's really nice is it's laser cut, so it doesn't foreshorten at all.
You have to pay attention to how far periphery you are and that you're not too close to the thing. When you kind of select your, you just use whatever you think is happening.
I just make sure that I'm in the
Okay.
Yeah.
Of course.
I don't want to have it too far in there because there is a risk of blocking, even though it has those little holes, blocking flow from the side branches, so.
And the direction, whether it's going through for free or the other way, doesn't matter.
You know what, I think it really doesn't matter that much, but yes, preferably you want it in the direction of the hilum, yeah, right. But sometimes you just can't get it there.
Yeah.
So, yeah.
All right.
Take the gallbladder. Thank you.
Thank you.
Yes. No. I can just do it from my laptop, right? Yeah. Oh, okay.
That's the only way you can get you on.
Okay. And I do have a backup on a.
Hey, Ken, you'll come back here after your break?
Yeah.
After the break.
Yeah.
Then we'll have a speaking timer here, you're like 15 minutes.
You know, I
know Dr.
but-
Shaw's always on some.
But it goes to lunch, so I
Yeah.
think they'll be a
So
little
whatever,
forgiving.
just know that like, 15, I'll start you out at 15
I
minutes.
sent you the.
Thank you.
Maybe you can help me with this, yeah, while I get this.
And then just make sure that your computer.
And then this caffeine thing is what makes it so it doesn't go to sleep, right? Are you familiar with
I
it?
am not a Mac person, so
Yeah.
I'm sorry. Is that, okay. Let's get your charged. You know, it's a great presentation.
I love keynote. I'm just going to quit a bunch of these other programs. That's good.
Do you have any videos playing on there?
They're embedded.
Embedded?
Mhm.
Sorry for taking up some of your time.
Oh, no, it's good. It's good that we're doing this because I would have forgotten. And then I'm rushing up at the last second trying to. do this and that's not good.
And Joe and I will be here to help us as you use. Just stare, give us that stare to the back corner.
All right, so let's see how, because I want to, this is the keynote. And then let me see if I go, because don't we want to test to see if it goes full screen? So let's say I go here. Into full screen. It looks like this.
Okay.
How does it look on the?
So we're gonna have to get you on Zoom first. So whatever we're gonna share your screen. So do you use Zoom on this? Do you have a Zoom app on your?
Yeah, there should be a Zoom.
Yeah, Zoom. And then I'm gonna give you the. Number.
Well, I could get internet. Okay, which.
Joe, you're a Mac person. Can you get us on the internet? You get us rolling? And then just make sure that doesn't go to sleep.
Wonder why I can't get the internet here. Just. You should just.
The guest should be fine,
Yeah, try to put.
but I'm gonna sign you in as me.
He's gonna advance from his.
Yes, from his computer. I can't test it until I get back there and then switch it over, so like.
I remember, right. Good to see you too.
So. Not sure. So actually it should be in there.
Let's get.
We gotta get. Reach out to my.
Oh, you know. You're like, this is.
Otherwise, I do have it on a PowerPoint.
That's a thing in PowerPoint.
Yeah, I converted it.
Okay, we can do that as well. That would be quicker.
Okay, let's try
And
that.
then you won't necessarily have to do anything.
But I can use my mouse or not? See,
Well,
that's
you can use this mouse. You can use this computer.
See, that's
here.
what I like here is that I can use my mouse on my keynote.
You can use the mouse to point at things.
Yeah,
You can, so we can give you a laser in PowerPoint. We can give you the.
but then I gotta go like this, right?
No, it's laser in PowerPoint. Here, let me show you. So if we go to. It won't show up here, but
Okay, so
I can show you.
let me see how this works. I haven't tested it.
So
let me
this
do that
this
real
would be
quickly.
easier if we can get it on this computer though.
All right, I get that. So it would be.
So in PowerPoint, when you go to the notes.
Because you can't do keynote, right?
Right, we cannot do keynote, but you do have this laser pointer. So you can do the exact same thing. as
Okay,
your
so let me
phone.
see.
That is an option.
I don't know how to use, uh, you do slide play here with PowerPoint.
You can go down here to this right here.
Here?
Yeah.
Okay,
And then you select that. It may have to select on the left side there. And I think
Right.
it might be extending already.
but how do I want to see what the audience would be seeing.
The audience will be seeing a.
But
Oh,
it's-
I see what it's.
not.
So
Oh, here we go.
This is how.
this the PowerPoint?
Yeah, this is how they will be seeing it, but you will get a note.
Okay. And then I can play this, right?
And if you are more comfortable on your MacBook, we can just join you to Zoom and go that way. Hold on. Yeah, he said.
I think we can do this with PowerPoint because I'm worried that the Zoom will be somehow not work. And how do we go to the full screen in here? Okay.
Stand by, look at his presentation, piece number 5, I'm sure.
Okay, works. So this is, I would eject it now and you can,
Yes.
So we'll just do that.
let's do that. That way I can just do it directly from here.
Exactly.
Okay, good. Wait, okay, I didn't eject it, but that's.
Well, it should be, it'll be.
It'll be okay.
It'll be okay. Okay, I gotta. Yeah.
It says because the file is read only, to keep your changes, you'll need to save the presentation with a new name.
Yeah. Oh.
Yeah. Yeah, of course.
Just for me, but also to send to Cyrus.
And then you need the USB-C connector?
No, sir, I just need.
Okay, one second, wait, I'll still say it.
When I
Send it to me too.
Yeah.
Here, sit down next.
Are you doing something?
We're about to go live, but go ahead, go ahead. Oh, hi, Amanda. Hi, Megan. Oh, yeah, you were at the nursing course. There, yeah.
Kristen is our other nurse.
Hi,
So-
Kirsten.
Wonder if it's quite sweet.
You know, he trained me in many ways.
Amanda, can you
And you know what I'm talking about. Let's see, move the microphone here.
think you're gonna have to force.
Wait, let's move the water bottle. This is my grandkid.
I know, exactly
That
what
is
I
my
said. My
grandkid.
grandfather.
Thank you.
Thank you.
Appreciate it.
But yeah,
Thank you.
we thought it was hilarious that you were like, push it out just a little more. What do you guys think? Push it out.
Just like Cyrus.
Things kind of straight up here.
He's such. Hey, Sean Bala, are you on the headset? Who's on the headset? Control room MD, who am I speaking to? Hey, all right. Hey, can you see what's happening in 14? Because they're still in there. I thought they'd be wrapped up by now.
Okay, so it's gonna be, let me just make this as easy as possible. Here, it's two.
Maybe they're taking the perk drain out. Okay, it looks like they're wrapping up. Okay, we're gonna go to the case presentation here in like 1 minute. Who's speaking? I can't hear you. Is that you, Anna? Okay, thank you. Okay, we're going to go to the next case presentation. And we have, is that live?
So I can take this.
Right. Yeah.
All right, guys, we're going to get started with our next live case. This is a patient with initials BS who's referred for an EGD with RFA or EMR. 51-year-old gentleman with a longstanding history of GERD on esomeprazole 40 milligrams daily, also taking famotidine in the evening, recently quit smoking. There's an EGD from July, which showed 10 centimeters of Barrett's, which looks like C8M10. Biopsies were obtained every 2 to 3 centimeters. Don't see the biopsy results. Plan is for EGD with RFA versus EMR. Now, there we go. So outside pathology revealed focal high-grade dysplasia and a background of intestinal metaplasia at 30 to 32 and 33 to 35. Other biopsies just showed intestinal metaplasia, looks like more proximally. When it was reviewed, a second look, there was scant high-grade dysplasia in some of the Barrett's, looks like 33 to 35, as well as between 30 and 32, and then some non-dysplastic Barrett's more proximally.
Hey guys, can you hear me and see me?
We can see you well and hear you well too.
Fantastic. How was the break, Raj?
It was really good. I was looking for something a little lower carb, but I found some coffee, so it worked out well. Thanks for asking. We got a pretty good audience here, so we're excited to see what you're going to do today. And also, by the way, I have Hero with me and Sumit and myself, and Ken is floating around. So you have a reasonable audience. I can't say that I can't speak for myself, but the others are experts. So what do you got? Oh, I can't hear you right now. We lost your audio. Can you hear us? You can't hear us?
We can hear you.
Oh, we can hear you now too. All right. We can't hear Sachin.
Oh, they cannot hear that. Can you hear me?
I can hear you, Momin.
I see.
How about now, Raj?
Oh yeah, that's great.
Okay,
You just turned your
perfect.
mic on? That's great. Thanks.
Let's stick to basics, right? So I have experts in my room too. I have Carrie here who's going to be assisting me with the case. I have Michael and I have Ren giving us anesthesia. And I have Momin Gabber from the University of Cincinnati who is going to be moderating. And I have Kusuma Pakala helping us as well. All right, so let's get started with the case. I think you guys went over this earlier, just the concepts of a high quality endoscopic examination. So I'm just going to go over a few basic principles just as a refresher for our trainees. I am using the best endoscope we have in our lab, so I'm going to be using a combination of high definition white light endoscopy and chromo endoscopy to really not only define the length of the Barrett segment, but to also identify any areas that may harbor dysplasia or cancer. So let's start with our landmarks. We have the diaphragm
diaphragmatic pinch right here. And as I'm pulling my scope up, these have to be really slow movements, really trying to inspect the mucosal lining, make sure that you have your water jet available so that you get rid of any debris that you may see within the distal esophagus. And as I'm coming up, I'm cleaning my lens. This is still the hiatal hernia sac. And then as I come up here, you're going to see these gastric folds end, which is what we call as the top of the gastric folds, and that's where you are typically supposed to see the gastroesophageal junction. And right off the bat, you can see some areas of erythema here at the top of the gastric fold. So I'm going to say that as I come up here, this is where the top of the gastric folds are, or your gastroesophageal junction. So as I'm pulling back, I've already told Carrie and Michael the measurements for these landmarks. So you need to document that. Now I'm going to keep pulling my scope back, and you can appreciate that there are some areas of irregularity. You don't even need to have NBI on to appreciate that there's something off within the Barrett segment right here in the 12 o'clock position. But let's keep marching on and seeing the rest of the Barrett segment. And we're going to use this as a red flag technique, right? You're going to see if there are areas of abnormality that you're going to look at even more closely with your virtual chromoendoscopy techniques. But again, you're seeing in the 12 o'clock to 2 o'clock position areas that just don't look right within the Barrett segment. And you can also appreciate the fact that I'm being very slow and intentional in inspecting the Barrett segment. You want to keep suctioning all these pools of water, and I'm pulling my endoscope back. I think when Sumit did the case presentation, he described the PROG criteria. So kudos to the endoscopist for using standardized grading systems for describing the Barrett segment, and we should all be using the PROG criteria for defining the circumferential and the maximal extent of the Barrett segment. Now I'm pulling the scope back, and you can see some of these areas where you can see squamous mucosa. I suspect that these are all areas from where biopsies were taken. This did not disturb me in terms of the presence of dysplasia or neoplasia within the Barrett segment. As you can see, this is a fairly long Barrett segment. I'm coming back, and soon you're going to see where the circumferential extent ends, which is right here, which is where you're going to start seeing the squamous mucosa. And then I'm going to keep bringing my scope back, and you're going to see an area again that does not look so right in the 1 o'clock to 2 o'clock position. And then I'm pulling my scope back, and you've now seen what the maximal extent of the Barrett segment is. While they did use the PROG classification, I think I disagree on the overall extent of the Barrett segment. I think this is an overall a 15 centimeter Barrett segment and a fairly long circumferential area as well. Let me just show you what we see on NBI and a couple of points that I want to make, and then would love to hear what panelists and Moman and Kusuma have to say as well. In the interest of time, I'm just going to go straight to near focus to help us define the areas that we flagged on high definition white light. And you can appreciate that there's clearly an area of nodularity that I suspect will show either high-grade dysplasia or intramucosal cancer, and it's right, again, at the gastroesophageal junction, moving proximally and extends from the 12 o'clock position to the 2 o'clock position. This pattern is not right. You can see the distorted pattern, the mucosal and the vascular patterns, which raise the suspicion for underlying high-grade dysplasia or cancer. One other area that I want to show, and then I'll hand it over to you guys.
There's some ulceration there. Does that impact your management or decision making? Maybe one of those could be from a prior biopsy, but the other one seemed intrinsic.
Yeah, yeah, I think that's just squamous mucosa. I don't think that's an ulcer.
Sorry,
So
where you just were distally.
yeah, I know, exactly. So I'm not too concerned about that, Raj, because I think that's an area of squamous reepithelialization. So that's not going to impact my decision to perform resection. I don't particularly like this area as well. There's a subtle nodularity that you can see right in this area as well. So I'll open it up to Momin first to comment if he feels differently about the areas that we've identified on inspection.
No, thank you, Sachin. This was a very nice demonstration. So basically to our fellows, the way we approach this is that any area that's nodular, that's not flat, it's not going to respond to RFA. So when we talk with the patient upfront, I always explain to them, this Barrett's is precancerous and we need to get rid of all the Barrett's. Flat areas would typically respond to RFA or cryo, and the nodular areas need to be physically removed because they also can harbor cancers. So on the first time we scope the patient, we do what we call like mapping of the Barrett's. We identify where the nodular areas are, where the flat areas are, and put a plan for treatment. I personally, if I don't have high quality endoscopic images before the first procedure, like if I'm getting referral coming from outside, I would typically do not commit to anything from treatment perspective on that first session and just tell the patient this is for mapping because we might have even like a large nodular area that would require ESD and there's also even some opinions now if you have not a long segment of Barrett's and you have a lot of nodularity and it's not circumferential, maybe you can take the whole Barrett's out by ESD. We cannot do this here. This is like a 15 centimeter area. But that's the thought process behind it. And I'll leave it back to Dr. Wani because he's showing us a very nice area in retroflexion. And this can highlight really what we mean by a nodular area that's suspicious for a more advanced process.
Yeah, I think really great points, Momin. I will tell you what our practice is. Our practice is to see all these patients with Barrett's-related neoplasia that get referred to me, Kusuma, Bilal, and we see all of these patients in clinic. And during the index endoscopy, we are prepared to do what we need to do, whether it's resection, ablation with RFA, cryo, whatever that may be. With regards to what we are seeing here, this is a really important step that I want to highlight for our trainees, which is to ensure that not only have you done a good high quality exam on FOSS when you're visualizing the Barrett segment, but you have to take the time to do retroflexion. Ensure that you get the endoscope into the gastric cardia so that you can visualize the gastric cardia, the gastroesophageal junction. I can't tell you how many times a patient has been referred for Barrett's-related neoplasia. Biopsies have either shown low grade or high grade or even cancer, and the only way you can actually visualize the lesion is in retroflexion. So really critical step. If there's one thing you can take away from this case and examination is to ensure that you do this, which is what highlights the pattern in retroflexion. Also remember that you should be doing this step even when you've completed endoscopic eradication therapy. This is a hot spot for Barrett's-related recurrence as well. So ensure that you consistently perform retroflexion using your high-definition white light endoscopy and chromoendoscopy. So what do the panelists think? They've been very quiet.
Hey, Sachin, this is Heiko. Nice to see you.
Hey, Heiko, how are you, man?
I'm good. Glad to be here and visiting your place. I want to just echo what Raj was saying. There's one white, looks like a small erosion or a superficial ulcer at the in the distal esophagus. Maybe you can show that again. You said it's neosquamous epithelium, perhaps. This one in the 3 o'clock position right now. So that's adjacent to the nodular area.
Yeah.
That looks more ulcerated. So
maybe.
are you concerned about
Yeah.
this? That kind of indicates a more deeper invasion?
Yeah, it could be, but it also, he just recently was placed on BID, PPI therapy, HICO. So this may also just be related to inadequately controlled reflux. So you're right. So I'm not sure if this is just some debris there. I'm going to try and get rid of this. Yeah, I think that was just debris. And then, you're right, this area does look
Yeah.
slightly ulcerated. I'm still going to plan on performing resection, especially if I can suction this adequately during my procedure today.
Just one comment. I mean, I think it's wonderful how you show the details of the mucosa, and it really highlights extremely well what is abnormal or irregular as compared to normal. So that's something we kind of want to find in somebody who has Barrett surveillance. We want to identify if present. So you really got to take the time, and I think it almost looks like the second case now. It almost looks like, okay, we see that a lot, but we don't see that a lot in our routine cases. So it's also important to understand what's normal. So everything else there, how regular that looks, and this is all normal, and then you see the clear difference in the pit pattern or in the mucosal pattern.
Hey, Sachin,
Thanks, Heiko.
Sachin, we were
Yeah.
thinking of going to another room for the case presentation. Would that be
Oh,
okay and
absolutely.
come back to you?
Yeah, let me tell you what I'm planning on doing.
Yes.
I'm going to mark the areas of nodularity, what I want to resect today, get everything ready. And if you're ready to come back to me, I can show you resection.
Wonderful. Thank you. That's a great overview of excellent inspection. Thank you, Sachin. Okay, we're going to
My
go to the
pleasure.
next case presentation.
All right, this is patient AR for a colon EMR, a 42-year-old female who underwent a colonoscopy due to a family history of colon cancer and change in bowel habits. A 4-centimeter hepatic flexure polyp was found. Biopsies were not taken. A tattoo was applied and now referred for EMR. You can see some pictures from the previous colonoscopy.
That tattoo's a little close. What do you think?
Yeah, I know. It did look a little close.
All right. Hi. Can you guys hear us
Hi,
okay?
Doug. We can hear you and see you. It's excellent views here we get of you. You look great,
Good.
as always.
Good. Good. Thank you. I know you're lying there, but I appreciate it. First of all, I would say I have a nice short scope. I think this lesion is in the hepatic flexure, and that's one of the most important things when you're taking off lesions in the right colon is to try to keep a short scope. And we've got about 50 centimeters of scope in the patient, so I feel like I have good control of the scope and the situation. So this lesion is a granular. I would characterize it as a granular Paris 2A. I don't think it has an important nodule in it. And if you look across the surface of it, you can see that the vascular pattern is, it's very nice type 2. If you like the JNET classification, I think it's all JNET 2A. I don't think there's anything here that is particularly concerning for high-grade dysplasia. And so we've been having a discussion about whether I do think it's a fine candidate for EMR, and our choices here would be conventional inject and resect EMR, which we could do either hot or cold. I don't think it's really flat enough to take it out cold. And so I guess because it looks like a lesion that we'll be able to close when we're finished, my tendency would be to take it out hot, get the benefits of a low recurrence rate. Underwater is an option here. I was mentioning earlier that I really like underwater for non-granular lesions. I tend myself in my own place for granular lesions like this to do conventional inject and resect. Now it's a little bit of an issue here that makes underwater attractive because this actually has these redundant areas in it. It's sort of like folded over itself. And you can see down here, it's kind of folded over. But when that occurs, this lesion is going to tend to expand really substantially as a result of injection. I don't think that makes it wrong to do it, but it's an advantage for underwater in this setting. My guess is there isn't a lot of submucosal fibrosis here, and I think when we put fluid in, it's going to expand quite a bit. The other thing is I think the defect is going to be larger, and it's actually going to change probably our closure approach. It may be harder to get across the defect with conventional clips. We may need a closure clip or a suture, an X-Tack suture. Most of this is the liver, but it looks like there's a bit of tattoo here. In the pictures, I actually thought the tattoo had been placed right next to the lesion, but I don't think that it was. And I said I had a short scope, and then I just fell back. So let me work my way in there. But at the risk of having Ken give me a hard time the entire case, I'm going to do a conventional inject and resect EMR on this, or at least that's my plan. Now, I will say, I could always, if it becomes a nightmare, I could get in the middle of it and switch. I mean, I've done that before. You can switch over and change your approach. You could even take part of it out. Amy, let's go ahead and put the needle in. I'm going to inject here. I don't think there's anything here. Needle forward. Yep. And we're using a 25 gauge needle, which is usually injecting now. And right away, we're seeing this thing expand. Oh, sorry. Needles forward.
Doug, I'm just want to ask Ken, because he's in favor probably of underwater EMR. It looks like the lesion is going over 2 folds. Would this be something you would be concerned about, Ken, that you might get too deep and maybe cut inadvertently too deep?
Let's go ahead.
Well, the first thing I want to say is that, and I actually will be speaking about challenging dogma, so I definitely don't want underwater to become the new dogma. I'm not dogmatic about it. It's just another tool in our box that we can do submersion. And one option would have been just to sort of say, let's submerge this and look at it and see how it floats. And it doesn't have to be on block. I always strive for on block, but it may be attempted on block with trimming of the parts that I can't get on block. So with 2 folds, it may be then that it will be 2 pieces, maybe 3. So it's really just about how well it's floating up. And you can really get a good feel for that. Sometimes I'll close the snare, look and see how, tent a little bit and see if it looks like I'm pulling the wall away. So these are all maneuvers that are part of the procedure before you just commit to saying, I'm going to now step on the pedal and cut through.
I don't think I would be able to get it out underwater on block. I'm not even sure there's a snare. I might need a little bit of just maybe some pressure on the abdomen. Maybe I'm overinflated.
Yeah.
You close that just a hair, just a hair.
How's that?
What snare are you using, Doug?
Yeah.
So once I get the snare underneath here at a good starting position, I'll try to push the snare into the blue.
Dr. Rex, Roger's asking what snare are you using, and I guess we can ask how you decided to pick that.
So, okay. Yeah, okay. That feels pretty good, Amy. I'm using a 20 millimeter Boston Captivator. And so there's our first cut, which is always an important cut. And we're in the submucosal space. And let's open again, Amy.
Doug, did you ask for rapid closure or did you slow closure during the cautery? And if you could mention the cautery setting now, is this an endo cut?
No, I do want to talk about that with everybody. Close again, Amy. So I'm actually using forced coagulation current. I don't know if you can see Amy's hand, but I'm asking her to squeeze the snare pretty tightly. The goal here is to have a rapid transection, but you can achieve that in one of two ways. One is to, I'm checking over the top to see if we're injected pretty well. Let's go ahead and get some fluid again. So one is to close the snare fairly tightly. When you do that, you increase the current density in the snare, and that will make your transection faster. The other way that you can get a fast transection is, of course, to use cutting current. So I used to use EndoCut all the time. I was a huge EndoCut fan, and I think most of the world still is. But you know, we did a randomized controlled trial in the US. Needle into the patient now, please. And it's the only real randomized controlled trial that there is of currents. And injecting now. And as I inject, I'm just lifting a little bit toward the center of the lumen. You can see we'll start on the rectal side of the lesion, and you can see how well it's lifting, just like we said. I mean, this thing is lifting like gangbusters. And so one disadvantage here when it's going over a fold is that we might push quite a bit of it over a fold. Needle back. I'll take the snare back now. And that would change our approach. This is lifting so well that we could use even a bigger snare. In fact, could I get a 25 millimeter snare? I often tell people, you know, try to stay with 15 and 20 millimeter snares for conventional EMRs. As Ken talks about often, when you're using it, when you're doing underwater, you don't do that as much. And oftentimes you're trying for an en-bloc resection and you want to get a really big snare. But for conventional EMR, it's usually better to stay, just from the standpoint of trying to avoid muscle injury. Open all the way, Amy. It's usually better to stay with a little bit smaller snares, but this thing is lifting so well that I think we'll get done faster and not, okay, let's go ahead and close. We'll get done faster and we'll still be safe because this is like a super lift. Amy's putting a nice squeeze on that. Okay, so if you look at our randomized controlled trial, Heiko's the first author, so he can speak to this. I don't know really what his feelings are, but in my opinion, open forced coagulation current flat out won that trial for a couple of reasons. First, there was no difference, close, in the risk of delayed hemorrhage between the EndoCut and the forced coag arms. So unlike the dogma that we've kind of lived with for, you know, a very long time, so we got a little bit of bleeding here, so I'm just going to just check and see if that's from the surface of the polyp or from the submucosa. The submucosa tends to bleed less than the surface of the polyp. I think it's from the surface of the polyp. So there was no difference in delayed bleeding, open, and the traditional teaching with EndoCut, the rationale for EndoCut, was that you had less thermal injury, okay, close now, to the submucosa, and consequently, you would have less risk of injury to a deep submucosal vessel, and you would have less risk of a delayed hemorrhage. And that, open, is all based on old data when the generators that we used had fixed output. You put them on 20 watts, they delivered 20 watts. Closing. So we now have microprocessor controlled generators that adjust the amount of power to the resistance that they're sensing. Open. And in that setting, and both arms of that study were microprocessor controlled currents. There was close. There was no difference in delayed bleeding. And the difference in immediate bleeding, which was higher with endocut, can I get a 10 millimeter snare now, was statistically significant. So you deal with more immediate bleeding when you use endocut, and with no advantage in terms of delayed bleeding. Now, the other thing about the study that nobody talks about is that there were 3 immediate perforations in the study, and all 3 were in the endocut arm. And I am absolutely convinced that when you're on endocut, if you have muscle in the snare, there's much more of a tendency for the snare to go through the tissue without anybody saying anything, like I feel some resistance, to cutting through this, or the tech saying something's wrong, than with forced coagulation current. And I certainly have had the experience of, being in some awful situation where I have a huge amount of polyp in the snare. You get the 10 millimeter hot. I think there was one right over there. I want a hot 10. I think it's over there in the stack. I'm just going to switch to clean up the edges here to the hot 10.
And what lifter?
We are using a lift called Everlift, which is a cellulose-based lift, and it has the color understanding which is methylene blue, and it has a nice concentration of methylene blue in it, which is kind of why I like it. Any luck with a 10?
Hey, Sean, are you able to switch microphones with Dr. Rex, or would that be kind of odd? I wonder if your microphone might work a little better.
Yeah, is the microphone not working?
Yeah, yours is, I can hear you a lot better.
Hold on one second. We're gonna switch you
over. Okay.
A little audible here. We have Dr. Bala here who joined us recently, and please don't consider this to be a new normal for you, Sean.
Switch to. Okay, we can finish up with that. You have what? Okay, that's fine. That's fine. And we have a little bit of bleeding here, so when we go over to stop that, we'll use the snare tip on soft coag. Anytime we're using the tip of the snare, whether it's to stop bleeding or whether it's to treat the margin of the lesion, then rather than using forced coag, which is what we're using now, we'll use soft coag. So I was mentioning open now. So this is just a little bit more, a little easier to deal with for a small amount of tissue. Closing. I hope that's going to dig in. Yeah. It got it. Good.
Dr. Rex, you've kind of switched between snares pretty quickly, and kind of earlier in my career, even as a fellow, I would stick with kind of one snare.
Could I get the snare tip on soft coag now? And I'll switch back to my other snare if I could.
How quickly do you move to your next snare? It seems like you just, you kind of move towards efficiency to kind of get what you need to get done.
Well, I realize we're maybe using an extra snare, and I try to be careful about costs and using devices, but I figure, we're trying to, when we take these lesions out endoscopically, we're trying to save the patient surgery, and I think the cost of another snare to be comfortable with what you're doing. Now I've switched over to soft coagulation current. We've got a little bleeding here, and I'm just going to touch that with the soft coag current, and that should take care of that. Now, if we look across the base, I'm pretty happy with the base. Is there anything here that anybody thinks I should avulse that's not dead? Why don't I do that? Could you give me the hot forceps just for a minute, just to demonstrate hot avulsion, and then we'll come back and cauterize the base. So you have these little cords that you get of tissue, and the question is, could anything be surviving on there? And I think in this case, probably not. But We'll just demonstrate hot avulsion real quickly. I was mentioning that earlier that, you know, that I certainly have had the situation where, especially when you have a big sessile polyp and you're trying to take it and, you know, there's a lot of fibrosis and you're stuck and the forced coagulation current won't go through and you switch over to endocut and all of a sudden, bam, you're through the muscle and everything and you've got a perforation. And I think endocut, so okay, so now we have switched over to endocut eye. Let's say that I thought that there was some residual polyp here. So we'll open a bit. So we're going to grab it, but we're going to do hot avulsion. So we don't necessarily want to grab, you know, like shove it in and get a huge amount of submucosa. Rather, we kind of back off and now close Amy, and we'll try to be a little, we're just overlapping the submucosa. Then we're going to put a bit of tension on the tissue, a stretch of the tissue, and then we just tap the yellow petal, and it tends to come right off. Open. Maybe I can do a little better getting that little fibrosis off there. Close. Okay, so I got a little bit more there. I stretch it a bit and just tap the yellow petal, and it just comes right off. And now you can see we've got a nice flat surface where we had that. Will you empty that for me now? Do you
What were
guys feel
your
like I should
settings there,
avulse the rest
Doug?
of that? I'm not sure I do. So
What were
I'm
your
using
settings for that? Yeah.
endocut eye on the 141 setting. So when I was talking about snaring, the snaring current that I'm not crazy about with endocut is of course endocut Q. And endocut I is a lower voltage current that, and we're using almost pure cutting endocut I. We have it on the 141 setting. And so, oh, okay. Okay. Yeah. Once we'll do this one more time, then I think the base is in pretty good shape and we'll go right to our treatment of the thermal margin. So let's say we've got this tissue and that may be open. Maybe that was a little bit of polyp that I didn't quite get out. So close. And you notice I didn't shove the forceps up into the tissue. Rather, I just tried to overlap the submucosa a bit. You want to try to get, now I'll take the snare and we'll switch back to soft coag. Okay,
And then
so I think
Doug, you're going to
yeah,
treat the margin with cautery,
yes.
and you'll use soft coag on the
Yeah, we're gonna,
margin with the tip of the snare. And then we're going to switch over to Dr. Wani's room and then come back. Are you planning to close this defect or is that a point of
sure.
discussion? Okay. So
For
we'll
sure.
come back
No,
and
we're gonna
watch some
close
of that. Thank you, Doug. It's excellent. You did that so fast. That's amazing. Thanks so much. We'll be right back with you.
you.
Sachin, we're live with you if you can hear us.
I can hear you. How you doing?
We're doing great. We're just, we see that you're in the middle of something.
Yeah. It's so funny that you know, the resection was going just fine. We've pretty much resected almost the entire area of nodularity. By the way, the technique that I used was the multi-band mucosectomy technique using the Cook Duet kit. And we've done about 4 resections. And just after the 4th resection, the patient got a little bit of bleeding, which we are trying to take care of post-resection.
When you did the band technique with this mucosectomy, do you put one band on and then put the snare through that same system, resect and then
Correct.
band, or yep?
Oh yeah, yep, exactly. So you can see that there is a spurter there, right? Do you
Good
see that?
timing to come to you, yeah, because we all like to
Yeah,
see how
perfect.
you manage this. This is good.
Yeah, I'm gonna
No
try
edited
and
video here.
yeah, so I'm going to have to use the tip of the snare again here to manage this. If not, then I'm going to come out and go with another scope. I think this is a large vessel, so I'm going to come out with the kit here and go with the scope and distal attachment cap and use the coag grasper to manage this.
Do you want us to give you a break and go back to Dr. Rex, or you want us to stay with you?
Yeah, if you want to go back there, I'm going to change my scope really quick, and then you guys can come back here.
We'll go back to room 16, please. With Dr. Rex.
Can I
Doug,
get the
you're back live. I don't know if you can hear. We're back with you live, Dr. Rex and Bala.
Okay.
Okay.
Can you hear me okay?
Yes, we can.
Okay. So when I watch people do this snare tip thing, let me first of all address the issue of why are we doing this? We're doing this because we have multiple now randomized controlled trials and very large observational studies that indicate that we can lower the risk of recurrence by 75 to 80% by doing thermal treatment to the normal appearing margin. So before we do this, we first should be satisfied that everything has actually been resected. We are not ablating any polyp tissue. We are rather treating what appears to us to be a normal margin. The lesson of this is that most of our recurrences must be actually small amounts of polyp tissue and cells that we don't see, but which are surviving at the margin. And so by doing this, we lower that recurrence rate. So you can do this with either IPC or with the snare tip, but the snare tip is much less expensive. It's actually faster because you're in contact with the tissue, and it works just as well, if not better. So it's really the method of choice is the snare tip. You really probably shouldn't use APC. Okay, and the thing I see that I think people are, a mistake I make when I watch people do it is they're not aggressive enough. You really got to get, your target is the very junction of the defect and the tissue. And you've got to be aggressive in frying it. You're using soft coagulation current. There's no evidence. Okay, I'll take the mantis now. There's no evidence. Will you guys take a picture of the defect for me? Oh, yeah. I can't help myself.
That looks really nice. Definitely get a nice picture of that. So you're gonna close this clip. I think we're gonna quickly go, or close the defect, not the clip. I mean, you'll close the clip too, I get that. We're gonna quickly go to Dr. Wani. He's got a little bit of vessel action here. We'll be right back to you, Doug.
And then I'm gonna switch to
We're gonna switch to room 15, please. All right, Sachin, we're back with you. Always catch you at a good time.
Yeah, Momin, you can speak.
Can you hear us now?
Yes, we can hear you.
So, so we're dealing with an active spurter right there. You can see Sachin is just using the coag grasper with soft coag current. Now they have good hold on the vessel, and that's actually a good sign. So it's expected when you have a good hold that you do not see bleeding even before applying electrocautery, which we were seeing that. Now we applied electrocautery and the bleeding stopped. So that's a great control for the bleeding.
Our
now,
heart rate went down too.
What is that?
I said our heart rate went down with Sachin's heart rate
That's good.
just now.
Perfect. So we're all synchronized here. I like that. So what Sachin is doing also is looking for any other like oozing vessels. Just since we have the coag grasper, we can always kind of clear any vessels or any other vessels that might bleed afterwards.
The visible vessels you see here, is it a different approach in the esophagus compared to, say, colonic EMR, and you see submucosal vessels? Do you have a different algorithm?
Yeah, no, some of us who focus on esophageal diseases, we're just not as smart as the colorectal guys. So we just basically use the same principles from the work that they've done. And they've obviously shown that you don't need to treat visible vessels after you've done resection. So I use that same principle, unless, of course, you see what you just saw. Open, please.
And before that spurter also opened up, we were talking about Purostat and the possibility of putting that as a measure to prevent delayed bleeding after we do this. So I wonder what's the panel's experience and opinion about using Purostat for prevention of delayed bleeding.
Yeah. So as you guys think about that question, I just wanted to show you, Heiko and Raj, you had brought up really good points about that area of ulceration and whether that would be able to, be sucked into our cap and impact our resection in any way. Thankfully, it did not, and we were able to suction. I'm not done with my resection, by the way. I'm still going to continue. I don't like this area, so I'm going to remove this as well. And now that the bleeding is controlled, my next step is to just see if there's anything else that's bleeding. And okay, there is right there. Can I get the coag grasper again? Well, before I pass the coag grasper, in case you need to go somewhere else, let me just show you what we've done proximally as well. Remember, I'd shown you an area of subtle nodularity in the proximal portion as well. So we were able to resect that area too. This thankfully did not bleed. What I also did, by the way, is once I finished resecting this, I did this first, and Momin brought up this question, do you go proximal to distal or distal to proximal? I like to learn from my cases. I want to know what the pathology comes back on this. Was this all just related to uncontrolled reflux, or was it related to high-grade dysplasia? So I resected this, grabbed the piece, and I put it in a separate jar. And obviously, I've got a separate jar for this area that I've resected here distally. Sorry, you can go back to the question that you asked about how to prevent delayed bleeding.
Is anyone on the panel having any opinions about the use of Purostat after resection?
Well, we don't know. This is Ken. I wish we're waiting for more data, and obviously a randomized controlled trial would be ideal. But I give the patient the benefit of the doubt, and if I can't close a defect, I will put Purostat on afterwards after doing ESD or as you're doing
Ken,
here,
you don't close the
EMR.
defects. You don't close defects in the esophagus, do you?
Smaller ones, I might. Yeah.
Okay.
Depends where it is. The closer to the GE junction, of
Open?
course, you have to be more careful.
Yeah. Okay, close.
Yeah, I don't think the data on Purostat is that good so far from case series in general for prevention of bleeding. But Sachin, I have a question related to your choice. So some people might have argued in ESD to trying to have an unblocked resection might have been an alternative because it's hard to predict if there is cancer, how deep the cancer really is. And so to give the opportunity to a patient to have an unblocked resection with free deep margins might have been a different choice. And the other related question is actually, do you prepare the resected specimens for the pathologist to make, to have a good exam in terms of deep margins?
Yeah, that's a really good question. And Heiko, this was something that we addressed in our most recent guideline document that, again, I encouraged fellows to read. These were guidelines that we developed through the AGA on endoscopic eradication therapy. And there are clear indications as to when you should be considering ESD. So obviously large, bulky lesions that have a combination of 2A plus 2C, which you can argue that this lesion may have, and obviously areas of depression, also lesions that have been worked on before. And we get some of those in our practice that you cannot perform resection on. These are all great candidates for ESD. What I think is important to recognize, Heiko, I know what you're getting at in terms of the oncologic principles. I think it's important to know that all the studies that have compared EMR to ESD, while there's a difference in the R0 resection status, there's really no difference in the endpoints of complete eradication of intestinal metaplasia or recurrence rates when these patients are followed after they've achieved that endpoint. So I keep that in mind as well. But if there was any concerning feature, or if I felt, Heiko, that I was not able to suction this lesion, then by all means I would not have persisted, and the next strategy would have been ESD for this patient.
Thank you, Sachin. We're going to go quickly to room 16.
Perfect.
Dr.
Thank you.
Rex, we're with you live.
Let's clock.
Doug, we can see you. I don't know if you can hear us.
I think we can
I
hear you
can,
now.
I can. Can you
Okay.
hear us okay?
Yeah.
Okay. So we've been waiting on doing the closure here. We finished our snare tip soft coag. We have a clip here that we're going to use just because the defect is a bit wider. I actually think we could close this with conventional clips. If we put a clip across here and another clip across here right in the submucosa, and it's important for people to know that there's no problem with putting a clip with both ends of a clip right into the submucosal defect. If we had a muscle injury here or a perforation, we might well need to do that, and that's perfectly fine to do that. And if we put a clip across here and across here, that probably would draw the edges together enough to then be able to finish the closure mucosa to mucosa. In this case, we're going to use a closure clip. This is the Boston Mantis clip. And Amy, if you'll open the clip, and could you turn it sideways for a second? It's got some sharp teeth on it and kind of a hook down there, okay? And we're going to use that. Now, turn back straight up and down if you would. People usually describe grabbing one side, but when we're tangential to it, we don't necessarily need to do this. We can sometimes just grab the thing and then drive forward slowly,
Repeat,
keep
please.
a little forward pressure on the scope and suction and have it rotate toward us. Now we have to check and make sure we've gotten everything to come with us. First position now, don't close it, but just close. There you go. Yeah, let's fire that. I think we've got both edges there. We don't want to slip. And you can release now, Amy? Okay, now I'm going to switch over to Cook clips if I could. So Instinct Plus, yes. So that first clip, if you are tangential to the lesion, this is true when you're using conventional or just regular hemostatic clips. A lot of times you want the clip to be open and to be oriented in the up-down plane. And then you use the lower jaw to force the tissue down and get it to turn toward you. But what this clip has accomplished for us is to bring the edges together so that now we can go mucosa to mucosa with our regular hemostatic clips. Open now, and we'll kind of orient that like a little bit like 1 o'clock to 7. I'm going to go on this side of this clip. I want to get in between there in this gap, and now we'll go mucosa to mucosa. And this clip is the Cook Instinct clip. I like this clip because it, first position and fire the clip. Okay, and then we'll take another one. We'll just stay with Cook Instinct now. Yes, it has very strong arms. When you push on the clip, the arms won't bend. And then secondly, the jaws are long. They're 16 millimeters. But also another feature that's useful is that the clip opens very widely, and that can be an advantage. So I think this is a good clip. A lot of different clips open will work. And here we're going to sneak in between this fold that's in our way. And we want to use a little pressure to turn the defect toward us. First position and fire. Fire. Go ahead, fire. Okay. And now that vessel right there, that's probably a vein. We have a couple of randomized controlled trials that have looked at, will you keep them coming, Amy, if you would? We've had a couple of randomized controlled trials that have looked at cauterizing those vessels versus leaving them alone And both trials were negative. They did not show that there was an advantage. Open. So the clips that the vessels that you think are going to bleed after the patient goes home are generally not the ones you're seeing. They're arteries. They're very small vessels, much smaller than those veins. First position there, Amy, go ahead and fire.
Thank you, Doug. We're going to go. First of all, congratulations. A great demonstration. You're going to continue to close the defect. Doug, thanks so much.
Thank you.
Beautiful case.
Thank you.
And we're going to go to the next case presentation. And before that started, I just wanted to give follow-up that the gallbladder stent got in, plus 2 plastic stents off camera. So that was done, and Sachin's wrapping up as well.
So this is another case. This is an EUS guided cisgastro on a patient with initials NG, 49-year-old gentleman with a history of idiopathic acute pancreatitis in 2017. A CT from June of this year demonstrated a large cyst in the tail measuring 9 by 11 by 10. There was no imaging between 2017 and 2025. No known history of gallstone disease, no alcohol. Patient does smoke daily marijuana. Triglycerides and calcium were normal. Currently reports intermittent left upper quadrant pressure associated with shortness of breath. A CT from August showed that the tail fluid collection was 10 by 9 by 16, so it looks like a little bigger, with superior displacement of the gastric body. The splenic vein traversed through the posterior portion of the fluid collection. You can see some of the representative CT images there. And you can see the splenic vein being pointed out there. I think we're live here.
Colin, we're live with you. Can you hear us? We can see you.
Fantastic. Can you guys hear me?
Yes, we can.
Welcome. And what a really fantastic number of cases that you've been through this morning. It's been a fantastic sort of live session so far. So congrats. I think you have met the team, but we have Alison here is helping us with anesthesia. We've got Summer, we've got Lindsay, and then obviously I think you all know Ryan, who's hopefully going to be able to field all the questions for us. So I mean, you can see on the endoscopic view at the moment, one of the things that we were concerned about was that splenic vein, and we chatted a little bit about it, and hopefully we can go into it here. But you'll see that actually, and it's quite often very common that CT overcalls these things, because you can see on the vasculature, I'm just highlighting, then you know, more often one worries on CT about these, but you can actually see that there's a beautiful pseudocapsule that's very well demarcated and you know, protecting us from those vessels. Coming back to the sort of the trainees that we had yesterday and through the sort of hands-on cases, you know, one thing that I pointed out and I sort of tried to get across was really taking your time and have a look at the cyst, because, you know, when you're doing lumen opposing stents, one of the initial concerns was obviously bleeding. And you know, to a large extent, you can negate that through good endoscopy or echo endoscopy, making the appropriate call, because the stents in themselves are actually very safe and fantastic sort of instruments for us. So you can see there, I'm just pointing it out again, and the color, beautiful. We protected, and one of the concerns with these sort of distal interface parenchymal vessels is twofold. The first is on decompression. When you place the stent, if you have, you know, a rapid decompression, there's the conceptual idea that you might get bleeding from this at that stage. Again, you're probably not going to pick that up from your stent, because you're protected with this pseudocapsule, so that's going to be outside of it. But more frequently, you know, in the learning curve with these stents, when we left them, you know, more than sort of 4 weeks, the incidence of bleeding increased. And that was really because the cyst had now collapsed. These stents obviously do have a flange, and there was this idea that that flange would rub against the now collapsed distal wall, and that predisposes to bleeding. So you know, first of all, take a bit of time, go through your entire cyst, make sure that you look at the entire cyst in entirety. Again, with regards to where do you zoom and how do you assess it, I think initially make sure that you have your whole cyst in view as much as you can. So increase the depth and have a good look. One of the things that catch you out sort of day 3, day 4 bleeding is your intracystic vessels. So sometimes, especially with necrotic collections, you can get vessels sitting within the actual necrotic collection, and you know, if you don't pick up those 3, 4 days later in the ward, that patients or if they're at home, can bleed. And then last, I think, is obviously the interface. Let me take off. Well, we can zoom in here. Your stomach tissue cyst wall interface. So again, we've got so many windows here to be able to go through. You can see the muscularis propria, which is a hypoecheic line there representing the sort of the gastric luminal component, and then in the very obvious cyst wall. And you can see very nicely that we don't have any major blood vessel in here. So we really, I mean, this is a fantastic lesion to be able to drain. And we chatted a bit, Ryan, unit and myself have slightly different practices. And again, I think a take-home message for the fellows is that people do things differently as long as it's done safely and that you understand why you're doing it, then that's great. So in my unit, we don't routinely place coaxial plastic stents unless it's needed. I know there is data, although it's equivocal. There was a meta-analysis, I think it was in 2023, that sort of suggested there was no difference in adverse effects, bleeding being one of them. But subsequent to that, the Polish group, I think they've showed that it does reduce bleeding and potentially food impaction. So there is a role for it, but we don't routinely place double big tail stents or do the coaxial placement. Ryan, I don't know if you want to jump in here because again, I think it's important to hear both sides.
Yeah, we tend to place double pigtail plastic stent, either 2.7 French stents or 1.10 French stent, depending on the size of the collection and just kind of overall patient level information. But I think our biggest goal with doing that is, as Colin mentioned, preventing food in, potentially preventing kind of refluxing necrosis from obstructing the stent lumen in patients with a true burden of necroma. And then also to use it as a bumper both on the opposite gastric wall and then on the contralateral cyst wall as the collection kind of collapses, particularly in a collection or a mostly fluid-filled collection. I think it may be a bit more important.
Yeah. So again, there's sort of, I think there are, for us, again, there would be indications when one would definitely do it. And if you're on your distal sort of cyst parenchymal interface, you do have blood vessels and you're worried about that, we would definitely place it. And we have a lower threshold to place it if we have intracystic blood vessels. But apart from that, for us, we wouldn't.
Which stent are you gonna which stent do you think you'll drain with?
So Raj, I think, I mean, just again, from a teaching perspective, regarding pseudocysts, I mean, I'm sure the panel there will be able to debate a bit more, but regarding pseudocysts, not much data to suggest that plastic or lumen-opposing metal stents have a big difference regarding outcome. In ward-off necrotic collections, single plastic stents, I think there one could argue that lumen-opposing stents are better. If you're using a multiple gated way approach, it becomes more difficult to tease it out. Personally, I really enjoy the lumen-opposing stents, the conceptual idea about it, the ease of placing them, the quick procedural time that's associated with them, and in the unlikely case that you do have a complication, you have access to that cavity that you can manage it. So for me, we have a tendency towards lumen-opposing stents. They're obviously cold and hot systems. The one that we're going to be using today is the hot axius, and I think we're all very privileged to have Ken on the panel there, and which is fantastic, and there's going to be a lot of insight shared there. But for me personally, the biggest attraction to the hot axius is, number one, it's really easy to place. But number two, it's a one-man show. I have full control over my stent placement, stent manipulation. If I do need to troubleshoot, it's all in my hands. So it really is a reassuring stent to place, as opposed to the other hot systems. I don't know.
Sometimes, Colin, if I could add to that, just as you're selecting the stent and proceeding with it, would love to see that deployment. And I'm wondering though, I think sometimes when we consider potential for disconnected tail type of pseudocyst or disconnected tail syndrome, or if there's a question about compliance, the patient may not come back. Sometimes you can see delayed bleeds with retained axios, especially in the absence of a double pigtail stent. I might consider drainage with 2 double pigtails and just leave them in indefinitely in the setting of disconnected tail and the compliance piece as well. Are you going to go with a 15 or a 20?
So in this case, for me, it doesn't make much of a difference. I think if there was necrotic components to it, I'd advocate for a 20, but I think here we're going to go for a 15 because that's, this is very homogeneous. There's hardly any sort of necrotic material, solid components to it. So you're going to get drainage. Raj, I agree completely with your previous statement. I think important concepts to keep in mind is that potential. I mean, if you have something that's feeding the cyst, specifically if it is pancreatic fluid where you've got lipase in it, a fistulous tract after about a week and a half is going to be mature enough that if you had to remove that stent at that time, as long as you've got continual drainage in the setting of, for example, a disconnected duct, it's very unlikely for that fistulous tract to close. Remember, you've got this is a retroperitoneal component, so you've got retroperitoneal pressure gradient compared to your intragastric luminal pressure gradient, which is far less. So naturally, the fluid is going to want to go down the path of least resistance. The downside to it is that it can perpetuate that fistulous tract, but obviously it goes into the stomach and eventually it's going to meet the food in the duodenum where it's supposed to sort of do its job anyway, and it's going to work. But generally speaking, in my experience, these stents after 2 weeks in a pseudocyst, unless you've got necrotic material and it's collapsed, you can remove these. And if there is a disconnected duct syndrome, those tracts, because it's fistulized and epithelialized, that fistulous tract, and it's being continuously fed with lipase, is generally going to stay open. And it only resolves, like any sort of intraperitoneal cavity or collection with a fistulous tract, it only resolves over time from the inside out with resolution of that underlying cyst tissue, if it's not being continuously sort of fed by fluid.
I think the other thing, Raj, to your point about using plastics, and it's certainly good, and again, I agree, a lot of ways to do this. I tend to get more excited about using plastics in particular if we're talking about a cyst that's originating from the body or the neck, because there's going to be potentially a lot of upstream pancreatic parenchyma that you're trying to preserve. This looks like it's very distal tail. So in the event that you developed any sort of disconnection, it's probably likely that you're not going to lose a whole lot or have access to a whole lot of pancreatic parenchyma. So that's another part of this consideration. Certainly, cost profile is different between the use of an Axios and double pigtails. But when you think about, some of the ancillary services like anesthesia time, room turnover time, maybe getting another case done, there certainly is more time involved with double pigtail stents. So
okay, Colin.
I think you can make a strong case for both.
Exactly.
Colin, if you can hold just 1 sec on the cautery, on the delivery, we're just going to switch to Dr. Wani's room literally for 45 seconds. If we can go to room 15. Sachin, can you hear us? We have about 30 seconds if you want to show us your excellent work.
Oh, sure. Thanks, Raj. So just want to show you what the resection base looks like.
Looks wonderful.
Yeah, very nice and clean.
Yeah. Well, it wasn't clean at one point.
I mean, it was clean.
They came for NASCAR, they got it, and they saw it fixed, so that's great.
And
are you going to apply something?
Raj, yeah, exactly. So we're ready to apply Purostat to this mucosal defect to reduce the risk of post-procedural bleeding. Go ahead. Delayed bleeding.
And it's
And for
important
our
with this to make a thin coat. You don't want to clump it on too much because of the way of the action of the gel.
exactly.
No.
So oh, go
Yeah.
ahead,
Oh no.
sorry.
Go ahead. Go ahead.
So for our fellows, this is basically a self-assembling polymer. So as Raj said, you just want to have a very thin coat over the tissue, and once it touches the tissue, it assembles into this very thin layer, which acts as a physical barrier between the resection bed and anything that comes on the other side, and that's where it gets its properties theoretically in preventing delayed bleeding. I mean, it's FDA approved for prevention of delayed bleeding. Whether we have a solid data on that or not, it might have benefits from that side of things. And again, the risks from putting Purostat there are really very low. I mean, theoretically, anything can have side effects, but for that, it's very, very low risk. So we typically put it when we have large resections. Hopefully, it helps with that. And then there is some data that we were even part of with Dennis Yang. I was just talking to Sachin about that, about theoretically possibly having comparable effect to reduce post-resection strictures in the esophagus, comparable to the use of steroids. So it's not superior, but comparable. Again, it needs, as Dr. Ben Moller said, more like the best option will be like randomized controlled trials to have that, and that would fill really a big need there to help with the stricture formation after big esophageal resections.
We're good. Thank you so much. Excellent resection.
Thank
Great
you. Thanks, guys.
demonstration. We're going to go
Thanks.
back to Dr. Knoll with the pseudocyst to room 14, please. All right, Colin, you're back live. We're excited to see this.
So Colin, this is Ken. Before we see what drains out, I'm curious to hear your thoughts on what the contents are likely to be. You see that starry sky, echogenicities in there. What do you think that is? Debris, infection, hemorrhage? What are your thoughts? And will that also influence your choice of drainage approach?
Good question, Ken. I think to me, so again, always keep in mind a differential. So this could, I mean, in this case, not the case because we've had a bit of time to look at it, but always keep in mind that the gallbladder looks like this. So biliary contents can give you this because the sort of calcium bilirubinate that's in the sort of bile. So that would be one, but that's a differential. Then on here, you're generally thinking of potentially infected contents. One, and then the second would be bleeding, but this is not looking like that to me. I'm not sure if you have anything else to add.
I think this is going to be kind of our typical kind of brown tinged liquefied component. I don't, I would think that if this truly were an abscess cavity, we wouldn't have as stable of a patient as we're working with. Similarly, if there were evidence of recent bleeding, I think we would be able to have sorted out that, or at least be suspicious of it as well. Certainly in the setting of close proximity to any vasculature, you always have to be concerned about pseudoaneurysm. But Ken, I think we're going to see some kind of brown liquefied necrotic, component here.
Agree.
Yeah, and the abscess you can really sort of exclude, again, coming back to the pseudocapsule. So you often have almost a laminated sign with the abscess, if you have an abscess here. And it's a lot thicker. This is really looking.
And the setting that you have on the Irby system?
We have it set at AutoCut 5.0.
Okay.
On a Irby Vial 3, which I think is pretty standard what most people are using. Some people use 6.0 with AutoCut.
I started using 4 because sometimes the artifact that you get with the higher effect it makes it harder to see the delivery catheter, but I think in this setting,
certainly the
whichever.
smaller the target or the more delicate the procedure, that I think definitely comes into play, Raj. That's a great point.
Yeah,
Well, thank you. All right, Colin, let's see this.
Okay. So I'm going to take this really slowly. I've tried to get it into position that hopefully this camera can look at.
Yeah, we can see the delivery system. We can see your hands.
Fantastic.
And really, the
Okay.
camera work is just fantastic. Thank you.
The camera work is not me. I think that goes down to the unit here. So again, just going back to basics for the fellows. Obviously, I zoomed out as much as possible so that I could sort of assess the entirety of the cyst. But now really I want to focus approximately up top here. One big mistake that gets made is this. You know, when somebody really zooms in order to magnify the cystotome coming through. The problem is that in order to make sure that you're definitely deploying the distal flange, you really want to get that cystotome in sort of, or the delivery system into the actual cyst. And that can be anything up to 4 to 5 centimeters. So if your cyst allows it, your magnification is fine at 4 to 5 centimeters. But you really want to see that distal part of the cystotome so that you don't go through the posterior wall. And you know, that's important. Then, as we went through yesterday, 4 very straightforward sort of steps with arrows corresponding to which step it is. So the first step is we've obviously linked up the cautery system, so we are able to go. The first step is to unlock. You'll see number 1 with an arrow pointing downwards. And basically what we're doing is we're introducing the catheter. Obviously your elevator should be up, sort of, yeah, in the,
One point that I want to make for the fellows, the entire shaft of this delivery catheter is hydrophilic. So it's really important that as you're doing these cases and working with your team, that they either you or them lubricate the shaft of the delivery catheter, because I think as you have different positions with your echo endoscope, it can make a passage of the stent quite a bit easier. So something that not everybody always either remembers or recalls, but is an important point in terms of how the catheter is designed.
definitely.
And then are you going to try and tent this? Do you tent a little bit as you're doing?
I don't
counter?
normally.
Okay.
I don't normally. I can. But just coming back to that point, so this is a 3.7 millimeter working channel, and it really does make it easier because it's a hydrophilic sort of catheter sheath. Okay, so first step is unlock, and I've gone in, and you can actually see the end of, yeah, I can try using my elevator just slightly to move it, but you can see it over there. I don't sort of
We see that
put
really
too
well.
much onto it.
Yeah.
Okay, fantastic. So then again, now it's really controlled, it's slow, it's consistent, and basically down on the cautery, going in. And this is what Raj was talking about with regards to the artifact. So if I had to cauterize, you can see there the heat, it's the temperature differences. The higher the cautery, the greater effect you're going to have there. Again, don't keep cauterizing all the way through. Now your cystotome's through, stop the cautery so you have very little artifact, but I want to make sure that my cystotome and delivery system goes into that. You can obviously go all the way through, number 1, right down to the bottom. You don't need to. General principle is less than 2 fingers for me. I know that the distal flange should be comfortably deployed. So yeah, about 1 finger, lock it again.
You can disconnect the cautery.
Then I take off the cautery because again, it's at this stage that somebody walks on it by accident or and now you've got this little clip here, which really is sort of a safety clip. 2 is unlocking and pulling back up. So again, make sure that you've got your whole nice view of the entire system. Unlock, take it from the top, and now control, you're going to see the distal flange get deployed.
Nice.
You can see quite nicely now that the distal flange is deployed with an almost neutral bridge. If you had an obtuse angle here, it's quite important to just jiggle, sort of make sure that the stent goes through so that your distal flanges open up, optimally. There's my cystotome over there. Now, in the next question, number 3 is going to be to unlock and withdraw, okay? And then what I'm doing now is getting the 2 tissue interfaces, approximating my 2 tissue interfaces. So I'm going to unlock, thumb goes up, and what I'm looking for now is 2 signs. The one is that sort of hourglass effect. So as I come back, you'll see the cystotome, if I keep it in the middle, starts going up, and I'm putting a bit of pressure on my stent. These stents are very forgiving. The other thing that you can look at is, I'm just going to lock it here so that I can point, but really, at the interface between your bridge and the distal flange, you'll start getting a feel for it, and that comes with a little bit of experience. But if it becomes too obtuse, you're putting too much pressure on it. But this looks fantastic. And as I mentioned, these stents are very forgiving. So you can see I'm putting quite a lot of tension on it. 2 ways to deploy the proximal flange. You can either deploy it under echo endoscopic view or within the scope channel, which is a lot safer. And that would correlate to step 4 here. So again, unlocking over here, I'm now going to deploy my proximal flange. Okay, so I've deployed it. It's in my channel. So now to be able to visualize this and to get it out, basically I turn to, hopefully you can see on the endoscopic view, just a little bit of air. It's generally a counterclockwise rotation, and I'm looking for just the corner of that bridge, just to see. And what I can do is just help the stent out a little bit, and you can see there, hopefully, with my air, that there's the end of my bridge that you can see on the endoscopic view. I hope you can see that. And really, just to get it out the scope is deploying it like that. It might take a little jiggle.
Alex, can you confirm if
You can use the elevator up and down to help it out of the scope. But just pulling the scope back.
Can you
And
go to Ecuador?
okay, it's deploying it into the stent, I mean, into the, you'll see the deployment there. Now, I mean, this is not a very fibrotic wall. Good call on the fluid, by the way. Not a very fibrotic wall. But sometimes your cystotome can get sort of caught in the actual cystic, on the cystic aspect of it, and you can't get your cystotome through because of that little bevel that's at the end. It's really getting it into almost a parallel position like this, where when I withdraw it, you can see there, it's pulling up, but if I withdraw it perpendicular to the stent, it's going to come out without any issue. Okay, and there we got our drainage. Last thing, as I said, mentioned, I'm just going to quickly take this out so that we can show you. Last thing, you are going to decompress sometimes 5, 6, 7 liters. We have decompressed up to 13 liters before into the stomach. Your patient, you know, the best is really to help your anesthetist here. Make sure that you suction the stomach so that on extubation, why is happening here? There we
So,
go.
Colin, were you going to put a double pigtail stent through there?
So I wasn't going to in this case. Like I said, you know, I don't see the indication here. So I just want to quickly show on the endoscopic view. So here is my distal flange within the cystic wall, and you'll see my proximal flange. I'm going to try to show you my lamina propria here. There's my muscularis propria. So there, so I know that I'm proximal. I'm in the stomach. You know, obviously you can look at it on the endoscopic view. And now just a bit of patience and just suction all of this up so that your stomach's not full on when you withdraw your scope, and when you extubate, you reduce the risk of aspiration.
If it's simple enough, our preference is to put a double pigtail through, and I don't know, that's what we would do.
We're more than happy to do that if you'd like.
If it's simple, I mean, you pulled the delivery system out, but
so yes, Raj. So let me come back to that. So
now
if
it's
you are
harder
planning
because
to
a lot of
place,
fluid
exactly.
flowing.
If you are planning to place your double pigtail stents, before you pull that cystotome out, just run your guide wire over, because then you've got access. As Dr. Shaw's just, you know, quite rightly pointed out, now I've got a lot of fluid. I now need to aspirate all of this. But you can see under endoscopic view, just using your echo endoscopic view, you can really position yourself quite easily, and you know, that should be the flange there if I had to run something through.
Hey, Raj, I want to make 2 points for, in particular, the trainees or people who are going to build this into their practice. When we're teaching our advanced trainees about doing Axios, regardless of what type of procedure it is, we always do our procedures with a preloaded guide wire within the catheter. And following deployment of the distal flange, we have them pass the guide wire, whether it be the gallbladder or the collection. Obviously, in this collection, it's huge. You can see it from the moon. I get that it's probably not going to be of huge benefit, but I think it's good practice for them from the standpoint that in those cases where they struggle or have any sort of challenge with maldeployment, that guide wire might be the one thing that saves their procedure from potentially being catastrophic, or a phone call to a surgical service, depending on the indication. The other point that I would make is, whether it be a gastrojejunectomy or a fluid collection or anything where there's a lot of fluid that you're draining through your Axios, you need to have a very clear conversation with your anesthesia provider in the room that this fluid is going to continue to drain out even after your procedure. So they need to be aware that maybe it's not a great patient to extubate at all deeply, or maybe the patient should be very awake when the tube comes out, or sitting upright after being transferred to the bed. Those are all conversations that, you know, can prevent, you know, catastrophic things like post-procedure aspiration.
I would like to say that Colin, Dr. Knowles, visiting from South Africa, and maybe the middle of the night over there, and he has shown an excellent demonstration, very calm and effective means of draining pseudocysts. Ryan, Dr. Law from Mayo Clinic has provided excellent points on some of the techniques and tips related to draining these. We're going to congratulate you on this excellent presentation, demonstration. And we're going to move on to Ecuador. We believe they're on standby. Dr. Carlos Robles Madranda is on standby. And here we are. I think they're transmitting through Zoom.
So hi, how are you? Can you see me?
Good. We can hear you, and we see your wonderful symbol, and I think you have a patent on this symbol. It's very nice. From
Oh.
IECD. Oh, here we go. We see the case. We don't
I
see
will-
you.
Oh yeah, I would love to be there. It's amazing panel. Oh my God, too much rain there. Too much question today. That will be fantastic. So hello to everyone there. So let's present the case, please.
Do you want us to read it? We can read it for you.
No, yes, please.
Okay.
Better.
All right. Reading for CRM. This is a 72-year-old female with extrahepatic cholangiocarcinoma. The patient refused surgery. Their bilirubin was, I believe, 2.5. EUS showed gallbladder stones and irregular hypoechogenic lesion in the CBD. ERCP with RFA was done 3 months ago. And the proposed procedure today is AI-assisted cholangioscopy, ablation, and gallbladder drainage.
So hi.
Okay, Carlos, we can see you now and hear you.
Yes.
We
So
see a
this-
cholangiogram. Yes.
Yes, this is a cholangiogram of the patient, and this patient have contraindication to surgery, and we start palliative treatment with radiofrequency initially, and I would like that to share with you a little bit a different kind of approach that we are doing right away and right now. So we have almost 7 to 10 cases, I believe, that we start to do this protocol to change a little bit, because when we read the literature a lot regarding the radiofrequency treatment in the cholangiocarcinoma, it shows not increase in the survival, which is, I believe, probably because of the way that we made the protocol, to be honest. What happened is that if we understand how the cholangiocarcinomas grow up, it comes from the deeper part and it's not coming from the superficial area. And that's why it's very difficult, first, to have a pattern, and second, to have a pure neoplastic area. We have involved inflammatory lesions because of the disruption of the wall. And also we have fibrotic tissue. So it's a really complicated situation with cholangiocarcinoma, because in spite of we are now celebrating 20 years of cholangioscopy, right? Because of a spyglass, that's changed a lot the way that we are working now on the biliary tract. But the thing is, we'll still continue having problems between the visual impression, as you publish it a lot, Rash, right? And we already show it a lot of multicenter studies showing that we are not so good as we are, even being experts, to first to have a very good interoperability agreement between the experts, even in the non-experts, and AI has shown to be an assistant to diminish this kind of difference. And also in the last publication that we sent to DDW this year, we show it also that we increase the accuracy to 98%. We increase the specificity. We increase the predictive positive value. We increase the negative predictive value, making an accuracy of 98% in clinical practice. It means AI will help the physicians to know where we have to take the tissue and the biopsy. That's why the study with the new forceps from Boston, for example, the Boston Scientific, the new forceps, it didn't increase the histopathological accuracy. And the problem is not the biopsy, it's the site where we are taking the biopsy. But well, I talked too much today. I am showing you, you are looking here. So we are in a part that normally we didn't have, extension of the lesion. So now what we are doing is just treating cholangiocarcinoma in this patient in a palliative treatment just by plastic stent and radiofrequency each 4 months. So the results are very interesting because the 7 first patients in the protocol are still alive after 4 years. So it means probably the way that we are treating cholangiocarcinoma is not the right way, and radiofrequency probably just one ablation is not enough. And it's something that came from Dr. Juan Manuel Alcivar that is just right in my side, but he didn't want to talk, he didn't talk too much. But it's amazing situation, and I believe that will change a lot the way that we are doing. So what I am seeing now is extension of the lesion, so I need to take some biopsy from this area. I believe this is cholangiocarcinoma that is appearing now. So I am in the distal part just near, you see here. So this is almost normal tissue here. Okay. So you see the AI is not showing, it's showing some small areas, but these are more interesting area because this is a disruption area that it doesn't appears before. And now I'm trying to go in down because I want to see what happened with my first radiofrequency that I had. So you can see this part down is much better. We have some tissue here again. You see here, you can see very well.
Some of that detection, Carlos, of the AI could be related to mucosal trauma. I saw some blood or clotted blood hanging down, and it did detect that. I see this area to the right that
no, it's not
maybe they're
detecting
saying
blood. No, it's not detecting blood or bleeding because if not, the highest part at 12 o'clock it will show it. You can see that. So it show it a little bit. Just it's not based on bleeding. It's based on three histomorphological characteristics that are more typical, based on all the classification that has been proposed. But we see that there is still cancer because we are not making a cure of the cancer, but it's very well controlled because I cannot see. You see the superficial area after 4 months after the first radiofrequency here. You see, so there is still areas that we need to retake, and that's why the principle of this new proposal for giving a treatment, a palliative treatment in cholangiocarcinoma is the way that is coming from down. Each certain time it will reappear because you burn the superficial area and it disappear, but the cholangiocarcinoma is still there. That is the
I see,
principle.
because
Okay.
of the post RFA, you're saying
Yes.
that.
This is the
So I
post
think
RFA.
some of the detection is not typical just for the audience. Some of the detection is not always is not classic for neoplasia. Like some of the vessels are prominent, but some of these at 6 o'clock that you were just coming into do look very typical of tumor vessels. Just for the
So
audience, I'm bringing up there's some
yes.
ulceration, some friability. There's also infiltrative stricture present that you just passed by with some partial lumen occlusion. I think all of us who don't have AI capability, just as a teaching points to bring up neoplastic,
Yeah.
things to look for. Like I think these
So
areas at 9 o'clock, these vessels, they are dilated. There's tortuosity to them.
yes. So the neoplasia, the cholangiocarcinoma extension was until here, but now I can see this part that I believe is a new focus here. You see? So I need to go a
Yes.
little up. And the second thing is that I came back because I wanted to see the cystic duct. It's completely occluded. So it means this is a typical patient that have problems. She start to have some pain in the gallbladder. So there is no draining. It's not coming out. So the gallbladder is we need to drain also because the cholangiocarcinoma is taking the whole biliary tract. So I will take a
That's a
biopsy
nice
now.
vessel there at 9
Yes.
o'clock.
So now I will take a biopsy from this area, right? Because this is a new area. And I will make a second radio frequency. I will make a second look that we are doing now. Less a plastic stent, and then going now and coming back with one of the best invention of the last 50 years, the hot axios, right? So I like it, and I will try to make a drainage, because this patient will start to make a cholecystitis. She's starting to do a cholecystitis. So it's because of the occlusion, and there is a lot of papers. So we were the first one publishing this about this situation, about the compromise of the cystic duct when there is this kind of tumors, Abre. So now
Carlos,
I
are
am
you suggesting, sorry, are you suggesting that you're going to prevent it or prophylactically place lambs into the gallbladder,
Yeah.
or just that would be an option if
No,
she
no,
were
no.
to?
No, I'm doing because this patient first is already having some pain.
I see.
So second, I know that it's completely occluded, the cystic duct. And third, she will do for sure now cholecystitis is because of the occlusion. Okay. Okay, Sierra.
So it sort of opens up the options here for treating with the RFA, because typically we would be concerned about involving the cystic duct and cholecystitis. And your point, and I'm slow to learn, which is why I'm reiterating this, is that because of the tumor infiltration of the cystic duct and symptoms, is justified to plan a lamb's transduodenal ideally, and then do the RFA that you think is appropriate, necessary.
Oh yeah, for sure. So moreover that this patient is under protocol now evaluation. So she's doing very well, and the quality of life of the patient is nice. So abre. So I am just trying to keep a good biopsy from this area because I don't want to burn something that is not. But I 100% that this is cancer, Sierra. So it's
And it's
very
a nice
important.
example of a tumor vessel,
Yes.
audience.
And the other thing is what I believe the role of AI in the future here in cholangioscopy is not to say us if this is cancer or not, or maybe, but I believe it's much interesting to show us where we need to take the biopsy, because when we train in this AI, we remove all the fibrotic tissue and all the inflammatory tissue to train, based on histology. So this is why the accuracy, how to increase the accuracy, because you need to remove all the fibrotic tissue, inflammatory tissue, as you already mentioned, Aure. You already mentioned that sometimes when you have inflammation, you have these vessels that are big vessels, but this is not the shape of the vessels is very important in this kind of cases, right, Sierra? Okay, perfect. So perfect. Now I will lay a guide wire here. I will try to see where I am. So here is okay. Okay. Now we'll take a picture here. Yeah. So I will pass my guide wire. I will try to select the left part that will be the right one. Empuja. Okay, so now I'm here. Okay, so I am in the left part, you see here, in the left intrahepatic duct, because I want that my radiofrequency goes there and make the ablation in that point, and also make the ablation of this part that is doing well. Huh? It's not so bad. I believe the response has been very good, but we need to make a second radiofrequency, plastic stent now, and imagen endoscópica en grande. And then gallbladder prophylactic drainage. We already published that in gastrointestinal endoscopy. A few months after the group from Italy and in a multicenter study, they show it. So they show it as the same results. So we are discovering a lot of new things that we didn't knew before, and the risk of cholecystitis when the cystic duct is compromised is in around 40%, at least in our study. So it's high. Okay. Okay, perfect. So now
In about how much time?
So now I am putting the radio frequency probe, you can see here. So you have two areas that perform the frequency in between them and perform the necrosis and the destruction of the tumor because of the frequency of the radio frequency. So I am using the StarMet radio frequency, and I am using a duodenoscope from Pentax Medical. So I will start my radio frequency in this area because I measure just at the level of the spine in this level. I remember that I saw that my cholangioscope was there. So I will start here. So I will start to put 10 watts, 2 minutes in a temperature of 75 degrees. So now I am putting, the impedance is increasing, is trying to maintain the watts. I don't know if you want that I show by the cell phone how it works, the machine. It would be nice for the
Carlos,
assistant. Yes.
This is the Elra device, is that right?
This is what?
Which device are you using for RFA right now?
Yes, I am using the StarMed device.
Okay.
Is this
I'm
one?
not familiar with it. So is this impedance gated?
Yes.
Okay. And yeah, maybe you can show us. Great.
So you can see, you put it count down, you doesn't have to do anything, and the impedance is doing everything. So the machine is doing everything, maintaining the temperature. So it's 2 minutes, and you have to go down, to make all the radio frequency, all the destruction of the whole tumoral lesion. And after that, when it finishes in 2 minutes, you will have a small song, like a beep that says to you that it's finished, and then you need to move down. So in that way, we will do the whole biliary tract. So if you want to change the room, that instead I finish the whole radio frequency, because what we see is that the image that you see of the X-ray, where you put the probe and then you go down and burn the whole tumor. So if you want to change the room, we are fine. So if not, we can stay here.
For the audience, this is very similar to the Taewung Elra device in terms of it being temperature and impedance gated, temperature controlled, impedance gated. It's a 2-minute cycle rather than the 90 seconds for the Habib, and you don't need any cool off. So there's some technical differences, but it looks very similar to what we have.
So and to clarify, Carlos, you brought up a point which was important, that you're not in the business of trying to, as a curative, this is a palliative treatment. And I wonder if you feel the palliation is more related to the ability for stent patency to be prolonged, because obviously there's not data on life expectancy prolongation here.
Yes,
this
that is,
alone.
yes, that's why I said this is a little bit outside the box, and this is a special protocol that we are doing here, just to evaluate if what is the best way to apply radio frequency in this kind of patients. And to be honest, we use radio frequency, and the results that has been published a lot in the literature with the Habib, and more than all with the Habib probes, it was that it didn't increase the survival when you make one ablation. Has been performing like that. But the thing is, if we think about the tumoral growth, how it goes, so this is why the results showing just making better patency for the stent, but we don't want just patency for the stent. We want that our patients be in a good, or at least in a very better conditions in terms of quality of life. It means do their things, try to make her own things, don't depend of going to the hospital all the time because of cholangitis and all the things. And the results until now, for me, the study, we make a retrospective evaluation in our unit, and what we saw it is with this kind of protocol, I don't believe that we increased the patency. We didn't have the same results that has been published. So that's why I believe there is something that is in the protocol that we need to change, because the technology is good, right? I don't know what the Ken or the members of the podium can say about that. Okay.
I mean, there's a growing amount of data now that in favor of what's called the abscopal effect of RFA. And I think that, is where we're thinking there's a translation to improve survival. So yes, it's become part of our protocol to perform RFA in the hopes that it will improve patient survival.
Yes. Yes.
And for that, you need to use plastic stents, though.
Yes.
I mean, do you ever place metal stents in these patients with cholangiocarcinoma?
No, now.
So that pretty much has gone by the wayside since we've started performing RFA routinely in all patients with cholangioCA.
Yes. Yes. Totally agree. I had my mentor that I always remember his words, Professor Bertrand Napoleon from France. He teach me a lot, and one of the things that he always said, he always treated with plastic stent the cholangiocarcinoma, and I never understood why. So at that moment, it was not radiofrequency available, but he made it, and I don't know why he have like a better response in terms of whatever things that he have to do it with the time. But for sure, there is something that we need to understand, and we don't know very well from cholangiocarcinoma. At the beginning, as you said, we use it a lot, and I use it a lot of metallic stents. But right now, we are not using more. We are using more plastic stents associated with radiofrequency because of the protocol, but just in palliative patients. In case of patients that need surgery, you need to send the patient directly to surgery, and not just waiting for other kind of treatment. So I believe it's a different approach, probably a different protocol, but I believe the results that we have until now, even the oncological hospital here, Khaled Solka, they send to us more and more because of the results. So we send the patients to them to make a chemotherapy, and it's something that is happening now. So I am very happy with that, because I believe the protocol that is trying to introduce now Dr. Juan Manuel Alcivar here with us, I believe is really interesting, and we need to see the results. So I will continue going down.
So Carlos, your plan here is so you did this 2-minute application, you waited a minute or so, pulling the probe out. You're going to plan to replace with plastic stents?
Yes, I will put just one plastic stents, because the bifurcation is fine, so it's not take it. So one plastic stent is enough, and then I will come back to drain the gallbladder, because the cystic duct is completely take it.
And what type of plastic stent are you going to place? Double pigtail or straight, and then
straight?
Maybe it's a straight stent?
Yes, yes. The double pigtail, it depends. I always use a strategy. I don't, put like just because I believe on that, or there are certain cases that we need a double pigtail or whatever, because of the risk of migration and things like that. In this kind of cases, the risk of migration is less. And second, nowadays we have cholangioscopy, so I need to come back and to review how the patient is doing. So I'm going down a little bit more. and and if the stent, going inside, so we can use the cholangoscope and we can use the basket to recover it, or and we can remove it. So there's not more big like a limitation or contraindication. I use more the double pigtail in the pancreas, for example, or just a single pigtail, or when I am doing a hepaticogastrostomy for benign disease. But it depends on the experience of the. Okay, so I
I
believe.
agree with you, Carlos. I also use straight stents, not only because if it migrates upstream, it's easier to remove, but also I like to exchange over the wire. So I'll cannulate, because these patients come back every 4 months for a stent exchange. Remember, the rationale for a metal stent, a SAMS, was that these patients would have longer patency and they wouldn't have to come back for frequent stent exchanges. But in fact, since we're doing RFA now intentionally, frequently, every 4 months, it's very quick to exchange through a straight stent, pass the wire, pull the stent out, leaving the wire in place and putting, doing the RFA and putting a new stent.
Okay, so I wait a little bit there because I needed. Yes, Ken, I totally agree with you, but I I I believe it's sometimes the ideas are great and the protocols are fantastic, but sometimes there are some things that we can mistake sometimes. But you know, so now I was waiting because I needed that the temperature diminish, because if not, you will broke your working channel. So this is very important. You need to wait that the temperature came until 40 or 39 degrees Celsius. So in that way, the probe will not destroy uh, uh, your scope. So now I will pass just the cholangoscope. I want to make a second look to see if how we made this ablation. And once we are inside, I will just look faster, and then I will pass a plastic stent.
Carlos, do you always do cholangioscopy after RFA?
Well, yes. Yes, to be honest, yes. Yes. It's not a formal indication, but I believe when we are doing a mucosectomy, when you are doing a ESD, whatever kind of treatment that you are doing, you always see with your scope. If I am correct, right? We want to see, we want to evaluate if we applied fine, and what was the power of the ablation. If I believe this is very important, even when you are doing radiofrequency for the barrel esophagus. We always try to look. So now
Carlos, has it been an excellent demonstration? And you're putting the stent in? Is that right?
Yes.
Oh, you're doing cholangioscopy again. Okay, I'm sorry. I was busy.
I'm doing the second look. You see here, we destroy the whole tumor. You see?
We can't.
Oh, we know we can't see the cholangioscopy view.
Okay.
Yeah.
Colangioscopía en grande, por favor.
Oh, got it. Okay, this is good. Okay.
So I like to see it. Second, I have to make a documentation of this because this is very important. You see, I burned very well here, this part. You see, this was a new area of cholangiocarcinoma appearing. So now I am happy with my ablation. You can see here. Very good ablation. AI is not detecting anything, which is good. So I'm happy. And now I will put the plastic stent. Okay.
That's a good point. I thought you turned the AI off, but it was on, huh?
No, it was on.
Good demonstration. Thank you so much, Carlos. We may be back with you and we'll communicate separately. Thank you so much.
All right, we've got another colonoscopy coming up. This is a patient with initials VL, a 73-year-old female with prior PE on rivaroxaban, left adrenalectomy in April of this year, positive Cologuard, and imaging demonstrating a right iliac nodal mass and a right presacral mass who underwent lower EUS and colonoscopy in June of this year. On EUS, there was a heterogeneous mass in the pericolonic space measuring 4 by 3.9, status post FNB, and 1 abnormal lymph node status post FNB. Cytology revealed intestinal epithelium with low-grade dysplasia. On colonoscopy, there were numerous polyps that were not resected. They were larger, 4 were larger than 15 millimeters. There was a large pedunculated fungating non-obstructing mass, 1/3 circumferential, measuring approximately 6 centimeters in length. The mass was biopsied and a tattoo was placed 2 centimeters upstream on the contralateral wall. Path revealed a TVA with high-grade dysplasia. A PET performed in July revealed concentric thickening of the proximal transverse colon with hypermetabolic activity, a 4.9 centimeter soft tissue density in the posterior pelvic fat with hypermetabolic activity. There was a soft tissue density posterior to the left kidney with hypermetabolic activity that may represent a malignant lymph node. And here's some representative pictures of the large mass. So the plan is colonoscopy with en-bloc endoscopic mucosal resection, given the features of advanced dysplasia.
So Doug, we can see you, you're live, and I just wanted to add something additional. The surgeons had wanted to go in and remove the pelvic mass. They thought if we can remove the colonic polyps that it might save her surgery on the colon. I did do EUS sampling of what they thought was a malignant node, and that was the same type of tissue. It wasn't malignant, same type of tissue in the node as it was in the pelvic mass. So EUS sampling was done of those areas. Doug, what do you think of this lesion? Can you hear us?
Yes, I
Okay.
can hear you, and this is impressive. So the biopsy showed high-grade dysplasia, and looking over the surface of the polyp, first of all, it does have a pedunculated element to it. Like right there, that's part of a pedicle. I think that there are parts of it. Could you guys put a little bit of epinephrine in the injection fluid for me? Maybe, like if you have 1 to 10,000, maybe a half an ml.
Doing EUS, right?
Yeah, if you can maybe at least mini probe or something.
So, trying to get this out en bloc, I think would probably require ESD. We can try it with a snare, but it's going to be difficult. I mean, this is a very, very large polyp, and maybe it should be called semi-pedunculated. You can see this part right here. In the left colon, if there was more of a clear stalk, because see down here it's extending onto the wall.
It's laterally spreading.
It's got at least a sessile or a flat component to it right there. And but I mean, looking at it, when I looked at the pictures, I have to tell you, it was so ratty looking. I really thought that it was cancer. And looking at it now, I can't say that it's overtly cancer. It's certainly bulky, and as I was talking about this morning, anytime you have a very bulky lesion, it's quite difficult to predict from the surface features that that it's benign, whether it's benign or malignant. And we've got high-grade dysplasia just on biopsy, so I think that's a little bit concerning. So I think we'll fill the colon with water here if we can.
Some additional background is, the surgeon asked me to do a colonoscopy for a positive Cologuard. Oh, just while you're in there doing the EUS, do a quick colonoscopy for this. So part of the reason why some of the polyps, obviously not this one, but some of the polyps weren't removed. So I think it would be interesting to know, is it resectable? Can you do it endoscopically? But if it's not, then also if there are other polyps that can be removed that may limit the amount of colonic resection potentially. I don't know what experts
I
think
hear you.
about that.
We passed some pedunculated polyps on the way in, so those could potentially, potentially be removed. And I'm asking myself now if we should consider
trying to do this underwater.
Yeah.
Or at least part of it underwater.
I agree. I think our best chance at getting a clean resection is trying to do this underwater at this time. For the fellows in the room, when these polyps get this huge, you end up encountering quite a bit of fibrosis, and that's just that polyp pulling into the lumen and just causing really a lot of inflammation within the base of the colon wall. So you can get into these scenarios where you're dealing with a mess on your hand when you start
I get a
resecting these.
33 millimeter.
Yeah, so I was just about to say this is those cases you're really tempted to go for your 33 millimeter, your 3 centimeter snares. And every time we pull one of those out, at least in my institution, I start getting my heart rate up a little bit. But sometimes you have to try to see what works for each individual polyp.
Well, I don't know. I'm a little concerned that with the 33, that what'll happen is that we're going to end up cutting across this and debulking it.
Mm-hmm.
I will say that sometimes when you inject a lesion like this, that the flat part of it that's against the wall, as you resect that, you actually can then do a conventional EMR, kind of across the lesion. This thing is awfully big to get a 33 millimeter snare around. I'm not sure that this is going to work. I think it's kind of worthwhile trying.
We have confidence in you, Doug.
Part of me thinks, for example, I don't very often change the patient's position, but we could change the patient's position, see if this thing would hang in another direction, and then go into the flat part of it on the rectal side of it and start to, move into a kind of a conventional EMR. And now in the left colon, sometimes what I'll do in this situation is to inject, even 1 to 10,000 epi into the stalk of the lesion. This thing is massive. Opening all the way. And then, waiting 10 or 15 minutes. And occasionally that will cause some shrinkage. I think there's a chance this is benign, and I don't really want to cut across it, but let's see what if we can get in position here with this thing. Now, right there's a portion of the polyp that is on the stalk. I'm bending over like I think that's going to help me see under it. Let's close the snare here and see what happens. And I want you to tell me, do you feel like you have a massive amount of tissue there? A huge amount. Okay. Can we switch the cautery source over to forced? I'm going to try to cut through this with forced coag.
It won't be on block because you see on the left side, there's still some residual there that wasn't captured. And then you can also look at the color change after you strangulate with the snare.
Okay, Ken wants me to, do you want me to reopen and try
Well,
that?
yeah, you can because you kind of bunched it together a bit now.
Open.
And now you can reopen and see if you can get that left side a little bit, into the left edge of the snare.
Keeping the snare down.
Yeah, what Dr. Binmuller was referring to is
swivel.
that violaceous appearance of the polyp that can come up and when you're strangulating all of the polyp.
And then I sort of jiggle, to kind of get it to displace more into the snare.
Okay. Let's.
And you may need to trim some of the laterally spreading parts, but that's okay. That's not the part that's concerning. The part that's concerning is this 1S, almost, 1P.
Yeah. Well, Ken, I'm going to go with this. I actually would sort of agree with you. I'm not that concerned about trying to get a perfect on block resection here. I think it's going to be very hard to do that because of the very flat part of the polyp. We've got is it any less tissue than we had before? Okay, now let's go ahead and hook up our cautery. And all right, so let's see what happens here. Yeah. So we got some burn in, and now you can start to, you know, slowly come through. I'm just kind of watching the snare. It's moving now. It actually went through that thing. I can't believe it. And I'm wildly grateful.
That's awesome.
So now you can place your snare again and get the next piece. Just
Yeah.
Wow.
if you want.
Big piece.
I do
You,
want.
you
Ken.
got
I
the big
appreciate
bulk
the
of it
coaching,
there.
but I do want. Now we're getting a
Oh,
little
man.
bleeding going on here, but okay,
Yeah.
let's go ahead and open the snare.
Yeah, that's why you have to be quick to get that snare open and then
Open again. Go and pop it open.
press it down flat. And then, yeah, and then torque, get it in the right plane and then close it. Beautiful.
That's great.
Okay.
Yeah.
I think that I'm at close again, if you would. Thank you. Okay. I have actually a little bit of trouble with looping. This colon is remarkably redundant. Are you ready? Okay, that was very quick. Okay. And there's just this tendency to loop here is quite remarkable. So let's go back with gas for a second and see what our status is here. But
Yeah, think of this as a large particle biopsy because, you know, the path will show you whether it's invasive or not.
now, Ken, since we piecemealed it, would you burn up the edges? I know we don't have really like a trial of doing that with
Yeah.
underwater EMR, but as a
So I
principle,
don't, only because I use near focus always, and underwater I see the edges so beautifully that I'll trim it until I'm confident that I have normal mucosa that I can see. So I don't do the burning of the edges, you know, a la Michael Burke, the Sydney group, but I would definitely trim until you have clear margins.
yeah, I think I'm in a transverse colon here. Let's go ahead and take the snare out for a second. Maybe we can suction this out a little bit faster.
Is this an adult colonoscope?
Yes, it is.
And so do you have the near focus too?
Yeah.
I do.
It's a Q, yeah.
I think probably because we're in the transverse and she's in the left lateral decubitus position, we're able to put a really big volume of fluid in there. I think we've got a little bit left over here.
Yeah, what I always
All right,
hate is
now.
that air-water interface, right? When you're trying to put the gas in now to see, and you've got that, all that artifact from the interface.
Right.
So you just have to be patient and suck out the water, and there's still residual there, it looks like.
Yep, quite a bit.
Well, Doug, we're gonna, first of all, this was fantastic so far. I know there's more work to be done. We're gonna quickly switch over to a case presentation and we'll be back with you for sure.
Sure.
Okay.
Let's go to a smaller snare. I don't think we need the 30.
So this is going to be a rectal ESD, patient initials KR, a 68-year-old who underwent a colonoscopy due to a positive FIT test and was found to have a 5-centimeter rectal polyp 10 centimeters from the anal verge. The mass was partially circumferential, involving 1/3 of the lumen. No family history of colorectal cancer. Superficial path showed a TVA. Evaluated locally by general surgery and then referred for ESD. Interval CT showed a rectal mass measuring 2.8 by 1.7 centimeters. And here's some representative pictures with clips.
Oh, hey, Professor Messman, Dr. Bilal, we see you. Can you hear us?
Yeah, I can hear you. Can you
Okay,
hear me as
wonderful.
well? Okay, great. Yeah, you see the lesion. Meanwhile, the clips are no longer here in place, but you see there is some tattooing, which makes sometimes any kind of resection difficult. So In general, I would say the lesion, as described, is 3 centimeters, and in the middle, bulky mixed type lesion. Usually for inspection, I use also underwater and a cap. With underwater, you have a kind of magnification, and you can nicely see the floating. And then here with the TXI mode, yeah, I don't think there is any deep submucosal infiltration, but sometimes in these bulky areas you cannot exclude. So I think in principle this is a good candidate for a ESD. No?
And Dr. Messman and I were talking about this before. There's always a debate whether EMR or ESD for these lesions. You know, in the rectum, ESD is preferred when they're so large because of the risk of covert malignancy that you can't detect. And obviously, Dr. Messman here is a world expert in optical diagnosis, but a lot of us in the West are still developing those skills. So ESD allows the chance to patient for the curative resection, and also rectal surgeries are much more morbid as compared to colonic surgeries. So that is why our preference is for ESD. Dr. Messman, is that your approach as well in the rectum?
Absolutely. So it does not matter whether it's a malignant lesion or benign lesion. All lesions in my unit larger than 3 centimeters are resected, are blocked by ESD. And this is for sure, although my unit, a typical lesion for ESD. And today I want to show you 2 different knives, the hook knife, which is my favorite knife, but also the dual knife. I mentioned yesterday during the postgraduate course that Professor Yahagi is in my unit, and he is teaching us in underwater pressure ESD technique, because then you have a nice lifting. The problem sometimes for lesions for ESD is that you have not a good approach to the submucosa, not a nice lifting. Therefore, in this situation, look at the gravity. Though this is also very important, you have the water at the 6 o'clock position. So for the moment, I wouldn't go for an underwater technique, and I would go straight forward to start with my ESD. Can I have the hook knife, please? Usually, rectal lesions or colon lesions need not to be marked. My chart here of lesions are marked in the esophagus. Barrett is sometimes very tricky, although gastric lesions, and then in the duodenum and in the colon, usually many people don't use it. I honestly, I like it. Makes life a bit easier. So therefore, we start now with marking the lesion.
I like to mark too. I would love to hear Dr. Pohl, Heike Pohl's opinion on this EMR ESD works in the rectum as well.
Yeah, I think we have learned over the past few years with the studies what constitute a high-risk lesion by size and also appearance. So nodular appearance or non-granular and larger size are all risk factors. And yeah, I think EST seems to be the right approach here. In terms of marking, it seems to be helping for you to later understand exactly where the margin is when you do your ESD, and also have like a clear, healthy margin of the resection.
Well, this was kind of a cheating question because Dr. Pohl has sort of mentored me on this approach. So. And Dr. Messman, while we're marking this, what is your approach? Are you going to use traction? Do you use traction or not every case? How do you approach that?
In this case, retroflexion was a bit difficult, so I think, and indeed, I think it's not necessary. So I think we can start with the gravity. I show you in a minute when we start with injection.
Well, this is unfortunate because now you've taken away what it used to be one of my favorite EMRs, was rectal EMR. It's below the peritoneal reflection and even one less procedure. I think I need to retire earlier.
No, Raj, we'll find some work for you to do. When we have a complication, we still need you. So.
Here is the tattoo. I hope it's not below the lesion. Yeah.
I honestly think that might be some serosa that we're glistening off of, but
Here we go now.
But this looks, I mean, you're opposing the tissue fine. I think this is gonna.
Helmet, we're going to briefly go to Dr. Rex's room, and we'll come back
Yeah.
to you in a moment.
Yeah. Yeah.
So to room 16, please.
Okay.
Hey, Doug, we're back with you. Can you hear us?
Yeah, we can hear you.
Okay.
So I'm going to show you just to the right here. I'm interested in what you guys think. We have looked. Will you just shut the clip for? Don't fire it. I want to get in and look at the defect, but you can see
yeah.
right in there. We're thinking that that's perforated, and that's the side of the lesion that we took off with the first big bite.
Yeah.
Open. We're not 100% sure, but it
That went through
looks
so
like it.
quickly, too.
And that's what
Right?
we were commenting on, yeah.
Yeah, the first
So we
defect.
were just talking about, I think something that happens, I don't know if there's invasion here, but when there is invasion, I think sometimes, go ahead and fire the clip. I think sometimes the invasive component will force the snare deep into the submucosa and into the muscle. And because I know when I have gone after sort of sessile lesions that you're not really sure whether it's a good idea in the right colon open, that invasion creates a greater risk. And this goes straight up and down. Now,
What's your CO2 at, Doug? Did you turn it down?
It's high, but we have virtually no, abdominal distension at all.
Great.
First position, fire.
Did you give a dose of antibiotics?
We have not, but yeah, you can give us, maybe get us some Zosyn. Is that what you like?
We can do Unison. We have that in the
Unison,
unit.
3 grams.
Unison here. Yep. Okay, so we'll give 3 grams of Unison.
No allergies or anything? Okay, yeah. 3
So
grams.
I guess this kind of kills my original comment that when you're using forced coagulation current, you're more likely to open to feel the muscle when you go through it. But
And you believe this is with that first resection that went so quickly?
fire. Yes, because it's on the right side of the defect. We did go ahead and finish the resection. But the injury, the muscle injury, the perforation, I will say it's a little bit weird looking. We were talking about maybe we were looking at the serosa, and she is not. Can I feel her belly once?
It feels great.
Her belly is perfectly soft.
Yeah, it's
now
great.
the other thing is, if we perforate into the mesentery, then we have a lot less problem, obviously, than if we perforate into the peritoneal cavity. I'm going to push the fragment away here.
This is just an excellent example for the audience about early recognition, completing, you're not faulted to not complete the resection. Of course, we have a international expert here, completing the resection, addressing the adverse event, suspected adverse event here with clips.
Once we get under the polyp, then we'll reopen the clip. So we're going to go under the polyp right there. And now we're going to reopen the clip. First position there. And now let me get a look at it. When you're closing a that's a good clip. Let's fire that. When you're closing a perforation, I think you should put the clips just really immediately adjacent to each other. And Ken, I want to have your comment. I appear to have perforated the colon during an underwater EMR. What are your comments?
Well, so I think this is invasive cancer. That was my impression from the beginning. In my unit, we have a forward view echo endoscope. I would have passed it and looked at it with EUS. You can use a mini probe as well. But I would have already been very concerned about this being invasive cancer. And so that risk of perforation is higher. But having said that, we can close these perforations so well now with the assortment of clips that we have. And you're demonstrating so beautifully how you can do that. And I think once you have robust closure like this, patient will be just fine. So the only issue here when you have a perforation is whether there's some residual neoplastic tissue that you haven't resected. But it looks like your margins look pretty clean. So I would say if the pathology turns out not to be invasive cancer, then we're good. Then obviously, if it's invasive cancer, well, then you're looking at surgery anyway.
And fire.
So I'm not surprised. I mean, this one, you have to be ready to deal with perforation. In other words, you have your clips on hand when you do this. And I usually can see the perforation right away underwater, and the margins, by virtue of the contracted lumen, the margins approximate on their own, and it's pretty easy to close these perforations then.
Yeah, open. Have you had, I have also had a previous perforation underwater. I didn't really have any water type, contamination. I'm going to go in between these two here. But have you seen or heard of that where we get water in the peritoneal cavity?
Well, maybe some will go in, and once again, it's about the pressure differential that we discussed earlier in the esophagus. So if you're then afterwards pushing in gas, well, then you're going to push water into the peritoneal cavity. But yeah, I think antibiotics are. I've never had to send a patient to surgery because of an abscess or anything like that forming.
Yeah.
We're gonna
Well,
switch.
I do think the margins are clear. I think our clip closure is good. And so obviously we'll be getting a CT scan to see the status of things. Open.
And why get that CT? How is that going to change anything?
We could just follow on clinically, really,
Would
right?
you feel, let's say that you did a CT and you don't see any water, and let's say we don't even see free air. Wouldn't that make help us in deciding, like, close for a second, like how long we're going to have this patient in the hospital, and what kind of trouble we're likely to get in? Open.
I think it's strictly clinical, how the patient's doing after. If the patient has a lot of pain, then obviously you're going to keep the patient for pain management and monitoring.
Keep them on an IV antibiotic.
But I don't think a CT adds anything.
First position. Yeah. Okay, Ken.
We're gonna.
Fire.
Doug, this is.
I want the CT.
I think what's really important here is that we recognized the perforation immediately, and that we didn't find this out the next day. That's where your outcomes are going to be the best.
Yeah, immediate recognition. Thank you so much, Doug. It's an excellent demonstration. We may or may not be back with you, but this is a really good case. Thank you.
Yep. Thank you. I guess. Thank you.
Helmut, we're back with you in 15. Can you hear us okay?
Little in.
Oh,
yeah,
wonderful.
Can you guys hear us?
Yes, we can.
Okay, so we are started with the incision.
Yeah, I show you.
Yeah.
So I show you. This is my gravity here. So I started here at this level, and I make now here my first incision. Not too deep, because otherwise you cut the vessels. Yeah, here's some vessels which can be coagulated then in a second step. But for now, I think if you can hold here, we inject now. This is the jet function. So I show you. It's a bit weak. Can you increase the flush? It's the highest. Okay. Now you can see it has a nice lifting now. And now we continue with dissection, knife out, the hook out, yes. And now turn the hook knife to the 12 o'clock position.
So you're thinking of doing a pocket or tunnel technique right now as compared to circumferential, right?
I will see how the
Okay.
gravity will help me, but for the moment, I think we have a nice approach here to the submucosa. You see here is some muscle fibers, so you be careful here. Here is a vessel. Cut it carefully. And this is the advantage of the hook knife. It's really very safe. You can hook and then very safe cut. Then the challenge is for the nurse or for the assistant. Can you turn it to 11 o'clock now? It's now 1 o'clock. So this is sometimes a bit time consuming because he has to turn. This is not necessary here. This out, needle out. No, you see. Now it's in the 6 o'clock position. This is definitely the biggest disadvantage. It's so time consuming. So it's more or less to 11. It's, yeah, but we try it in this position.
No, you're fine.
Professor Messman, as you're working on this, which is just excellent, by the way, we're going to switch over to Ecuador for just a couple minutes before a case presentation, and we'll come back to you. Thank you.
Yeah.
We have Ecuador, Carlos
Hi.
on the line.
So can you
You're
hear me
showing
now?
us something. Yeah, we see it really well now. Thank you for waiting.
Okay, first, I wanted to show you how the evolution of US assisted cholangiography has been changed a lot of things that we work in now. So I can see now that after injection of contrast in the gallbladder, it shows me that there is no communication with the common bile duct. You see? So my suspicion that I saw by cholangioscopy that the cystic duct was already taken, so it showed this. So now I am with the Axios. In this kind of cases, I want to show the biggest en grande la ecografía primero, la imagen ecográfica. So I want to show you my US because la imagen ecográfica primero en grande. Ecografía en grande. So you can see here, so there is a big thickness of the wall. So there is a chronic cholecystitis here. So that's why the pain of the patient now. So that's why we need to, make a drainage of the gallbladder that will relieve a lot. So now I'm using, as I already mentioned, thank you, Kenneth, for this for us. This is the hot Axios. I always try to use it because we have this particularity that I believe is one of the biggest thing of this. When you have some kind of patient like this one, when I have some risk because I cannot see very well by you, as you can see, I cannot see very well. So it's better because I can go guided by my guide wire. Even when you have ascites, there is not that is not the limitation, to be honest. So now I will pass my Axios here.
Carlos, can I ask a quick question? What about, because there's a stone right there against the wall. What about injecting with an FNA needle and filling that gallbladder a little bit more so you have...
That is what I did. You see?
Ah, okay.
Look.
Okay.
I did it. So I did it because I wanted to see if there is a communication or not with the cystic duct. So I confirmed that there is a cholecystitis now because of the stone, but also because of the obstruction of the cystic duct. So now I will deliver my Axios. It's a little bit tricky position, and I am trying to do my best. I made it guide wire. That's why I put the needle at the beginning.
What size Axios is this?
This is a 10 by 10. The flange is not open well, so I am trying to move a little bit.
The stone is in the way.
Yeah, I know. It's tricky sometimes, but I believe I am in, to be honest, and I believe it is open.
over? Why is he over?
Yes, I believe it's open. Podemos girar un poco
It might be
la
partly in the
fluoroscopy.
wall.
Yes,
huh?
I believe we are fine now. So I will start to open the other part. You see? I can bring it, so it's okay. I'm
I see.
okay.
Yes. Yes.
We are
Very
inside,
nice.
yes.
Wow. Okay. Not much room to
Now,
pull back though.
yes. And
Yeah.
now I deliver it inside my working channel because I love to do it. It's easier.
Yeah.
And you
It's
can
good.
see it, the axios, la imagen endoscópica, por favor. So now the axios is open, which is okay. So I need to remove this. Okay, perfect.
It's okay. Yeah. We'll
Okay,
we'll
perfect.
wait. We'll wait.
Perfect. Now it's raining. Okay.
Ah, look at that. Some pus.
Okay, perfect.
That
So
is
I will
fantastic, Carlos.
Thank
Thank you
you so
so much.
much.
No double pigtail in there, right?
No,
Yeah.
because it's
Thank you so much, Carlos. Thanks for
Thank you
joining
so
us
much.
today.
Thank you so much.
Congratulations. We're gonna go to a case presentation. He made that look really easy, by the way.
He did. It's not. This is an ERCP patient initials, 81-year-old female with metastatic pancreatic cancer with lung and lymph node mets, ongoing biliary obstruction with a bilirubin of 2.1, ALK phos 513, elevated AST and ALT as of a couple weeks ago, as of last week. EUS in March showed adenocarcinoma in the body of the pancreas. A CT just last week showed persistent but mildly increased dilation of the bile ducts with abrupt termination at the pancreatic head and the common bile duct. At the common bile duct measured 1.6 centimeters. Redemonstration of the pancreatic neck body mass measuring 2.4 by 1.8, which was compared to 2.6 by 1.7 on the prior CT. And here you can see the dilated bile duct and distended gallbladder.
And then, Dr. Knoll, Colin, we're with you today, this morning. And just a programming note update. I know it says lunch at noon. Now that I mentioned it, you're gonna get really hungry, but I know you don't look hungry right now. You look excited. We're just gonna delay it a little bit. We're gonna go with Dr. Knoll here for a moment, and then also the lecture, and then we'll do lunch right after that. Okay, Colin, thank you.
Oh, fantastic. Welcome back, everyone. Same team has been sort of in the rooms all morning, so big welcome to everyone here. And please ask any questions as you want as we go through. So just prior to this, we've actually just been discussing stent selection in the setting of pancreatic cancer. But before we get there, again, for the trainees, just to go over the basics, is the cannulation. And probably one of the important things is not to get too excited and rush once you get to the pillar and you've anchored your scope. It's very important to become comfortable in this position, and we chatted again about it yesterday in the hands-on. Any type of interventional endoscopy is making sure that you have a stable scope and that you are able to use your right hand without sort of needing to worry about your scope stability. Generally speaking, looking at the papilla, you want to approach the papilla from underneath it. You don't want to be on top like this because unfortunately you're then going to go into the posterior wall regardless how much you sort of tense your sphincterotomy. So you really want to be underneath it. If you're looking at the screen and using it at a clock face, I like to have the papilla coming out at sort of more or less on the left upper quadrant, 11 o'clock position. And that's because of the natural angle of my sphincterotomy. I think everyone's aware of the anatomy and sort of more or less in what direction the pancreatic duct and the distal CBD is running. Keep in mind when you've got pancreatic cancer or any type of mass there that this can be altered. So slow down, get your scope into the right position, and then take a second or not. You can even bring your papilla a little bit closer. Take a second or two just to have a look at the orifice, because again you might have two openings with a parallel channel, or you might have a common channel. So over here one can really see one opening, and then your cannulation's really about trying to get that angle right. keeping in mind that the biliary duct is generally going to go off at the sort of 11, 12 o'clock position. It's going to run anterior, so you want your scope sort of, or your sphincter return flexed, and the pancreatic duct running in the 1 sort of 2, maybe up to 3 o'clock position in a normal papilla, but we've got an underlying mass here, so it might be altered a little bit. The next is have your algorithm for a difficult papilla in place. If you struggle, have an idea as to, are you going to cannulate more than once? If you get the guide wire into the pancreatic duct, are you going to leave it there? Are you going to try use the double guide technique? Have your algorithmic approach. Same comes with conventional pre-cut. So either a conventional pre-cut sphincterotomy or your papillotomy coming from the top down. Have a look at your papilla and decide. Look at your scope position. What would be best? So again, in this position, you could almost do either of them. You can see quite nicely that one could do a papillotomy if one wanted to, but again, one could obviously do the conventional sphincterotomy. So for me, take a second when you're starting off, and then really, you know, the best time for your best chance is on your first attempt.
All right. So we're really waiting anxiously for you to tell us.
Yeah,
We're really waiting.
Okay.
If
So
you
here we
think,
go.
I hope it's not difficult, but we're ready for it.
Let's see.
So beautiful.
Yes.
Okay.
You guys can see he's engaging on what
Taylor
appeared to be
Swift's
the
song.
orifice of the biliary opening.
And you can see a bit of sphincter spasm there.
We don't have a fluoro view. If you can get a fluoro view for us, probably in the third panel there on the
I
right.
don't think I'm in there yet.
And sometimes we don't do fluoro until you feel a little bit of a give with the wire.
Exactly. So I haven't even got my wire in there yet. It is a short system, but I'm pretty
Very
sure
nice position.
if I had to put my wire in now, you'll see
Oh
there
yeah, look at
going
that.
through.
Let's see. We do need fluoro though. Before we
And
go too
if you'd have a
far,
look
it's coming.
there,
There we
I think
are.
I'm in the
In fact, if you want to spotlight fluoro now, please.
let's
The
tense
right
up a little
pedal.
bit.
He wants you to hit the right pedal.
The right pedal. Okay, let's just quickly, so just tense up a little bit there. I just want to see, because my guess is that might be pancreatic duct, but let's have a look. So we're going to fluoro. We're going to go down a little bit.
Can we lower? Yeah, if you could lower the fluoro a bit toward, there we go. And then if you can zoom up one and then spotlight the fluoro,
I'm just
please.
going to stop there. Okay. So as I thought, that's actually the pancreatic duct. So if you can see there, you can.
The right pedal. The right pedal.
Right pedal. There we go. So do you see that up to the corner of the right of the sort of main?
Yes, we
pancreatic
see
duct?
it's going toward the PD. Will you keep it there and then do an advanced technique now, or what do you think?
So my personal preference is I try again with pull back, and I try one more time. If for the second time I go into the PD, I leave it there. And that's really because sort of more than one guide wire cannulation of the PD has been shown to increase the risk of pancreatitis. One generally doesn't seem to have much of a risk. So I'm going to come back out. Now that I know more or less where the direction of my PD is, I'm going to try change it a little bit. I'm going to try come more, if you can tense up a little bit. Okay, I'm just coming back up, trying to change my angle a little bit. And probably still, there we go, let's try there. So I haven't actually come out because I think it's a common channel. And again, you can see that.
And I think what a lot of you can appreciate is you know, Colin's doing a very patient job here of trying different approaches with you know, maintaining the position and maintaining a angle of approach. And so, you know, those are two really important things when it comes to cannulation. And he's not really repeating his movements twice, right?
Yeah.
He's found his way to the PD, and now he's found another way. And if something's not going the way he wants, he's changing it up one movement at a time, not several movements together. I think it's really key important for the fellows out there to just really appreciate how it's being changed one at a time here.
Okay, so let's see. So this is, so I was expecting that to be a better position there, but obviously not. So I'm just going to come down. I'm still not going to come out. Now I've really changed the angulation, and I'm going to try go put more to the 10 o'clock position. And again, we know that she's got a malignancy, and I'm just going to screen now. No, So that's gone. Okay, so there we go. So now I've struggled, so now I'm going to come out. And if I go into the PD now, I'm going to leave my guide wire there. Okay, so
And
obviously
then would
filter
you do
that.
double wire, or do you think you'd go to transpancreatic septotomy since there's a pancreatic obstruction? What's your algorithm typically?
So I'd probably, before I go to septotomy, it depends if I get the guide wire in now, I'd go to a pre-cut. Because this, if you look at this papilla, it is conducive to a pre-cut. I think that would be relatively safe. But, it is individualized. I'm going to try once more. Let's tense up. Not too much, just down a little bit. There we go. That's lovely.
And we talked about this a little bit yesterday in the fellows course about when you have a malignant obstruction to the bile duct. Typically, it tends to push that bile duct more towards the 1 o'clock position as opposed to the 11 o'clock position that we're used to. Colin's doing a meticulous job, really, of just investigating where the bile duct should be and then steadily counterclockwise in his outside control and either rotating his wrist clockwise or turning his shoulders clockwise in order to change up that angle slowly to straighten the angle into the biliary
Let's
duct.
get a pre-cut if we can.
Yeah.
Okay, so we're going to go to pre-cut. Do you have a needle now? Yeah. No wire. We'll go back. Okay.
You want any glucagon?
We can, if you've got. Yeah, that would be fantastic.
yeah,
So glucagon, obviously, yeah, perfect. Relaxing the sphincter for us, which is fantastic. You can actually see drainage there, which is a bit frustrating, so we're obviously very close.
Yeah.
But just not where we should be. And so I move very, again, this is preference. I move very quickly to an alternative technique. I don't like to cause a lot of edema because the more edema I cause there, the more difficult it's going to become. I try not to repeat the same motion more than once, and I have explored it as best as I feel I can. So we're going to go to a pre-cut, and as mentioned, the pre-cut, you've got either a fistulotomy, which is from the sort of the apex down towards the orifice, or you go from this orifice up. So we're taking a bit of time and everyone's waiting for lunch, so apologies for that. Okay, needle out. I often don't take the needle in the entirety out. Okay, and over
And then
here,
your approach is, yeah, please explain
go for
your
it.
thought.
Okay, needle out. Go for it, Raj. What?
It looks like he's
He was
going to
just asking
start
what your
unroofing
approach
of the
was.
common channel.
Yeah. And that tends to be, I think, the more common approach. Fistulotomy is certainly is the other option. And obviously, Colin's really skilled and comfortable with both. That being said, in this case, I think it sets up nicely for the unroofing technique as he's just waiting for this contraction to slow down a little bit.
Yeah, we just got a bit of
They can pull up some glucagon for you too.
Yeah.
Yes. They're
I think
just
we're doing it at the
administering it as we speak. So
Oh,
as it
okay.
kicks in, we should be good. Yeah.
What do you usually dose? A 1/4 milligram, or what do you typically do?
I tend to do a 0.5 milligram at a time, and so I think that usually tends to be enough. Yeah, yeah. And so she's giving it as we speak, and as soon as these contractions stop, perhaps this intestine is as hungry as some of the intestines in the audience.
We're gonna, could we go over, I know I didn't give you a heads up proximity, but can we go over to room 15 for just a moment? They're making some significant progress here. Dr. Messman, we're back with you, and we'll just be here for a minute to just show us where you are now. We can see you. I don't know if you can hear us. Okay, got it. All right, sorry, they don't have headsets here, but we can show that this is why you should not backseat drive. That's what I just did right now. But okay, so then there'll be no audio coming out of this room, but you can see some really good progress that is being made on the lesion. And now we're going to go back to room 14 with Dr. Knoll. Okay, Colin, we're back. We can't hear you though.
Raj? I don't think they can hear us.
Oh, yeah, we can hear you. Sorry. Yep.
Okay, wonderful. Okay,
Okay,
so
needle out.
we're prepped and ready for you.
Okay. So I mean, this is really needs to be as controlled as you can. I try to look for the mucosas once
Copy
I'm
that. Sorry
there,
about that.
and you know, try not to surprise yourself with too much of a movement.
Nice. So for the audience here, he's showing unroofing of the common channel going up toward that 11, 12 o'clock position, and he's not trying to get too much of that tissue. He's just trying to increase exposure, may or may not see bile flow, and typically you just go layer to layer until you start seeing the transition between pink and white. Typically, you see a biliary orifice, some bile flowing potentially. Sometimes a PD stent in place can be helpful. And usually we'll use an endocut setting. 1, 2, 3 is a very common one, or 1, 3, 1. And now getting more into fistulotomy. He's using a technique from top to bottom. I tend to go primarily from bottom to top to try and avoid any chance of pancreatic orifice involvement. But obviously there are many different techniques here that can be
Actually
used.
using a combination of both, trying to open it up just to see. You know, the pancreatic duct is probably sitting somewhere down here, so hopefully trying to stay away from that. And just trying to open it up layer by layer, as Raj was saying.
Need to go to lecture.
Still don't have bowel flow, which was expected. It's a big mass that we saw on CT. And I'm really trying to look for some sort of biliary epithelium. The other option, if you go straight into it, is you're going to see straight away bile duct or sort of bile flowing back. So I'm going to go a little bit deeper. And over here, I can start seeing what it looks like, potentially biliary epithelium starting over here. That's a little bit deeper than expected. You should see it start. So if you're right there, I think that's sort of more or less where the biliary epithelium is going. Okay. So let's look. Still having a bile flow, which is... I'm going to open up this area here. So you can see I'm trying to be as gentle as I can, cutting one layer, really not try to create too much of a tract. And if I have to cross over, but it looks like there might be my biliary epithelium over there, although I'm not getting fluid sort of bile back. But that sort of pinkish tissue there to me looks like what do you think?
I think it's very nice exposure. And sometimes what I'll do then is switch over to the sphincterotoman wire and probe that area between that white and pink, I think. Is that what you're thinking?
Exactly. And you can see, I think this is the epithelium over here.
Yeah, maybe a little more there. Yeah.
So this
I don't
is
know
the
what
sort of
anyone
area
else
here.
thinks.
You can also probe directly with the needle
With the
knife,
tone,
that's
yeah.
triple lumen. But I agree, I think it's right there.
So there
Looks like a little bit of bile came from there.
You can almost see like a sense of
There you go.
biliary kind of bulge there coming in. Are you
So
going to switch
hopefully what I'm-
devices? Yeah.
We're gonna
So
switch
what we're
devices.
gonna we're gonna go to lecture here, Colin. First of all, I want to tell you that is such a smooth needle knife. You're now the nurses are going to expect us to be better after this. We're gonna unfortunately we're gonna have to go to lecture, and then we're gonna go to lunch. Not unfortunately, you know what I mean, Ken.
Yeah.
And so we'll go to lecture now.
Well, yes, it is unfortunate because I know everyone's stomach is grumbling and you're hungry, but it's such an honor to pay tribute. Yes, please.
Okay, sorry. No, I wanted to introduce this lecture, and you know, Ken has been a friend for our course from the very beginning, and personally knew young Chen, who recruited me here quite a while ago, and founded this course. Passed away too early in 2010, and I think his legacy has been related to education, innovation in endoscopy specifically. he developed the interventional section here at the University of Colorado at a time when there really wasn't that concept of having a dedicated team of interventional nurses and technicians, physicians that are focused on specifically interventional endoscopy. We now take all of that for granted, but it was really a novel concept when he moved here in 1999. So Ken is agreed to speak on innovation in endoscopy, challenging existing dogmas, and it's a real pleasure, Ken, to have you here today.
Thank you, Raj. What an honor it truly is to give this memorial lecture, and I have many, many fond memories of Yang. In fact, our relationship, our friendship started before he came to Colorado. He was at Loma Linda. I was in Hamburg, Germany. We communicated frequently, and we both were passionate about all of the innovative possibilities in interventional endoscopy, and especially around the time, this is at the turn of the millennium, there were just so many parallel developments that were just absolutely exciting. We had EUS guided therapy, we had treatment of GERD, we had capsule endoscopy, we had the ability to suture. I mean, just so many exciting new areas were burgeoning. And so Yang and I, we just loved to talk about all the future possibilities. And he did ask me about moving to Colorado, and I encouraged that. And I'm so happy that I did. He invited me to the very first Rocky Mountain Interventional Endoscopy course. This is in 2003. And you can see, Raj, you were part of that as well. I think you had just joined the faculty back then. And this was the beginning of Yang's vision and to integrate innovation into this course. And that's truly what we're seeing at this course. Steve Jobs said, 2005, this was at the commencement address at Stanford University, "Don't be trapped by dogma, which is living with the results of other people's thinking." That's what dogma is. Dogma is just a belief. It's other people's thinking. And it's important to always challenge dogma. And we've been doing that in interventional endoscopy all along. In fact, if you think about it, endoscopy itself challenged the dogma that the only way that you can see the GI tract is with radiography. So we have to think outside the dogma. So this is an existing dogma when I was a fellow, that endoscopic visualization of the entire small bowel is impossible. So I sent my patients for a small bowel follow-through if I wanted to investigate the small bowel. Well, we know that that dogma was challenged with capsule endoscopy and later with deep enteroscopy using double balloon, later single balloon, and Spirus. Another dogma that also dominated when I was a fellow was that cholangiopancreatoscopy is impractical. Yes, we had been doing cholangiopancreatoscopy using the mother-baby scope system, but it wasn't practical. It had only two-way tip deflection. The scopes were very fragile. Sometimes we could use it only one time. So it was clearly not something that could disseminate into the community. So we relied solely on fluoroscopy. And as we've seen today, this has been strongly challenged by direct single operator cholangioscopy. And it was no other than Yang who challenged that dogma. And he, together working with Boston Scientific to develop the spyglass, he started the way that all innovation should progress. It started with benchtop simulator work. This was back in 2007. You can see this benchtop simulator that was created to first test this preclinically, and then to move on to clinical studies, feasibility studies. This was in 35 patients, and 63% of whom had strictures, and there was a 95% biopsy yield. And then Yang contacted me and asked me to be part of a multi-center trial. This was 15 centers, and this is really what gave us reimbursement for this procedure, that we could demonstrate not just the feasibility, but how this really impacts outcomes. So this was this seminal paper evaluating the impact of single operator cholangioscopy in patients requiring evaluation of biliary strictures and stones. So another existing dogma that existed when I was a fellow, but has continued to prevail and still dominates, I would say, is that submucosal injection is required for EMR. When we insufflate with gas, we distend and thin the wall, and this flattens our lesion. So to counter that effect, we inject submucosally, and the concept here, the rationale, is that we facilitate lesion capture, we reduce the risk of transmural burn, and we reduce the risk of perforation. So this is the rationale for submucosal injection. And here you can see from Michael Burke himself an example of how this lesion is first injected submucosally to raise it up for subsequent resection. Now, this dogma subsequently became ingrained in our guidelines. This is from 2015. A solution is injected into the submucosa to lift the lesion for easier removal to facilitate the procedure. That's the assumption here. And to help protect the deeper layers of the bowel wall from mechanical or electrocautery damage. And this dogma also became ingrained in definitions. Here in Japan, where of course EMR was pioneered, the JGES, their society, defines EMR as normal saline solution or a sodium hyaluronic solution, they like to use that, is locally injected into the submucosa. That's a requirement for the definition of EMR. And this dogma has become ingrained in social media. So if you ask AI, how is an endoscopic mucosal resection of colon polyps performed? This is the answer that you'll get. It's performed by first lifting the lesion away from the bowel wall with a fluid injection and then using a wire loop to cut them off. And then you'll see diagrams like this showing how submucosal injection is done prior to EMR. And this even has medical legal implications, because then you'll read this on the internet. If the doctor was to remove a large polyp without first creating this safety zone, then there is a significant risk of making a hole in the bowel perforation. So clearly, this should be the standard of care of how EMR is performed. And yet there was never any proof that submucosal injection reduced the risk of EMR. We really have only this animal study with 6 swine. And if you read the title is not saying that submucosal injection does reduce the risk of iatrogenic thermal injury. In fact, the results were mixed. When they used the heater probe and APC, there was a benefit to submucosal injection. But when they used the hot biopsy forceps or the gold probe, there wasn't. It was non-significant. Now, the heater probe is perhaps not surprising that maybe there would be some benefit. I'm surprised that APC actually showed that there was some benefit, because we're taught, the dogma there, that APC prevents deeper thermal injury. And it's almost an ironic twist that the very group that has been the strongest advocate of submucosal injection before EMR is the same group that described the target sign as an endoscopic marker for the resection of the muscularis proprius, or a complication of EMR. So first, after describing this, they came up with a Sydney classification of deep mural injury. And in this paper, there was a 10% risk of deep mural injury and MP injury in 3%, with these pictures showing, initially at least, a very nice lift after submucosal injection, but then here you see the target sign. In our practice, submucosal injection may make EMR more difficult. Now, you didn't see this morning. What Doug showed you was so beautiful. So I'm not saying that it always makes things more difficult. It definitely facilitated his procedure today. But what we do experience is that there may be paradoxical flattening after we inject because the fluid disperses very easily in the spongy connective tissue of the submucosa. And there is increased tissue tension and slippage. So let's watch this video here of this large 25 millimeter lesion after chromoscopy, now the submucosal injection. Doesn't look like I can fast forward on this. All right. And so now we're placing our snare. And what this illustrates is how actually the fluid that we injected has dispersed into the surrounding submucosa, and it's actually resulted in a paradoxical flattening, even sometimes excavation of the lesion, making it more difficult to capture the lesion. So the snare tends to skive off, it slips off. And it also increases that tissue tension that contributes to the slippage. So here you can see we inject more and we keep getting the continued snare slippage. So really we're just sort of skiving off the surface. We're not getting a deep capture of the tissue. And then there are other potential drawbacks to submucosal injection. It distorts and narrows the lumen, it displaces the lesion, and it can result in bleeding, which in turn will trigger peristalsis. Misguided submucosal injection may increase the risk of EMR because we have a moving target usually with some peristalsis, right? So if we inject into that layer between the circular and the longitudinal MP, we may raise the circular MP, which is the thicker part of the MP, and capture that, and that may result in perforation. If we inject outside the serosa, this can result in local peritonitis and even infection. And maybe this is really what the post-polypectomy syndrome is about, not just the transmural burn. If we inject through the lesion, and this has always been a concern of mine, is it possible that we're seeding dysplastic cells into the deeper wall layers or even outside of the gastrointestinal wall? We know that seeding is a known risk of FNA. With hepatocellular carcinoma, we have a 2.7% risk of tumor seeding after FNA. With cholangiocarcinoma, 83% risk of peritoneal mets after positive FNA versus only 8% without FNA, which is why for liver transplantation, FNA is strongly discouraged for cholangiocarcinoma. That's just with aspiration. So if we're injecting, could we not be increasing that risk of disbursement? I discovered really on a routine procedure where I was staging a polyp to look for deeper wall invasion using a mini probe, where I discovered that the mucosa and the submucosa involute and this muscularis propria stays round on the outside like a frame, and it doesn't follow those involutions. So UEMR is essentially a floating EMR. We're allowing the mucosa and the submucosa to float up into the snare. When we insufflate gas, we're distending the wall, we're thinning it out, we're flattening that lesion. As you can see here, it looks like a 2A. And when we submerge in water or saline, that's when it floats up and it looks like a 1S. And why does the submucosa float? It's because the submucosa contains fat. We sometimes don't appreciate that after submucosal injection because we disperse that fat. The radiologists call this the black halo sign. And that's the third layer that we see on EUS, that bright echogenic layer. So now we have, and we're very privileged to have Helmut Messmann with us, who conducted this seminal piece, the landmark paper, randomized controlled trial that demonstrated that for large polyps, 20 to 40 millimeters in size, sessile or flat, that UEMR was significantly superior to conventional EMR with injection for en bloc resection rates, for R0 resection rates, for recurrence rates, especially when greater than 3 centimeters, quite a dramatic difference, and significantly shorter procedure time. And we've also seen this validated in 7 randomized controlled trials in a meta-analysis. These are randomized controlled trials, almost 1,500 patients, showing that the en bloc resection rate is significantly superior using the UEMR technique, as well as a significantly lower post-recurrence rate. And then at the same time, I discovered that there was another existing dogma, and that is you need gas insufflation to see. See, we just assumed we need to put gas in there to see the lumen. But in fact, I discovered that underwater, we get multiple optical enhancements, the magnification effect, the light scatter is reduced, so we get sharper images, no light reflection artifact, as you can see here with gas versus water, no fogging, no smoke, no char. But most importantly, we get this 3D floating effect shown very beautifully here with gas. This lesion is flattened, but here you can see the real villus architecture floating up into view. This is really scuba diving inside of the colon. And we have multiple now randomized controlled trials, this meta-analysis, 17 randomized controlled trials, over 10,000 patients, also demonstrating that the ADR is significantly better, higher, when using the water exchange method. That's how I do all my colonoscopies now. Also that it is better for patient comfort. So challenging existing dogmas. Well, here I am with my good friend Albert, and Albert said, if you always do what you always did, you always get what you always got. And that is why we're so grateful to have Yang's legacy living on at this course. And I'm sure he's smiling down on us right now, seeing this beautiful morning session that we had. His dream is being fulfilled at this course. And I thank you, Raj, you're his successor. And you have done what an amazing job. And I had the privilege to meet you back in 2003 at the very first course. So congratulations, Raj. Thank you. Wow.
For 1 minute, we're going to go to room 15, please. Professor Messman, Dr. Bilal, you're on. We're going to just show this for 2 minutes, and then we're going to lunch.
Can you hear us, Raj?
We can hear you. I think the mic,
Dr. Messman, you want to?
we can kind of hear you. Yeah, we can hear you.
Okay, yeah. So the plan was now to make a pocket and finally a tunnel here. You see the distal part is here, and I made a tunnel, and from the proximal part, so you see we come from here, we go into the pocket, and now we have here completed the tunnel. That means we have a nice lifting on this side still, yeah, here. And now I'm approaching the other side, and then I will cut the upper level, and then I think due to the gravity we can cut the other part of the lesion. This is the plan. Here is a deeper muscle injury. There was a severe bleeding. We will clip it later on, but I think it shouldn't be a problem. No? And I'm still working with the hook knife, so it's easy to catch here the tissue, and then you can easily cut the submucosa in this line and continue step by step. You can also nice inject, needle in, please. So and out.
It's a beautiful demonstration of the pocket technique. checking on this if you have to go to lunch. If you have any questions, otherwise.
Yeah, I hope after lunch we are ready here and could finish in the next 15 minutes or so. That would be my plan. So here is still some mucosa left.
This is the deep mucosa for the fellows in the audience that we're trimming right now.
Yeah.
For the mucosal incision.
For the tunnel, it's better to have here a deeper incision. In?
Can you hear us, Raj, or?
No. They are hungry. They left us. Yeah. Okay, out.
Is he going to be putting the brow stent in?
Helmut, can you say something about completing the circumferential incision first or doing? Because I don't think you completed in the beginning.
Yeah, it depends sometimes on the size. For small lesion, I start with a complete circumferential incision. For larger, it makes sense to start at the distal part and then at the opposite side, and then creating a tunnel or a pocket, and then the lateral margins. Okay.
And then it seems like you leave some tissue bridges there, tunneling, but can you say something about how you approach
exactly.
this?
Yeah, yeah.
Okay, well, thank you for this. We'll check back with you. We're going to break for lunch for 45 minutes. We'll see everybody back at 1:45. Thank you so much, Professor Messman. We hope to see you back and see the final if it's just an image. Thank you so much. Excellent demonstration.